occur. But till now, what used to happen is most of the women, they used to think that this is normal. And they used to lead this with this suffering. So they never used to come out with this problem to any of the doctor. When we purposefully ask them, do you have these problems? They tell, this is fine, sir. My mother has told that this is normal. So they start living with that problem. But eventually what has happened over the years, many of the women, they are all office going women. In them, any of the urinary problem or any of the pelvic floor disorders is a concern. So definitely nowadays, many of the women, they come to the doctor to seek the help for this problem. So this has changed. And nowadays, many of the women, they want to be well-being, not just by externally, but by internally also. Because the urinary problem is one which causes a social stigma. And the inner confidence comes down. So for all these problems, the women do come with these problems to you, and it's my request for all of you to identify these problems, and if you are able to treat them, or else you can refer them to the urogynecologist for the betterment of the health of the woman. So, can I have a mic? So, to start with, see, I spoke to Dr. Kausar. I was telling her, initially I will start with the prolapse and its problems, how to manage the prolapse. In the second half, I am going to talk on the urinary problems. Because when we have to understand the prolapse, we have to know about the anatomy of the pelvis. So we will go ahead with like that. Can I have a mic? We all were quadruped. That means we used to walk on the four limbs. So during that time, during the ancestral period, the genital structures were not under direct influence of the gravitational force, because it used to rest on the pelvis. And the pelvis was horizontal. But as the evolution has set in, the quadruped has become bipedal. That means we started walking on the two limbs. The pelvis, which was horizontal, got tilted vertically. So the genital structures now directly are under the effect of the gravitational force. And this is the penalty what we are paying. The prolapse and the dystocia. Dystocia is abnormal labor. These two are the penalties what the human beings are paying for becoming bipedal from quadrupedal. Isn't it? You don't see usually the dystocia in any other animal. During the animal childbirth, none of the animals will have any dystocia. Only in the human beings we find the difficult labor. That is also because of this evolution. So prolapse is also one of the penalty. So when I say that, we can imagine that all the women should get prolapse. No, that is not. Because as the evolution happened, simultaneously there were corrections which were happening in the pelvic structure. The supports of the uterus which were there earlier weak, now they have become very strong in order to hold the uterus in its normal position. So today I am going to talk on the anatomy and the genital structures and the supports of the genital structures and why they are so important in managing it. So one of the important, the supporting structure is the levatrine muscle. Levatrine muscle, we also call it as the pelvic floor muscle. It has got three parts, the pivococcygis, iliococcygis and ischiococcygis. This will be the sheet of muscle which will prevent the genital structures from coming down. So this is a voluntary, that is a striated muscle which will be always in contraction, especially when we sneeze or cough, there will be a reflex contraction of this levatrine muscle. So they will close the genital hiatus, they will close the urethra and they will close the anal sphincter. Another important aspect of the lever trana is that it takes part in the formation of the external anal sphincter. External anal sphincter. Why I am telling this is, during the delivery of the woman, whenever there is a normal childbirth, the lever trana muscle will get damaged. Simultaneously, there will be damage to the external anal sphincter as well. This is more common when we do it when we give episiotomic suture or when there is extension of episiotomic suture. Suppose the episiotomic suture is extended to external anal sphincter. The lever trana muscle, which forms the part of external anal sphincter, is also damaged. That we have to identify and rectify so that our continence is maintained. So, the puborectalis, the idiopathitis, and the another one is the ischiopathicus. These three are the part of the lever trana muscle. And in the supports of the genital structures, there are three dimensions. One is the muscular support, which I told. The another one is the ligamentous support. The another one is, third one is bony pelvis. All these three act in tandem in order to give good support to the genital structure. So this is the other dimension of the lever trana muscle. You can make up that the puborectalis muscle also has got a puborectalis muscle. PRM stands for puborectalis muscle. It forms the external anal sphincter. And all these muscles will be laterally attached to the pelvis, to the ilium, so that it gives proper support. You can see that the upper two-thirds of the vagina will be resting on this lever trana muscle. So it acts as a flap wall mechanism. Whenever a woman coughs or sneezes, the horizontal portion of the upper two-thirds of the vagina is compressed. Thereby, the uterus is prevented from coming down. If the uterus is coming down, what do we call that condition? Prolapse. So this mechanism, that is flap wall mechanism, will prevent the genital structures from coming down. That is, the prolapse is prevented. The another mechanism is, earlier I was telling you, the constrictive mechanism of the puborectalis muscle. The puborectalis will be like a U-shaped structure, within which there will be the urethra, the vagina, and the anal canal. Whenever the lever trana muscle contracts, all these sphincters will be squeezed and it will be like a sphincteric action. So this is nothing but the constrictive mechanism of the puborectalis muscle. That is the muscular support for the genital structure. It is provided by puborectalis muscle, lever trana muscle, which is nothing but the pelvic floor muscle. Now we will go to the endopelvic fascia. This endopelvic connective tissue of endopelvic connective tissue is nothing but the collagen fibers. Which will be organized in a specific way. Suppose if it is organized in a sheet, we call it as fascia. Suppose if it is like a rope, we call it as ligament. Both these fascia and ligaments are very important for the support. So there are various types of fascia. One is parietal fascia. In that there is obturator fascia. The specialized form of obturator fascia is arcus tendinous fascia lever trana. Just you remember this because in the subsequent slides this plays a very important role. The another one is lever trana fascia, also called as arcus tendinous fascia pelvis. Okay. The other fascias are visceral fascia. Visceral means inside. Inside the visceral fascia forms the pubocervical fascia. Pubocervical fascia or vesicovaginal fascia. As the name suggests, it is between the vesico, that is bladder, and vagina. Between the bladder and vagina, it will be a sheet of fascia. The another one is the rectovaginal fascia, that is between the rectum and the posterior wall of the vagina. The other things are the deep endopelvic connective tissue, or also called as the ligaments. I told you the connective tissue can form into a rope, that is ligaments. The examples of these are uterosacral ligament, which is very important, cardinal ligament, or also called as McEnroe's ligament. The another one is the pubourethral ligament. Okay. So in the subsequent slides, I will be telling you what are the importance of these things. So I was telling you during the evolution, as the genital structure were under the tremendous pressure for the gravitational force, simultaneously there will be modification. These are the modifications. These are the modifications because of which not all the women will have prolapse. So you can see this, the laterally this is the arcus tendinous fascia pelvis. Arcus tendinous fascia pelvis. And posteriorly we will have arcus tendinous levatrinae. These are nothing but the line of attachment. The fascia, that is pubocervical fascia and the rectovaginal septum, will be attaching laterally. It gives the lateral attachment. This is the one. So those two yellow lines are nothing but arcus tendinous fascia pelvis and arcus tendinus levatrinae, which forms the line of attachment for pubocervical fascia and rectovaginal septum. Okay. This is how it will be attached. Okay. So here will be the pubocervical fascia and here will be the rectovaginal septum. So they will come and attach laterally. So that is the line of attachment. So what is the importance of lateral attachment? The lateral attachment is because the lateral sulcus in the anterior vagina, what we see is because of the lateral attachment. Suppose if the lateral attachment is disrupted or damaged, then you will see this. The sulcus coming down. The lateral sulcus which are normally formed, here you can see that. Lateral sulcus which are normally formed is absent. So that indicates the problem in the lateral attachment. Okay. So I am telling you what is the significance of each of the fascia and attachment, and clinically I am showing the photos which are there, so that when you clinically examine you will be able to identify. Understood? That is the arcus tendinous fascia pelvis and levatrinae. The another one is, next is another fascia is the pubocervical fascia. As I told, it is the sheath of bluish. The sheath is nothing but pubocervical fascia. See, on it there is the bladder, isn't it? So this supports the bladder, isn't it? If it is damaged, what will happen? The bladder will come down. If the bladder comes down, what we call the cystosis, isn't it? And you can also notice that the fascia, the sheath is attached laterally. That line is nothing but arcus tendinous fascia pelvis. Okay. So in pubocervical fascia, the sheath is also important and its lateral attachment is also important. Okay. The attachment, those things detail I will not go to it because unnecessarily you will get confused. है ना? ये क्या सर theory start कर दिए, इसका जरूरत नहीं है. So the another best way of understanding pubocervical fascia is comparing it with a trampoline. Trampoline is just a sheet where the children will fall on that and they jump. So for the trampoline to be effective, there are two things. One is the sheet has to be intact and it should be laterally attached. Suppose the rope which is laterally attached to this iron ring, if it is damaged, then it will not work. If the sheet is broken in the middle, it doesn't work. Similarly, the pubocervical fascia and rectovaginal septum to function, two things are important. It should be intact and it should be lateral attached. Okay. So So you can make out here, this is the bladder, yellow is the bladder, and this is the fascia. This is the fascia, and down is the anterior wall of the vagina. Okay? Now, whenever the bladder falls down, because trampoline like elastic, with equal force it is pushed up. On the trampoline sheet, when the child falls, with the equal force the child is pushed up. Like that, it is also pushed. So the cystocele won't happen, the bladder won't come down. This is the thing. See here, the centrally the sheet is defective. You can see the anterior vagina is coming down, and along with that the bladder is coming down. So we call it as simple. So I told you there are different varieties of the fascia damage. We will not go into detail. So this is the proximal, the higher up the fascia is detached. Understood? The fascia will be attached anteriorly to the pubic ramus and posteriorly to the cervix, laterally to the lateral wall of the pelvis. So here it is at the level of cervix it is detached. And one more very interesting thing I want to tell you, always the prolapse is because of the obstetric injury. Suppose if the woman has delivered twice or thrice, definitely she will have some the damage. That is the thing. Okay. So this is again anteriorly we spoke about the pubocervical fascia. This is the rectovaginal septum. Rectovaginal septum. Here you can see that this is the rectum. This is the posterior vagina. That red line on the left side is nothing but the rectovaginal septum. This also acts like a trampoline. If it is damaged, it causes the rectum coming down. What do we call that? Rectum. Simple. Next we will go to the three ligaments, that is the uterosacral ligament, cardinal ligament and pubo-urethral ligaments or pubocervical ligament. We call it as tri-radiate or fan-shaped structures. They spread in the different directions. As you can note down in this diagram, this is nothing but cervix. The cervix is held in position by these three ligaments. Posteriorly, the uterosacral ligament, laterally by the Mekenroth's ligament, anteriorly by the pubo-cervical ligament. Okay. So, and each of the names depends on what it is attached. Pubo-urethral means from the pubic bone to the cervical ligament. Uterosacral means from sacrum to the uterus. That is cervix, like that. And so this is the. And when it is attached to the cervix, it forms a pericervical ring. It forms a good support to the cervix so that the cervix doesn't come down. Suppose a woman is delivering, she is having pain, and the cervix is not completely dilated, cervix is incompletely dilated, about 7-8 centimeter, and somebody tells her, kilo. So, क्या होता है? So the ligaments will be stretched because cervix is not dilated. Along with the fetal head will push the cervix, which is not completely dilated. The cervix is pulled down, the ligaments are stretched. Then in between the breaks will happen. That's how the damage to the ligament. So what will be the result? Then she will be fine. But after 2-3 deliveries, the cervix will start coming down. She tells that something is coming down, isn't it? That is nothing but uterocervical prolapse, isn't it? So, in a overall, we understand the pelvic support in this D-axis concept of the uterovaginal support. There are 3 levels of support. One is the higher level 1 support, which supports the cervix and the upper portion of the vagina. That is nothing but this uterosacral, cardinal and pubocervical ligament. Okay. Second one is level 2 support, which is formed by the fascia sheath, that is pubocervical fascia and rectovaginal septum. Okay. Then the third one is the level 3 support. That is nothing but the pubo-urethral ligament and perineal body. Understood? Suppose if the pubo-urethral ligament is damaged, then the urethra comes down. Then whenever she coughs or sneezes, the urine will start. That we call it as stress urinary. So all these levels of support are very important because we have to understand where it is defective. Suppose I tell you the first level 1 support is damaged. But if we do the surgery for cystosine, is it going to? No. So we have to address the level 1 support. That is the introsectional cardinal level. So it will understand where is the defect and it will tell us what surgery we have to do in order to bring it to the normal. So there is, nowadays we have a new concept called as the site-specific repair. Earlier, all prolapse used to be considered one. They used to remove uterus, they used to repair it. But that is not the answer. Now site-specific repair is we have to identify which site it is defective and that site has to be repaired in order to give good outcome. So I was telling you, the muscular support, the fascia and ligaments, bony pelvis act in tandem in order to give good support. So all three are important. All three are important. And another in this, the prolapse juncture is the understanding the sacrospinous ligament. This is also very important. Sacrospinous ligament is a ligamentous structure. Here you can make out. This is the sacrum. This is the ischial spine. Ischial spine. There is a ligament. There is a ligament which is a very strong ligament. Why I am telling? We are plicating or fixing the vagina to the sacrospinous. We call it as sacrospinous fixation. Then the anatomical aspect is the obturator canal. Obturator canal is the pelvic bone. There is an aperture formed by inferior pubic ramus, then the ischial bone. So this canal we utilize it for the tape to bring it out. Tape. We call it as transobturator tape. Later I will show you transobturator tape. That is also. So for that reason I am showing this anatomy. Okay. Next you should know about the ureter, pelvic ureter. I am sure you will be having some idea. So after anatomy we will go to the prolapse. So prolapse is nothing but the descent of the pelvic structures from its normal anatomical position. So cervix is at the level of ischial spine. If it is coming down, it's abnormal. The bladder has to be higher up. If it is coming down, we call it as prolapse. So any structure, any pelvic structure which is coming down from its anatomical position, we call it as prolapse. So here we can diagrammatically show that the cervix is at normal place, whereas in this diagram the uterus and cervix is coming down. Along with that it is dragging the part of bladder also and rectum also. So we call it as the genital thallus or uterine thallus. Support I already told you, 3 levels of support. So anterior vaginal, if there is prolapse, there has to be 2 things. One is the bladder, another one is urethra, isn't it? So anatomy is very important. See here, there is bladder anteriorly and urethra. Posteriorly there is rectum and there is intestines. Okay? So likewise we have to understand. So anteriorly, so if there is upper 2/3 of the vagina which is coming down, then the bladder also comes down, then we call it as cystosine. Suppose if the lower part of the anterior vagina is coming down, along with that the urethra is also coming down, then we call it as urethrocyst. Then there can be both the cystocele as well as urethrocoele, then we call it as combined, that is cystourethrocoele. That is the anterior aspect. Coming to the posterior aspect. Okay, so what could be the cause for anterior vaginal wall prolapse? That is the weakness in the supports of the bladder neck, and the uretrovesical junction will be coming down, and even the proximal urethra will be coming down. Why it happens? That is because of the weakness of the pubocervical fascia and pubourethral ligaments, isn't it? So this is the diagrammatic representation of the cystocele. You can make out that the anterior vagina, along with that the bladder is also coming down. So that is the cystocele. Here you can see that only the urethra and the anterior vagina is coming down. We call it as urethrocoele. Sometimes there can be only isolated urethrocoele. There need not be cystocele all the time. So it's like that. So it depends on the type of the obstetric injury which has happened. Suppose while extension of the fetal head, if there is any damage, then that would cause the urethral damage or pubourethral ligament leading to urethrocoele, like that. So in the middle compartment, we have pouch of Douglas. Pouch of Douglas, that is behind the cervix. So what does pouch of Douglas contains? It contains the intestines. So if the intestine is coming down along with the pouch of Douglas, we call it as enterocoele. Entero stands for intestine. Coming to the posterior. Posterior, as I said, it is nothing but it is having the rectum behind to that. So rectum, posterior vagina and rectum, if it is coming down, we call it as the rectocoele. And the another important aspect is perineal body. So this is rectocoele. Rectocoele. So you can see that along with that the rectum is also bulged. So that causes rectocoele. Sometimes there can be only the uterus and cervix coming down. We call it as isolated uterine descent. It doesn't have power. The prolapse is there. We have to quantify, we have to grade it, how much it is coming down. So you might be asking why it is necessary, isn't it? When there is prolapse, prolapse is there, that's all. But you have to tell to the patient severity. Suppose if there is first degree or minimal descent, you can tell her there are some exercise, either Kegel's exercise, isn't it? You can ask her to do those exercise so that there will be some improvement. Suppose if there is severe form of prolapse, then you cannot tell her that the Kegel's exercise will heal it. No, it cannot treat. So for that reason, we should know the degree of the prolapse. So in the degree of prolapse, there are 4 degrees. One is first degree. First degree is nothing but the uterus is coming just below from its normal anatomy, but above the introitus, whereas second degree is, it is coming up to the introitus, third degree is coming outside the introitus, fourth degree is the entire uterus is outside. We had a few days back, we had one case here, we did for precedentia. So it was precedentia means the complete uterus was coming down, like that. So first degree is coming down from its anatomical position but above the introitus. Second degree is up to the introitus. Third degree is outside the introitus. Fourth degree is whole of the uterus is outside the introitus. These are the different grades. So first degree, second degree, then the fourth degree, third degree. There is one more concept called as the vault prolapse. Vault is nothing but once the uterus is removed, after hysterectomy, once the uterus is removed, the apex, the higher portion of the vagina is left out. If that is coming down, we call it as vault prolapse. Okay. So this usually happens after hysterectomy. Suppose after hysterectomy we have not supported it properly. If we have not fixed it to the ligament properly, then the vault will come down, vault prolapse. So this is vault prolapse. Here you can see that the uterus is absent, only the vaginal vault is coming down. So another one is I said that these are the Shaw's classification, first degree, second degree, third degree and precedential. It's Shaw's classification. The another one is the POPQ system of analyzing the prolapse. This is also very important, POPQ. I will not go into detail, just you remember the POPQ. So, what are the causes for prolapse? As I said, the erect posture leading to the direct action of the gravitational force on this one, and the acute and chronic trauma to the vaginal delivery. If the vaginal delivery is not managed properly, or as such the vaginal delivery can cause the damage to the pelvic supporting structures. Then the third thing is aging. Most of the prolapse, they come in after menopause, isn't it? They tell that when we ask, was it before? It was a very milder form. It didn't have, I was not bothered, but after attaining menopause, it has aggravated. That is aging. Why aging? That is because of estrogen deprivation. Estrogen is important for maintaining the collagen fibers. Suppose after menopause the estrogen deprives, that is stops, then the collagen fibers will lose its the strength, then the prolapse will aggravate. Then sometimes we see in the young ladies, suppose if 18, 20 years, 25 years, in them only prolapse is seen. That is because of intrinsic collagen abnormalities like Ehlers-Danlos syndrome, Marfan syndrome. In those, the collagen fibers will be genetically defective. In such cases, though she has not married and not given birth, they will have prolapse. Then debilitation, weak lady or iatrogenic. Suppose nowadays the painless labor is common, isn't it? We do it under epidural anesthesia. In such cases, what happens, although the head is coming in the vagina, but she is not bearing down because she is not having the urge. What we will do, we will put forceps or vacuum, isn't it? When we do that, definitely we will pull. While pulling, definitely the damage will happen. That is iatrogenic, isn't it? Nowadays, the painless labor is common, epidural anesthesia. The other precipitating factors are increased abdominal pressure, then increased weight of the uterus, traction of the uterus by the vaginal prolapse, by the large cervical polyp. In cervical polyp also we can see obesity, smoking, pulmonary disease, constipation, recreation or occupational activities like labor workers. So, now we will go into what are the symptoms with which they come, isn't it? So, what are the usual common symptoms with which they come? Something is coming down, isn't it? When the uterus is coming down, they tell that something is coming down. That is the commonest symptom. So, whatever may be the symptoms, they will be because of two things. One is, as such, the uterus and vagina is coming down. Second thing, along with that, it is pulling down the bladder and rectum. So, the bladder function is also abnormal, the rectal function is also abnormal. So, the thing is, one is mechanical symptom is something is coming down or mass per vagina. Another one is urinary symptoms, rectal symptoms, isn't it? So, clinical presentation, in the initial stages there can be weakness in the perineum, but as it progresses it becomes mass per vagina. The urinary symptoms are urgency is every 1 hour, 2 hours she wants to void urine, and frequency of urine. That is every time 1 or 2 hours she wants to go. Urgency is when she gets the urge to pass urine, she cannot hold it. She has to pass. So what happens whenever a lady enters any function hall, first she looks into the toilet. Kidhar hai toilet? First I will get arranged with that, like that. That is urgency. Then is stress urinary incontinence. That is whenever there is urine leak on coughing or sneezing. And the third thing is inability to micturate. Suppose the prolapse is very severe, the urethra will be kinked. That will lead to the obstruction of urine. Whenever she strains, the kinking will aggravate. The bulge will aggravate, then the kinking will aggravate, there will be more obstruction, like that. Then the other things are because of the infection, frequency and cystitis. Cystitis is nothing but bladder infection. The rectal symptoms are like constipation. The other symptoms are backache. Because the uterosacral is pulled, there will be backache and the congestive dysmenorrhea. She may have the dysmenorrhea because of the pelvic congestion. And even the leukorrhea because of the gaping of the introitus. And there can be formation of ulcer on the cervix. That we call it as decubitus ulcer. You people are very perfect with the theory. So, I will just brief these slides. So, decubitus ulcer is nothing but because of the pelvic congestion. So, what all the things we require for diagnosing? Prolapse is just a clinical diagnosis. No special investigation is required. Only clinical examination, if we see, we will come to know. But what is important as a consultant, you people are consultant, as a consultant, what you have to look into is whether anterior vagina is coming down, posterior vagina is coming down, the cervix is coming down, and whether she has got stress urinary incontinence, isn't it? Those things are important because we have to identify a particular problem and then we have to rectify it. So examination, local examination, then per speculum examination in order to identify which is this one. Then the pervaginal examination. Sometimes what happens along with the prolapse, there can be ovarian cyst. Suppose if I do only the hysterectomy and pelvic floor repair, ovarian cyst will be remained. So we have to do bimanual examination in order to understand the adnexal pathology if it is anything. Okay, that is the thing. Then the fourth thing is Bonis test. This is very important, I am telling you. Because I told you in prolapse there can be stress urinary incontinence. But what happens? Because the anterior vagina is bulged and there is kinking of urethra, though she is having stress urinary incontinence, it is not seen. Suppose I do the surgery, I will finish off. Then she will come. सर आपने तो सर्जरी कर दिया, मुझे तो नया प्रॉब्लम आ गया, स्ट्रेस यूरिनरी इनकॉन्टिनेंस, ये क्या है? बट दैट वाज देयर अर्लियर, वी आर नॉट आइडेंटिफाइड. We call it as occult stress urinary incontinence. Occult means hidden. So that we should not miss. Bonis test is nothing but sponge holder. We have to hold it at the bladder neck, and we have to keep it at that position so that the cystocele which was coming down is supported. Then you ask her to cough. Then if there is any urine leak, stress urinary incontinence is there. That you should not miss as a consultant. Okay. So that we call it as Bonis test for occult stress urinary incontinence. Then evaluation of the tone of the pelvic floor muscles. I was telling you levatrine muscle. Levatrine muscles, we have to check the tone because there is one procedure called as the levatroplasty. Levatroplasty, that is additional plication of the levatrine muscle. Whether we require that or not, we will be able to see. And rectovaginal examination to see whether the rectocele is there, how much it is there. And how do we examine? Usually we examine the patient in dorsal lithotomy, but also you can ask them to, we can examine them asking the patient to stand or while straining. Okay. So evaluation of pelvic floor muscle, I was telling you, this is by the modified Oxford scoring, wherein in the score 0 is there is no contraction in the levator muscle. Score 1 is flicker of contraction. 2 is weak contraction. 3 is moderate contraction. 4th is good contraction. 5th is very strong contraction. So bladder evaluation. So I was telling you, basically the prolapse is nothing but just the post-void residue. Post-void residue. Normally when we ask the woman to pass urine and come, and when we do ultrasound examination, there should be hardly 50 ml of urine. That means the bladder is completely emptied. Suppose if it is more than that, there might be some other urinary bladder problem, like overactive bladder, like the urethral stricture. There could be some other problem which we might miss. So that has to be ruled out. Okay. The another one is presence or absence of bladder sensation. We should ask her whether she is able to feel the bladder fullness. That is also important, to know the neurological part is intact, isn't it? All these things are very important. Though we consider not so significant, but they play a major role. Ninth, why I am telling this is, after surgery they are definitely going to come and catch us. क्या सर आपने तो सर्जरी कर दिया, सर्जरी करने के टाइम पे ऐसा वैसा बोल दिया, अब तो हमें प्रॉब्लम हो रहा है ना, which we would have missed it. And the bonus test already I have told. Then the positive incontinence surgery. This is suppose if there is prolapse and there is stress urinary incontinence, then we have to combine both the procedures. Prolapse rectification and the stress urinary incontinence surgery for a good result. See, sometimes what happens, this may be boring for a longer duration. That's why I am giving some clinical scenario in between. And if you have any doubt, you be free to ask, and we can have an interactive session as well. Okay. And the another important aspect is anal integrity. I was telling you, when we have to look into the levator muscle, we have to look into the anal. Whether she has got anal incontinence. Suppose anal incontinence is there, we have to note down the tone of the anal sphincter. So prevention of prolapse. So in a way I should tell that 100% cesarean delivery, isn't it? हाँ, एक पेशेंट भी नहीं आएगी मेरे पास, सर टाटा बाय बाय. बाजू में एक और डॉक्टर है, वो बोल रहे हैं 100% वेजाइनल डिलीवरी, मैं उसके पास ही जाऊँ, isn't it? So in order to prevent the prolapse, we have to do 100% cesarean section. That is not possible, and it is not the acceptable form also. So usually damage do happen with the vaginal delivery, but we can reduce it by understanding the pelvic anatomy and conducting the delivery in a proper way, isn't it? So I was telling you, what are the measures we have to take? Avoid the premature bearing down. So what happens, the earlier we used to have the DICE, home delivery. They used to, once the pain starts, they used to tell kilo, kilo, kilo. They will stop telling kilo until the baby delivers. They will never stop it, isn't it? So that used to be scenario. But now, most of the deliveries are institutional deliveries. Now no more the home deliveries. In institutional deliveries, we know when we should ask them to bear down, and we will be frequently examining them. We will be doing the vaginal examination. We will be understanding the cervical dilatation. We have a beautiful partogram, isn't it, to understand the progress of the labor, which will help us. Then avoid a long second stage of labor. The head has come down in the vagina. And what happens if there is long second stage of labor? The vagina is expanded for a longer duration. What is the support which is for the vagina? The pubocervical fascia, rectovaginal fascia. It will get torn off. It will get torn off. Then she will land with cystocele and rectocele. So if there is more than 2 hours, do some instrumental deliveries to bring out the baby. Repair all tears and incisions accurately in layers, isn't it? That's also very important. We have to identify the apex of the episiotomy wound, and if there is cervical tear, we will identify and suture. Nowadays, all of us, we are doing it. Very important thing is, when we give episiotomy suture, I'll tell you, make it a point, you put one index finger in the anal canal and pull it up. Why this? Because you will come to know whether the external anal sphincter is damaged or not. I had put earlier one diagram where the external anus sphincter was shown. So in that diagram you will understand whether the anus sphincter is damaged or not. Because endoanal ultrasound is the other way of identifying, but it is not available. Even in medical colleges it's not available. So simple clinical is pull it up and see whether, if it is damaged, take the patient to the labor, the OT, give anesthesia, spinal anesthesia, proper anesthesia, good exposure, lighting is there, and patient won't be suffering from the pain, and she will be cooperative. So what happens in the most of these repairs, difficult episiotomy labors or difficult episiotomy repairs, the patient won't be cooperative. You ask her to lithotomy, she will not be able, because she will be suffering from 10-15 hours, she will be in pain. She will not cooperate. So when you give anesthesia and when you manage IV fluids, she will be cooperative. She will be conscious, she will be cooperative. That time, aram se you can do the repair, a proper work can be done. Otherwise, if you aim to do it in the labor room itself, it will not happen. It will not happen. The incomplete work will be done. So that should be taken care. The delivery of the placenta. So now we all manage with the modified the Band-Andrews method, isn't it? So we will not pull the placenta alone, we will push the uterus as well. And encourage pelvic floor exercise. This is another important thing. What happens, once delivery is done, all the concentration will go on the baby. Mother is forgotten completely, nutrition wise, the sleep wise, everything. Why the postpartum blues or depression happens is because of this thing. So everybody will shift the focus on the baby. Mother is left out. So that should not happen. You should ask the mother, you should counsel mother to do the pelvic floor, Kegel's exercise. Because the torn muscles which are there, it will regain its strength. And the minimal damage which has happened, it will get rectified. I'll tell you, post-delivery or postpartum Kegel's exercise is very important and highly neglected thing. So in your clinical practice, you make it a habit. And avoid puerperal constipation. Again, this is very important. Again, for the mother, they will be given specific diet. And mother-in-law will decide, I am going to give only this diet. Nothing else. Water, nothing. You have to be like that only. Not even a single drop of water will be given. So I usually tell to the patient, see, don't tell to your mother-in-law. Go to the kitchen silently, have your water and come. If you go on asking her what I want, what to should take, what to take, she will restrict you everything. So ek kaan se sunna hai, ek kaan se chodna hai. So that is the thing. So constipation is very important because again she will start straining. The damage which has happened, it will get aggravated. That is the thing. This I will come to later part. Physiotherapy, I told you. The Kegel's exercise, very important, Kegel's exercise. See, in Kegel's exercise, I will tell you very practical aspect. This is very important for you all, practitioners. See, most of the time when we tell Kegel's exercise, hardly the patient understands. Sir, आपने तो एक funky terminology use किया Kegel's exercise, but how do she understand, isn't it? So you have to explain to her, whenever you go to pass urine, that time you hold the urine. So you will understand what is pelvic floor muscle. See, suppose if I tell the biceps, I can make out. I can show it to her. This is the biceps. But pelvic floor muscle, can I show her? No, I can't, isn't it? So I should make her understand which is the pelvic floor muscle. So whenever she passes urine, whenever she stops it in between, that muscle is nothing but pelvic floor muscle. That has to be contracted. So initially we should ask her to do the Kegel's exercise only while voiding urine. Once she understands, she need not do only during voiding, but other time also. Isn't it? That is one. Second thing, in YouTube, if you see, there are beautiful pictures or the videos of the Kegels exercise, wherein the pelvis is tilted up or pulled up. So that also leads to pelvic floor muscle exercise. But you can ask her to type Kegels exercise in YouTube, you will get the videos, you can do that. So either of these two will help her, and this is very important because 50% of the problems is solved with that. Next, another thing is, if we send the patient to the physiotherapist, they will use the vaginal cones in order to rehabilitate the pelvic floor muscle. So that is the physiotherapeutic, the rehabilitation. So I was telling you the decubitus ulcer. Decubitus ulcer is nothing but ulcer on the cervix. As a practitioner, what you should know is the decubitus ulcer heals only if the uterus is pushed inside and tampon is put, because the coming down of the uterus is the cause for decubitus ulcer. You push it, keep one tampon, betadine tampon, and make her lie down for a longer duration so that the congestion will go off, the decubitus ulcer will heal. But another important aspect is, in the decubitus ulcer, you should also know, is it a normal decubitus ulcer or abnormal? Sometimes it could be vaginal cancer also. So suppose 1 week you have done this vaginal repositioning and tamponing, then also the ulcer is not healing. Then you have to take the biopsy from the edge of the ulcer, and then you have to send it for histopathology to note down. Okay. Some people, they put the acryflavine glycerin pack. This will absorb the water content from the prolapse, then it will assist in healing. Huh? This is the decubitus ulcer. The another important aspect is the pessaries. Pessaries. So pessaries are nothing but ring structure or cubical or cone shaped, anything which is placed in the vagina in order to prevent the prolapse from coming down. This is a temporary method, isn't it? It's a temporary, it's not a permanent, it's a temporary method. It can be chosen, suppose if the pregnant woman is having prolapse, for first 3 months you can put the pessary so that the prolapse will go away. Or suppose postpartum, after delivery, if the tissue damage is more, then the prolapse will happen. Till the tissue regains, you can put the pessary. Or else, sometimes what happens, the patient is too old, too elderly lady, she is not medically fit. What to do? You can put the pessary as a medical or non-surgical treatment. Sometimes what happens, patient herself refuses. I don't want surgery, sir. You tell me something else. So pessary is the answer. So these are the various types, Hodge pessaries, ring pessaries, isn't it? So this is the donut pessary. So these are the various pessaries, but in India, clinically we are available, we are having ring pessaries, isn't it? Commonly available. I am sure most of you would have used the ring pessaries. So this is the ring pessary. Can you see this? So the pessary is, one end of the pessary is put into the pouch of Douglas, the other end is brought behind the pubic symphysis. Here you can make out. So behind the pubic symphysis. It's a easy, not a great thing. Only thing is, before that you have to identify what is the size of the pessary. So put the hand till the pouch of Douglas, measure the distance, then deduct 2 centimeter. Deduct 2 centimeter, that is the size of the pessary. Okay. So ask the surgical person, he will give the pessary. You take 2-3 sizes. Then you put the pessary, make her void urine, make her walk around. She should be comfortable. See, otherwise what happens, if the pessary is loose, it may fall off. If it is very tight, it may cause urine retention. So it should be a proper size. You make her spend another 1 hour in the hospital, make her walk around, pass urine, she is comfortable. Then you send her, and once she is sent, again you call her once in 3 months to check whether the pessary is proper, and you can replace the pessaries. Because the pessary is a foreign object, it causes vaginal erosion. So long-standing vaginal pessaries, if left out, it may cause vaginal cancer, or it may burrow to even to the bladder. That should not happen. So that's why. Huh? So these things has to be taken precaution. Complications, as I said, if it is too tight, the constipation, urinary incontinence, vaginitis, cervicitis, carcinoma of the vaginal wall, impaction of the pessary, strangulation of the prolapsed uterus. Management, so if it is a minor degree and if a patient is not medically fit, you can either ask her to undergo the Kegel's exercise or the pessaries. If it is severe form, then the surgical management is required. So aims of the surgery is to restore the anatomy, isn't it? To send the uterus and cervix in its normal position, and pubocervical fascia, if it is cut, plication of the pubocervical fascia. Laterally, if it is detached, you have to attach it, isn't it? These are the things. So suppose the woman is a young lady, about 30, 40-year-old, and if she doesn't want to undergo hysterectomy, what we will do? We will do the conservative surgeries like sling operations. So should I go into detail of these? No need, isn't it? So we have various sling operations, Shirodkars, then Kannas and Purandares, isn't it? Another one is the Fothergill's operation. What flaps? So this is the Fothergill's operation. See here you can note down that the only the cervix and the uterus is coming down, whereas the cystocele is not there. Only the cervix has come down up to level introitus, isn't it? When I pull, the cervix is hypertrophied, and you can see the whole of the thing is the cervix. That is because of the bearing down before the complete dilatation. So I will measure the uterocervical length, how much portion of the cervix has to be cut. So here this operation is called as Fothergill's operation or Manchester operation, wherein the cervix has to be amputated and the ligaments which are weak, which has to be refixed. So infiltration is done in order to reduce the bleeding. So I am cutting the vagina. So first I will identify how much is the bladder. So I have to identify the extent of the bladder, then beneath that I will cut. So then the fascia, that is the fascia. White part is the fascia. Fascia is cut. Then the vagina is dissected. Once I cut the fascia, the bladder is pushed up. Then the remaining is only the cervix. Laterally we have the cardinal ligaments, that also has to be dissected. So this is the pouch of Douglas, posteriorly. Pouch of Douglas and rectum. So now I have opened the pouch of Douglas. Can you see that? So this lady was a 30-year-old woman. She was previous to normal deliveries, but 30-year-old, it's not good that we do the hysterectomy. The ovarian function will come down early itself. So, and even for womanhood, the conservation of uterus is very important. In Indian women, there is one psychology that unless she doesn't have a normal menstruation, she is not happy, whatever may be the thing, isn't it? So, the conserving of the uterus is very important. So, for that reason, I had to do this Manchester operation. So this is the lateral cardinal ligament, McEnroth's ligament. I have separated it. I will attach it to the anterior part of the cervix. All my videos are available in the YouTube. You can go through. Huh? So that is the McEnroth's ligament. See, so it has come down so much, isn't it? That much is the laxed ligaments, isn't it? Now we will do the curettage. Curettage is because after the surgery, if she has got menstruation, then it becomes a problem. That's why we curate the endometrium prior only. And I'll check the how much the uterocervical length, how much cervix has to be amputated, cut. Then I will use the cautery to cut it. So this much is the cervix which is coming down. So that will be cut. Then the ligaments are placed anteriorly so that the ligaments will take care of the prolapse this way. Do you have the surgical treatment also in Unani? Do you do cesarean? Doing. So now you can see that when I placate it, the ligament, it will pull back the cervix. Initially, this why we call it as Manchester operation is because it was first done in Manchester, UK, Manchester, and why we call Fothergill's is because he was the other person who came out with this the procedure. Earlier in 18th century, what used to happen in UK, all these surgeons, they used to go once in a year. They used to have like this conference. They used to display their surgeries. What has happened in that conference? Two people have come with the same procedure. Now we have to please both of them, no? So that's why both the names has been kept. One is Manchester from that person, and the another is Fothergill's. Yeah, it will be fine. It will be fine. Only thing is, suppose if she want to conceive, the external cervix, ectocervix is also important for fertility. That will be hampered. So in such cases, we do IUI. Natural conception, the capacitation of the sperms will happen in the cervix. That will be hampered here. That's all. Otherwise, the sexual function, everything will be fine. Because the physical barrier which was there in the cervix coming down, it is gone. So in fact, it will be useful for them. In fact, in this patient, the husband was reluctant because of these things, because of the sexual dysfunction. That's why she had approached us. Now the vagina which is there will be covered on the amputate cervix. Amputate cervix. You can make out the vagina. I am just bringing out into the cervical canal so that it covers the cervix, raw area of the cervix. Suppose if they are having secondary infertility, then we do the modified Manchester. We will remove the central portion of the cervix. The ectocervix is retained, the endocervix is retained, only the central portion is removed. Yeah. Nobody will take chance. Because after the vaginal delivery, again she will have prolapse. Means nowadays cesarean has become much safer, to be frank with you, isn't it? Than the difficult vaginal delivery. So then the cervix will move up. Then the cervix will move up. Then we do the posterior colporrhaphy. Posteriorly, that will give additional support. Additional support. Now you can see that the cervix is gone up. You can make out. Now the introitus is narrowed so that the gaping introitus has been reconstructed. Sometimes patient only come with gaping introitus, the lax vagina. For them these procedures are fine. The vaginal rejuvenation operation or vaginal tightening operation. So now you can make out that the cervix is gone up. Yes. So that is the thing. Thank you. So somebody is awake. The another one is the laparoscopic sacrocolpopexy. Here what we do is again, this also uterus, she doesn't want the uterus to be removed, but prolapse is there. So what we do is we fix the uterus to the sacrum through using a mesh. So we call it as sacrocolpopexy. Earlier we used to do open method, now laparoscopy we can do it, so we call it as laparoscopic sacrocolpopexy. So here the sacrum is, the peritoneum over the sacrum is identified and it is dissected. So it is dissected up to the uterosacral ligaments. That is the uterosacral ligament. Only thing is ureter will be very close. We have to see to that ureter is not damaged. Then the anteriorly the bladder is dissected away. Then the mesh is put. This is the mesh. So this is propylene mesh. So we place it around the cervix. So that anteriorly it will hold the anterior part of the cervix and posteriorly the posterior part of the cervix. We take a bite using the non-absorbable suture. Then we place it. So it is brought anteriorly. So we have to suture it so that the mesh will hold. Mesh will hold the this. Again posteriorly also the mesh is sutured. Then this is the sacrum. Mesh is tied to the sacrum. We have called as tackers. We fix the mesh to the with using the tackers. So tacker is nothing but a spring like. It will go inside the sacrum. It will hold the. You can see that. So now the mesh is holding the uterus. Can you see that? Then the peritoneum is closed. So mesh is covered. Otherwise, it will get adhered to the bowel. Bowel will stick to the mesh. So it has to be covered with the peritoneum. So now it is clear. Huh? Yeah, surgery means there will be something, isn't it? I cannot tell that 100% everything will be fine. And this is the patient in whom there was no vaginal atresia. For that, we do the vaginoplasty, reconstruction of the vagina. Vagina is not there. Uterus is also absent in this lady. She is 23 years now. So we utilize. This is the rudiment uterus. This is rudiment uterus. Only the small portion of the uterus is there. What we do is, earlier we used to open the vaginal canal, put the amnion graft or skin graft, but taking up of amnion graft is difficult. Again it used to close. So now we started utilizing the peritoneum. Peritoneum which is there in the abdomen is taken into vagina and put. So that is all peritoneum. So again, vaginally also we have to open that the closed vagina, that has to be done, but it's not there in the video. That is the ureter. Again, some more peritoneum and the anterior wall has to be taken. Now, this is the vaginal portion. Here from down I am dissecting so that the dilator which is kept in the vagina will be passed into the peritoneal cavity. I will cut it. Now the uterine sound is coming out. That is the uterine sound. So that is the vagina which is collapsed. Now I have to reconstruct. Now through that small hole I will be passing the peritoneum. So that is the valsalem forceps. The peritoneum is hurled and it is pulled down to reconstruct. This is the vaginal dissection. So that peritoneum up to perineum we will stitch it. So assistant will hold that peritoneum and bring out, they will stitch it. We have to ensure that the vagina is adequately dilated. So here again some more portion of the vagina is constructed with the peritoneum. So that is the, yeah. This is the mechal caldoplasty. After doing hysterectomy, what we do, we have to fix the vault. Otherwise, the vault prolapse will happen. So that's why we call it as the mechal caldoplasty. So here, uterosacral ligaments which are there, it will be approximated and closed with the vagina. so that the uterosacral ligament will support the vagina. So this is the peritoneum, posterior peritoneum. This is nothing but the uterosacral ligament, this one. Suture is passed through the vagina and passing it through the uterosacral ligament. Uterosacral ligament. Another 5-10 minutes, madam. We'll take break. So through the peritoneum. So then it is passed through the other uterosacral ligament. So when I close it, the apex will go up. You can see that. Now it has moved up. So that is called mechalcaldoplasty. So we have the sacrospinous fixation. I was telling you the vaginal vault is fixed to the sacrospinous ligament. I showed on the video. No, this is to detect the to fix the vault to the sacrospinous ligament. Here lateral pararectal space is dissected, and the suture is passed through the sacrospinous ligament. It's not an easy operation. It takes time, and it comes with little risk also. Now that is fixed to the vault. I am fixing it to the vaginal vault, so that when I tie it, the vaginal vault will go inside and fix it to the sacrospinous ligament. Now I am closing the vagina. Now I am fixing it. So now I am fixing it so that the vagina will move away, move up. That is the sacrospinous fixation. This can be done for 4th degree prolapse, procedentia, or 3rd degree prolapse. In fact, this also we had done here one case. And I want to show the pessary. Just 2 minutes, I'll just show the pessary insertion. Okay, in the next half I'll show that. If there are any doubts or any queries, please free to ask.
Said about vaginal folds.
Yeah. vaginal cones are nothing but the graded vaginal weight cones. We ask the patient to, we will insert the cones in the vagina and we will ask her to walk around. We will start with the lower weight. Once she starts retaining the vaginal cone, indirectly she is making levator and a muscle to contract in order to retain it. That's how we gradually will increase so that the levator and a muscle is strengthened. That's a part of physiotherapy.
Can you please repeat?
So vaginal cones are nothing but the graded vaginal weighted cones. We insert the cones lesser weight in the vagina and ask her to walk around. So when she starts contracting levator and a muscle, for a lesser weight, lesser strength is required. But we slowly increase the weight so that the levator and a muscle slowly, indirectly it is. It's a physiotherapy. In the physiotherapy, what we do, first we will ask them to just mobilize the hand. Then we will give him some weighted dumbbell to move, isn't it? Then we increase the weight. Even when we go to gym, that's what we do, isn't it? We slowly increase the weight. So like that, the physiotherapy, the rehabilitation of the levator and a muscle. Pardon? We initially we will observe her. Can she hold for 10 seconds? We slowly increase it. 10 seconds, 20 seconds. Like gradually we will increase the duration as well as the weight of the cones as well. That also can be implemented in your institute for pelvic rehabilitation. Yeah, it's there. I can share with madam later. I have to search it. In the next half, I'll put it. I'll put the video. Okay. See, for that, so PopQ has been devised in order to quantify it, means measure it, how much it is. See, earlier what used to happen, when I used to tell second degree prolapse, before doing surgery, I used to do second degree prolapse. After surgery, I used to tell that yes, second degree has been rectified and it has become first degree. That's all I can give. But this same patient, if somebody else has examined, if this patient goes to that doctor, that doctor would have told, no, first degree ही था ना, ये doctor क्या किया है, first degree को first degree रख दिया है. Unnecessary, he said that second degree and he did surgery, it has become first degree, but it was first degree only. So it was just a subjective. I used to tell second degree, somebody else used to tell third degree. It was not an objective. So PopQ is nothing but pelvic organ prolapse quantification. So it is nothing but we are measuring each thing, we are measuring in centimeter. अगर मैंने एक 5 सेंटीमीटर बोल दिया, it has to be 5 centimeter for all of us. It cannot be 6 centimeter for me and somebody else 4 centimeter. That is the thing. And second thing is, we have fixed certain points, AA, BA, AP, BP, and C. C stands for cervix. That is the thing. So we will measure how much it is coming down with respect to the introitus. Suppose AA is a point at the uretrovesical junction. Uretrovesical junction. I don't have the this one. Uretrovesical junction. So if AA is coming down, if you have the internet, it would be nice. There is one. I have this one video in the YouTube. Do you have internet? The forechair. So AA represents the uretrovesical junction. AP represents posteriorly perineal body. Okay. So this is nothing but the the IUCD pusher, I marked it into centimeter. So 1, 2, 3 centimeter. So I have to measure from the external meters. Grading is up to 12 centimeter I have done. So from external meters 3 centimeter. First we mark the points A and AP, then we will ask her to strain. Then how much it is coming down we will come to know. Uretrovesical junction is nothing but it is telling urethrocele, how much it is coming down. So after surgery it has to go to the same point, it has to become normal. So that much is the thing. So I am marking it. Then I will ask her to strain. That is AA. Then posteriorly slowly I am pulling out the speculum. So that's how we will identify posterior vaginal prolapse. Now we have to mark BA. BA is nothing but on the anterior vagina how much it is coming down, the anterior vaginal B. Yes, yes.
Why is that? They have to be measured where the patient strains maximally. That is, when the prolapse has come out to the maximum extent, that time we can be able to appreciate how much the proximal vagina which is coming down. So,
Can you please?
when the prolapse has come out,
I'll just attend on phone call.
when the prolapse has come out to the maximum, you can see that in the proximal vagina, this is the most distal part of the proximal vagina. Okay? So this forms the BA point. Okay? So when I reduce it in normal anatomical position and in the normal anatomy, the AA and BA point should coincide by the definition. But in a prolapse cases, the BA point may vary. Okay? So here, this is the BA point. So this has to be measured from the hymen or the introitus. So how far is it from the introitus? So you can note down that it is about 4 centimeter outside the introitus. So any measurement which is outside the introitus, we mark it as plus. And any measurement which is inside the introitus, we mark it as minus. So here, since it is 4 centimeter away from the introitus, we consider it as plus 4 centimeter. So what is the significance of BA? So the BA tells about the proximal vagina, and in turn it also evaluates that there is a cystocele. How much is the cystocele? Cystocele is about plus 4 centimeter outside the introitus. So when we do surgery, the surgical correction is said to be done properly if this BA point coincides with the AA point. Coming to the central defect, so in the central compartment we consider 2 points. One is C and another one is D point. So C stands for the cervical lip, which is lowermost, which is most dependent. So here you can note down that the posterior lip of the cervix is the most dependent part, so that we consider it as the C. So that has to be measured from the introitus, how much it has come out. So about 7 centimeter. So C is about plus 7 centimeter. Normally the C has to be inside the introitus about minus 10 centimeter. But in this case it has come out how much? Plus 6 centimeter. So next, the other point in the central compartment is the point D. So D stands for, in simple words, D stands for the pouch of Douglas. So how to mark the pouch of Douglas? The posterior lip of the cervix has to be held, pulled up, then the speculum has to be placed. Speculum has to be placed and mark has to be put on the posterior vagina, which coincides with the pouch of Douglas. As you all know that here, since the cervical elongation is there, the vagina is tightly adherent to the cervix. Only at the pouch of Douglas it becomes loosened. So this is the point which coincides with the pouch of Douglas. So this D point, how much it has come down? So when we measure it, it is about 3 centimeter inside the introitus. So we consider D as minus 3. So you can note down that there is a lot of disparity between the C and D. C is plus 6 centimeter, whereas D is minus 3 centimeter. So the total difference between the C and D is about 9 centimeter if you analyze properly. So what does that tell? That tells that the cervix is enormously enlarged or elongated. So this measuring of C and D point indirectly tells that the prolapse what we are examining is a uterovaginal prolapse and not a general prolapse. So coming to the prolapse, so we are measuring the 3 centimeter proximal to the fourchette, and this forms the point AP. So, point AP. This forms the point AP. So again we should ask the patient to strain to the maximum in order to measure the AP point from the introitus. So we will ask her to strain. So it is coming out, the prolapse has come out, but where is the AP point?
So instead of minus 3,
is about
minus 1.
at the maximum 1 centimeter. proximal to the introitus. So it is about -1 centimeter. So the AP point which has to be at -3 is at -1. So it indirectly tells that there is some deficit in the posterior vagina, but it is not that severe. It is about only 2 centimeter difference. So coming to the BP. Again, BP stands for the point on the proximal posterior vagina which has come out so this forms the BP. So when we measure BP point, so it is about the -2 centimeter. Since it is proximal to the hymen, we consider it as minus. So instead of -3 centimeter, it is -2 centimeter. So by measuring the AP and BP, we are coming to know that the posterior vaginal defect is not that severe compared to the anterior and central defect. So the advantage of the POPKI system is that it indirectly tells which compartment
So I
is
was
at
telling you,
maximum
you have to
strength
identify
and
site
how much
specific.
is the
This
severity of
site
the
which is
prolapse.
defective and how much.
So
it will help
in
us
this
to
case,
identify site of the
when we put the
defect and
POPQ
help
grid, we will be able to
factor
analyze
the
much
exact
more
site.
clearly what is the compartment which is defective and how much is the defect. So these are the 6 points which we have measured. There are other 3 measurements which has to be done. What are they? One is
genital hiatus from
genital
external
hiatus.
urethral meatus to portion.
So genital hiatus is measured from the external urethral meatus to the fourchette. So it is about 5 centimeters. Normally the genital hiatus has to be 2 to 3 centimeter, but in this case it is about 5 centimeter. It is little enlarged. Next is the perineal body. Perineal body has to be measured from the fourchette to the midpoint of the anal canal. So when we measure, this is the fourchette and this is the mid part of the anal canal. So it is about 2.5 centimeter. So normally the perineal body has to be 3 to 5 centimeter. Here it is about 0.5 to 1 centimeter deficit. So while doing the surgery, we have to keep it in mind that the perineal body also has to be constructed properly. The last measurement is the total vaginal length. So in the total vaginal length, the prolapse has to be reduced and the measuring stick has to be passed up to the pouch of Douglas and then it has to be measured. So here 6, 7, 8. So the total vaginal length is coming to the 8 centimeter. So what is the normal total vaginal length? About 10 to 11 centimeter. But in this case it is 8 centimeter. So not only there is prolapse but also there is shortening of the vaginal length. So we have to choose the surgery which are ideal to correct the prolapse and also to bring back the vaginal length to a proper extent. So this is how we do the POPQ grading. So as shown in the picture, there are 2 methods of quantifying the pelvic organ prolapse. One is this grid system, the another one is the line diagram. Most of the times we use this grid system where we draw a grid making
So this is
9
the grid
points.
system. We will mark it as
The
9
A
points.
and PA
Then we will write it down.
comprises of the
So in the case sheet,
anterior
before
compartment,
surgery and
C
after
and
surgery,
D
we will mark it.
makes
So to
the
identify
central
how much it
compartment,
is.
the AP and BP forms the posterior compartment. The genital hiatus which tells about the gaping of the vagina, indirectly tells how much is the levator ani defect. The genital hiatus is maintained in its normal measurement by the tonicity of the levator ani. If there is more gaping of the vagina, it indirectly tells that the levator ani is defective. The perineal body, as I have told you, forms the posterior distalmost support to the vagina, and if it is defective, it tells about the level 3 defect. The genital hiatus is maintained in its normal measurement by the tonicity of the levator ani. The appropriate surgery which has to be done. So, for example, in a case of wall prolapse, wherein the total vaginal length is reduced, is quite significant in a younger patient. So, in such younger patients, if we do the sacrospinous fixation, the total vaginal length will not be improved that significantly. Although support will be obtained properly, but the total vaginal length is not obtained significantly. Whereas the same patient, if she undergoes the sacrocolpopexy for the same wall prolapse, then there will be tremendous improvement in the total vaginal length. So, this measuring the total vaginal length after surgery will also tell the significance and the importance of the type of the surgery for particular patient. So we have examined the patient and we have put the POPD grade. So in this case, the AA is about 0. That is, 0 means the uretrovesical junction is at the level of introitus. Normally it has to be 3 cm proximal to introitus, but in this case it is at the level of introitus. So what does that mean? So it only tells that the uretrovesical junction is coming down. So indirectly it suggests the hypermobile urethra. So if we inquire with the patient properly, she may come out with the history of stress leak. In the prolapse cases, the patient may not voluntarily come with the history of stress leak. This could be because of the prolapse of the anterior vagina leading to the kinking of the urethra. Thereby, although there is the hypermobile urethra, because of kinking, there will not be involuntary loss of urine. So this we call it as a hidden stress incontinence, or else also called as subtle stress incontinence. So to evaluate this, we have to reduce the prolapse and then we should ask the patient to strain. So this is quite important because sometimes what happens, we may do the surgery for prolapse, but later after correcting the prolapse, she may again start complaining of the stress incontinence because the uretrovesical junction would be pulled up and the kinking of the urethra will be rectified for her to start complaining of this stress leak. Next, going to the BA point. So BA, as I told you, it's the maximum straining point on the proximal vagina, in a simple words. So this usually has to be minus 3 cm. AA has to be minus 3 cm, BA has to be minus 3 cm. So in a normal anatomy, the AA and BA should coincide. But what is happening here? It is about 4 cm distal to the introitus. So the proximal vagina is coming down. How much? About 4 cm. So this has to go back. How much it has to go back? About 3 cm from the external urethral meatus. That is the importance of the Poppy system. Coming to the C point, that is the most dependent part of the cervix, is about the 6 cm distal to the introitus. Actually this has to be minus 8 cm, but here it is plus 6 cm. So the central defect is how much? It is about plus 6 cm from the introitus. Next, going to the point D. So point D usually normally So point D normally has to be about minus 10 centimeter, minus 11 centimeter. But in this case it is about minus 3 centimeter. So there is about defect of 7 to 8 centimeters. AP and BP forms the posterior compartment. AP, which has to be normally minus 3 centimeter, is minus 1 centimeter, and BP, which has to be minus 3 centimeter, is minus 2 centimeter. When we compare the anterior compartment points, that is AA and BA, and the posterior compartment points, that is AP and BP, we can make out that the maximum strain is on the anterior compartment, not on the posterior compartment. So in this case, there is central defect as well as anterior defect. The posterior defect is not that significant. So the other three measurements, that is the genital hiatus, which has to be 2 to 4 centimeter, the perineal body, which has to be 3 to 5 centimeter, total vaginal length, which has to be 10 to 11 centimeter, is also defective. So that has to be kept in mind while doing the surgery. So instead of the grid, if we have to depict it in a line diagram, how to do that? So here is the 0, and whichever the measurement which is proximal to the introitus will be minus. The distal points will be always plus. So in a normal anatomy, what will be the line diagram? So the anterior vagina will be, this will be the AA, this will be the anterior vagina, the proximal vagina, again the BA, as per definition, coincide with the AA point. So AA and BA points will be next to each other in a normal anatomy. The C point will be at about minus 10 centimeter. This will be the cervix. This will be the D point, that is the point which coincides with the pouch of Douglas, about minus 11 centimeter. And again the posterior vagina runs up to the introitus. Again, if we have to measure the AP and BP point, AP point will be minus 3 centimeter and BP will coincide with the AP point. This is the normal line diagram. If we compare it with the abnormal case, that is, in this case, what will be the line diagram? So here the AP is at 0 centimeter, AA is at 0 centimeter, BP is about plus 4 centimeter, C is about plus 6 centimeter, D is about minus 3 centimeter, and the AP is minus 1, and BP is minus 2 centimeter. So if we join all these, we will come to know how much is the anterior and posterior defect. See, if we write like this, so this forms the defect. The AA, which has to be normally, which as it has to be minus 3, is at 0. That means the uretrovesical junction is up to the introitus. The proximal vagina, which has to be deep inside, has come out. So this much is the cystocy. The cervix, which has to be at minus 10 centimeter, is about plus 6 centimeter. And the D, instead of minus 11, it is about the minus 3 centimeter. So this forms the total
So we can
length of the vagina.
write it down, how much
cervix.
it is coming down.
So in this case, since the C and D points are quite apart, it also signifies that that much is the cervical elongation. Even the posterior vagina is also defective, but the severity is not much. Yeah.
So this is important. Yes.
Telling you that the stress urinary incontinence or any urinary incontinence, again, it's a very less spoken subject, especially among the patients who are coming to the OPD. So always make sure that you ask one particular question: is there any urine leak on stress or on coughing, or is there any other urinary problem? Otherwise, they themselves will think that it is normal and no need of any treatment. So, what is the definition for urinary incontinence? Any urine leak, we call it as the urinary incontinence. There can be 4 types. One is the stress urinary incontinence. Second one, urge urinary incontinence. The third one is the mixed, both stress as well as urge urinary incontinence. The another one very important is the overflow incontinence. And one more last one is functional urinary incontinence. All these are important. Why I am telling this is we have to differentiate each of them. So the management for each of them will differ. So what do you mean by the stress urinary incontinence? Stress urinary incontinence in simple words is whenever a woman coughs or sneezes, whenever she strains, that time there will be involuntary leakage of urine. Involuntary leakage of urine, that we call it as stress urinary incontinence. Next is the urge urinary incontinence. Urge urinary incontinence is the condition where the urine leaks on filling of the bladder. Suppose when we go out, whenever the bladder fills, there are two times the bladder sensation happens. One is at about 200 to 250 ml of bladder fillage. The another one is at about 350 to 400 ml of bladder fillage. So in the initially when the bladder fills, voluntarily we find this socially it is not acceptable to void the urine. So what we do is we consciously send the inhibition to our brain. The brain will indirectly again it will send a signal so that the detrusor muscle relaxes. It accommodates further urine. So in urge urinary incontinence, that accommodation is absent. So whenever the bladder fills in the first, immediately the lady has to pass urine. Otherwise she cannot control the urine. So that condition we call it as urge incontinence. The third is the mixed urinary incontinence. The woman will be having both stress urinary incontinence as well as urge urinary incontinence. So the cause for each of these will differ. Suppose the stress urinary incontinence is because of the bladder neck injury. the urethrocoel, wherein the sphincter will be defective. The urethral sphincter will be defective, so the stress urinary incontinence happens. So the defect is at bladder neck and with the sphincter. Whereas urge urinary incontinence, the defect is at the bladder. It has to relax, it is not relaxing. So the bladder defect is at bladder. Why I am telling this is because suppose if I put any tape considering it as stress urinary incontinence and the urethra is occluded and this case turns out to be urge urinary incontinence, then the severity will increase. Instead of solving our problem, we are aggravating the problem. That is the thing. The fourth one is the overflow incontinence. Overflow incontinence is nothing but the lady has lost the sensation of bladder fullness. Very simple. The lady has lost the sensation of bladder fullness. When this happens, normally we see it in post-delivery. So she had excess straining, the head was pressing on the bladder for a longer duration, the nerve was damaged, okay, the bladder sensation is not there. So after delivery, she is coming and telling that, no sir, I am having continuous urine leak. When we see the abdomen, there is bulge, the bladder is full. So the bladder sensation has gone, the bladder has filled to the fullest capacity of 400, 500 ml. After that what happens? It starts flowing, overflowing. It's like filling the tank. If it overflows, then the leak will happen. That's what is happening. So what is the treatment? We have to catheterize the bladder, leave it for 1 week so the nerve again regenerates. There will be neuropraxia, we call it as neuropraxia, minimal damage to the nerve endings that will regain, then our bladder sensation will come down. The another one is functional urinary incontinence. This we commonly see in our daily practice. सर मुझे पड़ोसन ने बताया था पानी पीना बहुत हेल्दी है, बहुत अच्छी बात है, मैं तो दिन में 10 लीटर पी रहा हूँ सर, मगर मालूम नहीं है हर 1 घंटे को पेशाब को जाना पड़ता है और कंट्रोल ही नहीं होता है. कैसे कंट्रोल होगा? इतना पूरा टैंक भर रहा है हर घंटे को एक बार, तो वैसा होता है. दिस इज कॉल्ड फंक्शनल यूरिनरी इनकॉन्टिनेंस. सो शी हैज बीन टोल्ड दैट द यूरिन taking the water is good for her health. She is going on, bladder is filling every hour, it is getting filled. So she has to pass urine. So that is functional urine. There is no organic problem, only functional. So among these all the incontinence, the stress urinary incontinence, mixed urinary incontinence are common. So what are the initial investigations we do? It goes by the mnemonic pads. P stands for post-void residue. So this is very important. So suppose a woman is telling that I am having urine leak. When you put the scanning, the bladder is completely filled with excess of urine. That is overflow incontinence. Or else, suppose if the bladder is filled about 300 ml, she is having the urinary incontinence, urge urinary incontinence. The bladder is not filled that much, then also she is having urinary incontinence, stress urinary incontinence. So like that it will come to know. Next is urinary analysis. Simple urine test will also tell so many things. Suppose she is having urinary infection, urinary tract infection, especially the bladder infection, cystitis. That time the bladder is very sensitive. At 200 ml it will start contracting. She is having urge urinary incontinence. Simple urine test will tell that yes, she is having urine infection. Treat the urine infection, urge incontinence will come down. Third one is voiding dairy. I was telling you, we should know how much she takes and how many times she passes urine. Some patients, they will be having the habit of taking coffee every 1 hour. Village side if we go, चाय तो लेना ही है हर घंटे को एक बार. So it's a diuretic. tea, coffee is diuretic. So she will be having urinary incontinence, isn't it? So when we go through the diary, we will give that this input and output chart for 3 days they have to put. So we will come to know how much she is taking the fluid and in which form she is taking, we will come to know. Sometimes the patient will be too sensitive. Even if she gets first sensation, she has to pass urine. But that is normal, isn't it? That is not a abnormal thing. She can void the urine, but she will not be doing that. Or else sometimes she will be working in the office in the AC condition. So those things we will come to know in the bladder diary and we can correct these. Though organic pathology is not there, many of the functional things we can correct by the bladder diary or voiding diary we call. Then the another one I mentioned about the full bladder stress test, isn't it? So what happens? Most of the women they will be telling that there is stress urinary incontinence. But when you examine there won't be any incontinence. What we have to do is we have to make her wait, take lot of water, then once the bladder is filled, that time we have to see. So that is also very important. So the stress urinary incontinence, I said it's the one of the commonest form of urinary incontinence. Now what are the treatment for it? So there are various surgical and non-surgical treatment. Suppose if the stress urinary incontinence is a milder form, she tells I will have occasionally. Suppose if I have a severe sneezes or if I strain a lot, then only I will have, otherwise routinely I will not have. That's a milder form. That also can be corrected with what exercise? Kegel's exercise. That can be corrected with Kegel's exercise. Suppose she tells that on daily routine, while working, while cooking, and if I lift a smaller tumble also I get, that is a severe form. That type of stress urinary incontinence requires surgical correction. Like that. We have to clinically grade the stress urinary incontinence, then we have to advise them about the management. So, this is the image of taking the pessary size I was telling you. We have to place the finger, we have to note down from the posterior fornix till the pubic symphysis how much it measures. Then we have to deduct 2 centimeter, that is the size of the pessary. Then we will go to the so this is the ring pessary, how to place the ring pessary. You are asking, no? So these are the various types of pessaries, Doe pessaries, Hodge pessaries. This is for stress urinary incontinence. Huh?
In place. The muscles of the pelvic floor and other supporting tissues hold your bladder, uterus, and rectum in place. If you suffer from first and second degree pelvic organ prolapse, with or without mild cystocele, and with or without stress incontinence, your doctor may recommend the use of a Cooper surgical bilex ring pessary. If these muscles and tissues weaken,
So that is the pelvic floor muscle which has come down.
may shift out of their correct position, resulting in pelvic organ prolapse. The Milex ring pessary is a device you can insert into your vagina to support and lessen the stress on your bladder and other pelvic organs. While wearing dry gloves, the healthcare professional will lubricate the entering end of the ring pessary with a lubricant such as Trimosan. Cooper Surgical's Trimosan is vaginal jelly that helps restore and maintain the normal vaginal acidity and reduces odor-causing bacteria. The pessary is folded by bringing the small round holes together. The knob will be at the top of the arc. Use your fingers to spread the labia. The healthcare professional will direct the pessary past the cervical os into the posterior fornix. The index finger is inserted deep into the vagina to turn the pessary approximately 90 degrees so that the knob is resting behind the pubic bone. The healthcare professional should be able to sweep one finger between the
So to know appropriate size, it should not be too tight also.
space to do this, the next smaller size pessary should be tried. If excessive space exists, the pessary will not be effective and may rotate or even be expelled. The Milex pessary, making life easier for you and your patient. For more information, please refer to the
I am not endorsing this product. I'm just playing the video.
Patient choice of keeping both heels parallel to the easy and involves hooking the pessary edge with the index finger.
This is removing. Removing is easy.
And used as a second-line treatment for patients unable to retain the ringwood support pessary. The support pessaries are used to treat stress urinary incontinence and pelvic organ prolapse. These types of pessaries are easier for patients because they are more comfortable and easier to remove and insert. Patients are able to have intercourse in spite of this type of pessary being in place. Examples of support-type pessaries include ring, garum, shats, and lever pessaries. The ring pessary is the most commonly used pessary because it fits
Earlier rubber pessary used to come, ring pessary. Now we have elastic pessaries which are inert.
ringwood support, incontinence ring, and incontinence ringwood support. The ring pessary treats all stages of pelvic organ prolapse. The ringwood support has a diaphragm that is useful for treatment of uterine prolapse with or without cystocele. The incontinence ring has a knob that is placed beneath the urethra to increase urethral pressure and is useful for treatment of stress urinary incontinence. The incontinence ring and incontinence dish pessaries compress the urethra against the pubic symphysis, increasing the urethral closure pressure, thus preventing urinary incontinence. Insertion of the ring pessary is done by folding it in half and inserting it with a curved side up. Once in the vagina, the ring opens up. The lower rim of the pessary should be placed.
Just if you push it behind the pubic symphysis, it will get retained.
Removal of the ring pessary is easy and involves hooking the pessary edge with the index finger. Another type of support pessary is the garum pessary. Although rarely used, it is intended to treat cystoceles and rectoceles.
In India, we have only the ring pessaries. We don't have these Garang pessaries and other pessaries.
Both heels parallel to the posterior vagina with a back arch pushed over the cervix in the pelvic organ prolapse. Insertion of the lever pessary starts by folding the pessary and inserting it into the vagina with the index finger on the posterior curved bar until it rests behind the cervix, and the anterior horizontal bar rests behind the symphysis pubis. They are currently rarely used. The second pessary category is the space-filling pessary. Examples include Gellhorn, donut, tube, and inflatable. These pessaries are primarily used to support severe pelvic organ prolapse, especially post-hysterectomy vaginal vault prolapse. They have larger bases to support the vaginal apex, therefore more difficult to insert and remove. When this pessary is in place, sexual intercourse is not possible. The Gellhorn pessary is the most commonly used space-filling pessary. It has a broad base with a stem. The concave base provides vaginal suction and maintains the pessary in place. The holes in the stem and base provide vaginal drainage. Folding one side of the base to the stem, the Gellhorn pessary is inserted vertically inside the vagina. The non-dominant hand separates the labia and depresses the perineum with the index finger to facilitate insertion. Once the circular base is inside the vagina, the pessary is pushed upward until the tip of the stem is just inside the vaginal introitus. Removal of the Gellhorn pessary is facilitated by pulling the stem while the opposite hand is inserted beneath an edge of the pessary base to break the suction to the vagina. The donut pessary is another example of a space-filling pessary. It is difficult to insert and remove because it is a large, thick, and hollow pessary. The donut pessary is used for advanced prolapse. It is inserted vertically, then rotated to a horizontal position once placed in the vagina. A Kelly clamp could facilitate removal of the donut pessary. A third example of a space-filling pessary is the cube pessary. It supports third-degree uterine prolapse by holding the vaginal wall with suction. Because of the risk of vaginal erosions, the cube pessary requires nightly removal and cleaning. Squeezing the pessary and inserting the device at the vaginal apex facilitates insertion. The inflatable is a space-filling pessary designed with an air-filled ball and a stem with a cord to allow patient insertion and removal. It is made of latex, so it needs to be removed daily. The inflatable pessary comes in small, medium, large, and extra large sizes. Insertion is similar to the donut pessary. The ball bearing within the stem is moved to a lateral position to allow pessary inflation. The bulb is attached, the pessary inflated, and the ball bearing is moved back into position to keep the pessary inflated. Then the bulb is removed. Although pessaries are fitted by trial and error, proper fitting requires the following. Obtain a thorough history.
No, madam. Nowadays, many of the patients will come asking for pessary, especially to be frank with you, madam, for prolapse, surgery is the definite treatment, definite. But suppose if the patient, they don't want a surgery for few days, such cases the pessaries are used. It's not the permanent treatment. And the whatever said and done, suppose if we, it's there, madam, it's there, it's there. Many of the patients are using pessary. Yeah, it's ring pessaries are very not that costly, very cheap, very cheap. But only thing is, see, for these things, many of the trials are required. That is the thing. Suppose patient, even the patient needs time, doctors also should give time. Once we put it's not the thing, we have to ask her whether she is comfortable. Again, she may come 2-3 days later. though we have checked it, everything is fine, then also she will come after 2-3 days. No, I am not comfortable with that. So like that.
Sometimes the pricing will come out.
Yeah, it will come off, madam. Many of the time, the slip off of the pessary are common. Yes. That's why 1 hour after insulting the pessary, we have to keep them for 1 hour. Make them walk around, climb the staircase, go for toilet, everything, then she will be comfortable. Otherwise, if we immediately send them, they'll come with the problem, one or the other. No, madam, if it is maintained, that's why the pessaries are ideal for the urban educated population, not ideal for rural uneducated, because it has to be maintained. And if we teach them how to remove it and reinsert, it becomes very comfortable for them. I have one patient, I had just lost the follow-up. After 1.5 years, she is coming that I am continuing to use her. How means I have learnt it, I am using myself. Fine. So like that, if they understand that, they will be able to use it. So, I was telling about the stress urinary incontinence. So, it is defined as involuntary leakage of urine in the absence of detrusor contraction. There won't be any detrusor contraction, but still urine leaks. Yes. So, how we will demonstrate the stress urinary incontinence is, we will ask her to strain. But usually what happens, one more very practical thing what I want to tell you is, we always ask the patient to be in dorsal lithotomy position, in gynec examination position, then we will ask. But sometimes the patient, they tell that, not in this position I will be having, while walking, while this one. So in such cases what we do is, we give one pad, pre-weighed pad. Then once she walks around, we will come to know whether there is staining, urine staining of the pad. Then we will come to know, yes, she is having urinary incontinence. Otherwise, when we dorsal lithotomy, when we examine, instead we will scold her and send her, hey, कुछ नहीं है आपको, बेवजह आ रहे हो, जाओ करके. What she will do silently, she will go to other consultant. That's all. So, in the pathogenesis, there are two types. One is the hypermobile urethra. The pubourethral ligament which is supporting the urethra is defective. The urethra is coming down. Because of that, there will be the urine leak or stress urinary incontinence. The hypermobile urethra is commonly seen in a younger population, about 30-40 years. Those who had 1 or 2 deliveries, they will be the one. Whereas the other type is intrinsic sphincter deficiency, where the urethral sphincter is defective. That is commonly seen in postmenopausal age, 60-70-year-old. In such patients we will be seeing. Why we have to differentiate is, again the treatment differs. In the hypermobile urethra, the sling surgeries are beneficial. Whereas in intrinsic sphincter deficiency, which is seen in elderly population, the sling surgery will not be appropriate. For them, either the artificial sphincter or the urethral, the bulking agents, those things are useful. And usually intrinsic sphincter deficiency is of severe. They tell even on changing the position on the bed itself will cause stress urinary incontinence. Whereas in hypermobile urethra, which is seen in younger population, is not that severe type. She tells occasionally I will get, and that too when I got a severe cough, that time I will come to know about this stress urinary incontinence, like that. Yes, madam. Yeah. Yes. Yes, madam. In the prolapse again, as I mentioned, because of the birth injuries. Birth injuries are the main cause. Yeah. So, in prolapse, I was telling you how to prevent prolapse by doing cesarean for all the cases. Okay. But stress urinary incontinence, you cannot prevent even if you do 100% cesarean. What I mean to say is, pregnancy itself is a risk factor. When the pregnancy happens, the intra-abdominal pressure increases. That itself will cause the straining of the sphincter and hypermobile urethra. So, pregnancy itself is a risk factor. So, in such cases, though she has not delivered vaginally, she may have. What madam is asking about, even if she is not pregnant, in such cases, the defect, yeah. No, madam. In such cases, the stress urinary incontinence will be very unlikely. Very unlikely. I have seen few cases where the nulliparous prolapse, nulliparous woman had the stress urinary incontinence. In one case, elderly woman who was not delivered, who has not become pregnant, but she had undergone radiotherapy for CS cervix. In such cases, again, there will be destruction of sphincter that time. Whereas in a young lady, suppose a 20-year, 18-year-old, she has come for with the stress urinary incontinence, kindly rule out other types. Stress urinary incontinence may not be the case. May not be the case. Now, for all these things, how we will come to know stress urinary incontinence? Clinical diagnosis. But whatever the other, that can be detected by urodynamic study. Urodynamic study. If we subject the patient for urodynamic study, we will come to know whether she is having mixed urinary incontinence, urge incontinence, then we can rule out. And even sometimes the simple urinary tract infection may cause. And as such, urinary tract infection will be common among female, and they will be presenting with the urinary incontinence. So, pessary for SUI, I already showed the video. I don't know whether this. The important surgery for the stress urinary incontinence, especially the hypermobile urethra, is the transobturator tape. So I was just talking during surgery. I'll mute the audio.
Placed the police catheter with the bladder, now distilled water. Now, once I pull the police catheter, it is lifted at the diaphragm because of inflated bulb. Here I can make out that now this is the tip of the clitoris. Take approximately 3 centimeters lateral to the tip of the clitoris.
That is the obturator canal which I showed in the anatomy. Obturator canal, because the tape will pass through the obturator canal.
Make a horizontal line from the tip of the clitoris and one more vertical line from the point of insertion of the adductor rhombus vertically. The intersection point is the point where the needle has to pass through. Now I make a transition.
You can uninterruptedly demonstrate the procedure.
Yeah.
Will not disturb in your flow of surgery.
Now the needle has to be pressed through the foramen and it has to be rotated. Since the needle tip is in the helical shape, it always goes spirally around the intrapubic hammer. Once the tip is bent with the index finger, then the index finger will assist in safe exit of the needle. Now you can see that the TOT tape.
So needle has come through. Then the tape is fixed to it and brought.
Once I retrace the course of the needle, I bring out the tape. The care has to be taken that the tape is not position. This is natural. Then the other needle has to be placed. Once I am immediate. Are you able to see?
Yes, yes. You do.
Yeah. Once the index finger touches the tip of here has to be taken that tape is not folded on itself.
So it acts as a amok. You have seen amok. So it will prevent the urethra from coming down. That's all. The tape will act as a amok.
Once that is ensured,
It should not be tight. That's why I put the scissor and check with it's not tight. Otherwise it will compress the urethra and she will have inability to pass urine.
which will subside eventually. So catheter can be kept for 24 hours and
So that is transobturated tape. So, yeah, we can combine, madam. Rectocele repair has to be done. Yeah, rectocele has to be done. Simultaneously, we can do the stress urinary incontinence surgery. No, madam, simultaneously we can do. Only thing is, clinically we have to detect what all the problems she has. Rectocele is there, whether uterus is also coming down or not, we'll check. Stress urinary incontinence we'll check. Then we will subject her for few investigation, urinary tract infection to rule out. We'll do urine routine, urine culture, because when we are putting tape, urine infection has to be ruled out. So we will do that. Then everything, if she is fit for surgery, if everything is okay, both surgery can be done at a time. Very important, madam. Very important. Yeah. Yes. Because it not only rules out mixed urinary incontinence, but it also will be helpful when we are doing surgery as well. That is. How we? Out. What? Yeah. When we pull out the tape, the extra length of the tape has to be cut. I have not shown because it's a edited video. I have cut it. We have to cut till the skin. Yes, to the skin level. I will not fix this tape to the skin. I'll leave it because it will be having lateral serrations. When it passes through the tissue, the serrations itself will hold the tape. And this is one. This is the immediate effect. Long-standing effect is that we purposefully use the macropore meshes. Macropore are the one wherein the macrophages will come and sit. When the macrophages come and sit, they start synthesizing collagen. That will give additional support. This is the immediate effect, that is the long-standing effect. So these are the two, this one. So then we will close only the skin. Stab incision skin is there. So what the stab incision was given on the skin, that will be closed, that's all. And vagina will be closed again. And catheter will be kept for 24 to 48 hours. And after 48 hours, we will take out the catheter. We will make her comfortable. We will see that she voids urine comfortably. Then we will send her. It will go until she goes to grave. So it is permanent. Permanent. You know what, madam? The lifespan of this tape is 166 years. So it is sure that it will go along with her. So that is the thing. Yeah. So suppose if we are doing it for mixed urinary incontinence, the urge incontinence may get aggravated. That is one. Or while doing surgery, the urethra may get damaged. Or the needle while passing, it may go to the bladder also. Bladder injury can happen. So surgery comes with lot of these headaches. Post-surgical, suppose if I put the tape little tight, then the voiding problem may be there. She tells, sir, I have to strain excess while passing urine. Then what I have to do is I have to put dilators into the urethra. I have to dilate it a bit so that she will be able to pass urine. Suppose if she, in spite of urethral dilatation also it is not coming, then I have to again open the vagina and cut the tape. Because fibrosis would have set in. It's very difficult to remove the tape. We have to think twice before we cut the tape because it's difficult procedure. That is it. So this is the mid-urethral sling which I showed. Huh? The other method is the Birch-Kalpa suspension. In the Birch-Kalpa suspension, what we do is it's not there. Yeah. So this is the laparoscopic Birch-Kalpa position. Here what we do is, instead of putting tape, we will fix it to the pelvic bone, the bladder neck junction.
The patient is a 57-year-old woman with 1 year history of stress urinary incontinence. Laparoscopic Birch-Kalpa suspension begins by dissecting the space of Brisket, which is also known as the retrograde space. The incision is made in between the two obliterated median umbilical ligaments on either side. This space lies in between the posterior layer, anterior abdominal wall, and the parietal plexus. The alveolar tissue in between the space is dissected off. As you can see, this space is immediately avascular.
Maximum.
The aim of this procedure is to re-establish the intra-abdominal location
This is the maximum. Usually speakers will be given there, down. The apertures are there, no? Okay, I will do one thing. I only will start describing. So this is the prepubertal space. The space what you are seeing dissection, this is the prepubertal space that is just behind the pubic symphysis. In the behind the pubic symphysis there will be a ligament called as Cooper's ligament or pectineal ligament. So we are fixing the bladder neck to that. So in a transobturated tape I said the tape is put, but instead of putting tape we can stitch it the bladder neck so that it doesn't come down. So that is nothing but Birch-Kalpa suspension. So now I am dissecting this the prepubertal space and pectineal ligament. Lot of vascularity will be there, careful dissection has to be done. So I was telling you arcus tendinous fascia pelvis. So the fascia is intact, only lateral attachment is gone. So we will fix it, that's all. So this is one side, again on the other side we have to dissect. This is nothing but the urethra. This is the bladder, this is the urethra. Can you see? Yeah, that is the urethra. See, now the assistant is putting the finger in the vagina to see where is the bladder neck junction. Because I have to take the bite at that junction only. See, that is seen. Huh? Now the stitch is taken. Suppose if I am taking bite, if I go deep, I may injure bladder. So that is the Cooper's ligament. This is the Cooper's ligament. Why we choose these ligaments are because they are strong. They will not become weak. Now it is fixed. See, the bladder neck is moved up now. So similarly on either side 2 stitches are put. Now this side also I am putting the stitch. But I should not pull it too much also. Otherwise again kinking will happen. So that is the later, afterwards the vagina which was coming out will be pulled back. So apart from that there are various other surgeries are also there. So these are the modifications of tape, transobturated tape what I mentioned, these are the modifications. Suppose the tape, if we have to control the tightness and looseness, then we can use this instrument. It is called as remix, wherein we can adjust the tightness. It will be brought suprapubically to adjust the tape tightness. So this is how the tape acts. It acts as a hammock to hold the urethra. Laparoscopic birch position. This is the injection of the bulking agents. So we use the polyvinyl alcohol. These are all microplastic elements which will be put in the bladder neck. So which is open, which will be closed because of the particles. They are like pellet-like, very microscopic pellet structures. When we inject, here is the open bladder neck because of intrinsic sphincter deficiency. After injecting the microplastic, this is the closed. So she will not have stress urinary incontinence. If the bladder neck, always it has to be closed. But in intrinsic sphincter deficiency, it will be open. So whenever she coughs or whenever she gets up, the urine will leak. Understood? But when we put the microplastic, then it will get closed. Whenever she strains, that time only urine will come. This is artificial sphincter. This is very costly, and nowadays we don't do this. This is a very invasive procedure. This, the incontinence pessary, already I have shown you. This is a simple the urethral insert device. What happens, suppose if the patient is not fit for surgery, you just put this insert into the urethra. Both sides the bulging will happen, the urethra will be closed. It's like putting a tap, this one. So whenever she wants, we can deflate this bulb with a syringe. Here the syringe accommodation will be given. When I deflate, this bulge will collapse. The urethral insert can be removed. She can void urine like that. So even there are scope for stem cell therapy. In the intrinsic sphincter, we can inject the stem cells so that it becomes the intrinsic sphincter, regrowing of the internal sphincter. So this is about the urinary incontinence.
Thank you, sir. It's truly an honor to gain knowledge from you. Your esteemed presence has indeed glorified the event and added a vibrancy to our humble gathering. Now I request Professor Isma Shamim ma'am, HOD Department of Ilmul, Qabalat, Amraze, Niswan, to present a token of to call the second speaker of the day, Professor Isma Shamim ma'am, HOD Department of Ilmul, Qabalat, Amraze, Niswan, and IIM Bangalore. Currently, Head of Department of Ilmul, Qabalat, Amraze, Niswan, Bangalore. Ma'am has done BMS and MD from Nizamiya Tibia College. Ma'am, come on the stage.
Good afternoon to one and all over here. How many of you are having postprandial cerebral hypoxia? Session. Dr. Vijay Kumar has delivered a very informative session regarding the pelvic organ prolapse, so he has made my job easy. Anyhow, I am not going to cover any modern aspect. I will cover only the Unani concept of pelvic organ prolapse along with this management. So the objectives of my talk is to understand the concept of pelvic organ prolapse and the different treatment options available in the Unani system of medicine, to learn from the research study the role of Unani medicine that can be used in the management of pelvic organ prolapse, and to draw the conclusion based on evidence-based research. So as you all know, genital prolapse is as old as Egyptian mummies. How old are the Egyptian mummies? 4,500 years old. So this is already discussed in the morning. Let's see what is the history of the pelvic organ prolapse. Kahun papyrus. What do you mean by papyrus? Yes, during the Egyptian periods, The material which is used for writing and printing is basically from the paper plant that is spread over the sheet and used for the writing and printing. So Cahun Papyrus, the first textbook on gynecology in the medical history, described the uterine prolapse in the form of management with a concoction. This concoction is nothing but a mixture which contains the cereal, fruit and the cow's milk, which is cooked together and then taken as a gruel. The gruel is nothing but ash, where the food is prepared with the wheat, barley, ash, rice. Either it is cooked in water or it is cooked in the milk. So in common word it is known as the gruels. So that is the treatment option for the uterine prolapse during the Egyptian periods. Ayush papyrus, which is apparently a copy of the older papyrus, mentioned the use of various lotions, honey, fumes of wax for the treatment of uterine prolapse. Ibn Sina, he has described the etiology, symptoms and the management of the uterine prolapse, and he has mentioned bath with alum water is sufficient or beneficial in patients who is having uterine prolapse. So this alum water, we have sufufezage available in the OPD. It mainly contains alum. So this sufufezage is very effective if the patient is having the uterine prolapse because it has got not only the antibacterial, antiviral activities apart from habis and habis. So basically it contains tannin which coagulates the proteins and helps the prolapse to revert back. Abul Qasim, that is Zahrawi, who is the father of the surgery, he has stated if any organ which was prolapsed but could not be reinserted or replaced in its positions can be removed from the below, that is nothing but the vaginal hysterectomy. Hippocrates recommended to apply the dry cupping over both the buttocks and the lower abdomen in the hope of sucking the prolapse back into its place. So even the dry cupping can be recommended if the patient is having the uterine prolapse either on the back or on the lower abdomen. He also advised to raise the foot end of the bed and sponge the prolapse with the cold wine until it was reduced. Cold wine, sharabih, barit. What are its properties? Habis. It also contains tannin, so it is helpful for prolapse to revert back. It was then supported in place by the vaginal pessary prepared with the pomegranate soaked in wine. Again, pomegranate anar. It is also helpful because it contains, it acts as habis and also it contains tannins which coagulates the proteins and helpful. They have also recommended to have the mechanical blocking of the vagina by vaginal pessary, which was considered as an accepted treatment for the genital prolapse till 1800. Habib Abbas, that is Ibn Abbas Majusi, a Persian doctor of the great repute, was the first to acknowledge the trauma, particularly the birth trauma, especially with the difficult and the prolonged labor as the cause of the genital prolapse. As Dr. Vijay Kumar in the morning has stated that the vaginal delivery is the single most important risk factors for the prolapse to develop. He also advocated the treatment as the manual replacement of the prolapse with the introductions of the wool pessary into the vagina. So first you have replaced the uterus positions, then you have kept the wool pessary. Later on you have to, the thigh has to be crossed, and this is considered as a treatment of the choice for the patients who is having the uterine prolapse for the 100 of the years thereafter. Other authors like Soranus of Ephesus, he has treated the uterine prolapse by amputations. So the excess portion of the prolapse has to be amputated. So before doing the amputations, the bladder and the bowel must be empty. Later on he has packed the uterus and performed the hysterectomy for the prolapse. So the excess part has been amputated, uterus has been packed, and later on he has performed the hysterectomy for the prolapse. Whereas Galen, he believed that the genital prolapse was capable of reducing itself, and he has used fumigation to vulval area to treat it. So fumigation is nothing but you have burned the drugs and you have given the fumes from below, that is nothing but dhuni. It is helpful if the patient is having the prolapse, especially you have to burn those drugs which has got fragrance, because the uterus has an affinity towards the fragrance. So if you give the fumes from the fragrant drugs or the burning the fragrant, it is helpful for the uterus to revert back. So So in 19th century, many conservative methods was available for the treatment of the genital prolapse, which includes like intravaginal pessaries, cold water douches, sitz bath, vaginal lavation, that is nothing but the vaginal wash, as well as uterine gymnastic and massage. Uterine gymnastic is nothing, I think, it is pelvic floor muscle exercise. Let's see what is the Unani concept of the pelvic organ prolapse. So the uterine prolapse was first described by ancient Egypt. There are several terms or synonyms for the uterine prolapse, whether it is a nutu-e raham, khuruj-e raham, zalaq-e raham or inzilaq-ur raham, buruz-ul rahim, istirkha-e rahim. All these are the synonyms for the uterine prolapse. So it is defined as uterine prolapse is the conditions in which the uterus descends down into the vagina or outside the introitus from its normal levels. So the causes of the uterine prolapse, as mentioned in the classical Unani text, that is Al-Aksir, Al-Khanun, Zakhir Khawasim Shahi. So the external factors includes like fall from the height, lifting heavy weight, trauma to the uterus, forceful shouting or sneezing, coughing, jumping, exposure to the shock or fear. So what will happen in all these conditions? Yeah, there is an increase in the intra-abdominal pressure. So if the patient is having any defect in the pelvic floor muscles, the uterus may descend down. So the internal factors include abnormal accumulation of the balgam-e ghalis in the uterine ligaments, which causes the weakness of the uterine ligaments, leading the uterus to prolapse or descend down. Again, it occurs in old age women with having excessive rutuban in their bodies. As Sarah discussed in the morning that in old age women, because of the lack of estrogens, it is estrogens which maintain the elasticity of the tissues, which maintains the collagen contents. When there is a deficient collagen contents, the uterus may descend down. Sometimes if the patient is having the uterine ulcer or khuru-e raham, it may also cause disruptions or discontinuation, thereby the chances for the or weakness of the uterine ligaments as well the uterus may descend down. Istirkha-e badan, that is generalized muscular weakness. Ayusha. You're sitting in front, right? You're sleeping. The obstetric causes includes delivery, difficult or precipitate labor, big baby, sudden expulsion of the fetus. In all these conditions, the chances for injury to the female genital tract, once there is an injury to the female genital tract, naturally the pelvic floor support may get damaged, and because it maintains the pelvic organs in its positions. So any sort of defect in the pelvic floor muscles or pelvic support may cause the organs to descend down. So the clinical features, symptoms. The patient may have the severe pain in the back, pelvis and anus, again because of the stretching of the ligaments and the muscles. Retention of the urine and feces, again because of associated cystosis in the rectocele. Dribbling of the urine, again because the sphincter has been damaged. Whenever the patients may sneeze or cough, the chances that there will be a dribbling of the urine. Fever may be because of the associated infections. Generalized body ache. Other symptoms may be like fever, tetany or tremors as mentioned in the classical Unani text. The signs include mass per vaginum, feeling of soft mass in the vagina and vaginal discharge. Again, the vaginal discharge may be because of associated infections or it could be because of the decubitus ulcer. So the diagnosis, on per-vaginal examination, if you are feeling a soft mass in the vagina, it confirms the diagnosis of the uterine prolapse. Differential diagnosis, on PV examination, the externals of the cervix is felt in the uterine prolapse, whereas it is not felt in the inversion of the uterus, because in inversion of the uterus is turned outwards, okay. And again, the uterine inversion is an acute obstetric emergency which usually occurs because of the mismanagement of the third stage of the labor. So it can be easily differentiated. We are able to visualize the os, it is uterine descent. If it is not, we are not able to visualize the os, it is uterine inversions. So the degrees of the uterine prolapse, like descent of the uterus into the vagina, same as in modern concept. descent of the uterus up to the outside the vaginal introitus is the second degree. Third degree, the complete descent of the uterus along with the bladder rhythm, that is nothing but the uterovaginal prolapse. So what is missing here as per the modern concept? Second degree. Okay. First degree is the same, second degree is missing, and here the second degree is comparable to the third degree of the modern medicine. Okay. So the management advice the patient to have a rest and reassurance, avoid intercourse at least for 2 months, avoid strenuous physical activities as well as shouting, again because it increases the intra-abdominal pressure which also the patients may have. Avoid home deliveries by the untrained midwives and encourage for the hospital deliveries. Avoid immediate resume to the work and heavy weight lifting following the deliveries. So the principles of treatment, usul ilaj, it includes treat the cause. As the cause is accumulation of balgam lazij or thick phlegms within the uterus. So you have to give misal balgam adya mainly for tankhaya badan. Use mulagin hukna for tankhaya ama. Use mudarribol adya for tankhaya masana. So again the same concept is here. You have to evacuate the bladder as well as the bowel. Then following tankhaya you have to replace the uterus in this position. Once you have replaced the uterus in this position, you have to use khabis and mukhawir ram adya because these are the drugs which strengthen the uterus in this position. And mukhawir ram adya basically is acted on the uterus by providing strength to the uterus and also by maintaining its normal temperaments. Whereas khabis drugs mainly it constrict the uterine ligaments and helps the prolapse to revert back. Ilaj mulkaza. So the diet which is allowed is usually liquid diet is preferred. It should be jayyidul kayus, sariul hazm, like bazain risht, meat soup, maul laham, maul sheer, moong ki dal ka pani, maul fawake and sagudana. Diet restricted, the food is usually avoided during the course of treatment. Why? Why the food is avoided during the course of treatment? Constipation. Is it? Food is avoided during the course of treatment. They have advised to give the light diets only. What else? Bowel and bladder must be empty. Okay, that's why you have to prefer diet is liquid diet. Avoid spicy and the salty food also. Various regimens which are being recommended. Massage the uterus with rogan will mixed with rogan khalukh and ghalia. What is khalukh? What is khalukh? खुशबूदार दवाएं जो काफूर मिश्क अंबर की आमेज से बनाया जाता है उसको खलूख कहते हैं. What is ghalia? Aromatic powder which is prepared from the aromatic plants. So when you observe the nuskha, massage the uterus with rogan gul mixed with rogan khalukh and ghalia. All this contains aromatic drugs. So again, the uterus has an affinity towards the aromatic drugs. So when you do the massage over the lower abdomens, massage of uterus is nothing but the lower abdomen, so it helps the uterus to revert back. Massage with rogan shamil, again aromatic drugs with saffron or ghalia. Hijama and muhajjama nari, there is nothing but the application of the fire cupping over the back to revert the uterus to its normal position. Hijama bilashu, that is nothing but the dry cupping below the breast as well as the umbilicus, especially for a longer duration to make the prolapse to revert back. You have to avoid hammam, avoid use of items which causes sneezing and coughing, avoid intercourse at least for 2 months, use fragrant items, avoid unpleasant items. Why hammam has to be avoided? Yes. What else? Yes. हमाम से जिस्म में नरमी और तरी पैदा होती है, एक तरह की मसल रिलैक्सेशन का काम करें, दैट्स व्हाई इट हैज टू बी अवॉइडेड. इवन दे हैव रिकमेंडेड टू अवॉइड यूज ऑफ मुसख्खिनात. मुसख्खिनात मीन्स गर्मी पैदा करने वाले कैलोरीफिक ड्रग्स. व्हाई इट हैज टू बी अवॉइडेड? It increases the metabolism because of the hot temperament. So there are chances for tahleel, the chances for vasodilatation, muscle relaxation. That's why use of musakkinat has to be avoided if the patient is having uterine prolapse. Then the procedure of the implant replacement. Patient is asked to lie in the lawful returning position, and you have to keep sterile soft wool over the uterus. Then tampon soaked in usara akhakhia or khabit sharab is to be placed over it. Again akhakhia, khabis and habis stuck. Okay, first you have replaced the uterus in its positions, you have kept the wool sterile soft wool over the uterus, then later on you have kept the tampons which is prepared from either usara akhakhia or khabis sharab in the vagina. Then you have covered the vulva with a pack soaked in the vagina and the bandage is applied over it. Pad soaked in vinegar. What is the role of vinegar here? Antiseptic. What is vinegar actually? Acetic acid. Okay. Acetic acid is the main component of the vinegar because the vinegar contains 5 to 6% of the acetic acid. This is the end product of the fermentations. So again, vinegar acts as a disinfectant, antibacterial, antifungal, wound healing. That's why Hippocrates used vinegar for the cleansing of the wounds. That's why they have recommended the vulva has to be placed, the pad has to be placed over the vulva, soaked in the vinegar, and then later on you have to apply the bandage over it. And the patient is instructed to remain on the bed for 2 days, and only the liquid diet is allowed, and then cupping is applied over the lower back. And on the 3rd day you have to remove the tampon, and the fresh tampon has to be shown in the Shanda of the Khabit Adviya, whether it is, what are the Khabit drugs? Mazin, Mayan, Gulnar, Post, Anar. So Fizaj. Okay. Then absent with Iskhar, Habbul As and Gulesru, again Habis and Habis drugs. Vaginal packing is recommended on every alternate day to prevent the further descent of the uterus and advise the patient to avoid ambulations at least for 1 week. So these procedures can be applied if the patient is having 3rd degree cervical descent or prostration. So again, if you are applying the same regime as mentioned in the classical text, that is Al-Aksir, Al-Khanun, Al-Habi, it may be helpful if the patient is having 3rd degree or 4 or prostration. So the first and foremost treatment is you have to go for Tankhiyah Badal, sabab ka izala karenge. Tankhiyah Balgham with the help of Habbe Ayarish, Habbu Nui, Shahab Hanzal, Ayarij Turbudi and Ayarij Khibr. Use of, then you have done the Tankhiyah, then you have to use uterotonics, Mukhavir and Adviya. So these drugs like Dawaul Misk, Khurse Ambar, Sharbate Bad Shakri, Sharbate Gauzuban, Majule Mocharis, Jawahar Mohara 20 milligrams or Habbe Jawahar 1 piece with Khamire, Gauzuban Ambari or Dawaul Misk. These all drugs not only act as uterotonics but they also act as a generalized tonic. So it also improves the generalized weakness as well as uterine weakness. So may be helpful for the uterus to revert back. Apart from this, there are several drugs that can be used locally, topical drugs like use of Hukhna with Rohan-e Zalbakh mixed with a small amount of Khalukh and Ghalia. Again, the Hukhna has to be done with a mixture of the drugs which are aromatic, or else prepare the decoction of Shugufai Anar, Shugufai Mazu, Karnab Kham Aslu sauce, each 1 part, then Sarupal half part, Ustukhudus, Shugufai Babuna, each 1/4 part. Add 2.4 ml of the Rogan-e As and 1/4 part of the Rogan-e Zaitun in 204 ml of the decoctions, and it has to be used for Hukhna. Rogan-e Shamili suffered with little amount of Ghalia. Hukhna can be done with Rogan-e Shamili with little amount of Ghalia. Mutun, that is nothing but the irrigation. So So irrigation can be done with a small amount of Rogan Zafran in Rogan Zambah or Rogan Gul and pour few drops of this water over the uterus, in the uterus. What does it mean? Pour few drops of the Rogan Zafran, Rogan Zambah or Rogan Gul in the uterus. What is that? What do you call this procedure? Pishkari, douche. Then another regime recommended is takme, that is nothing but the hot fermentation with the use of Rogan Gul or akhakhiya with water or usare tarasis mixed with sharab khabis or aswad as recommended by those kharidos. Okay? As. Habulas. Tarasis is also a khabis truck. I will tell you later. Then the nuskha that can be used for the fixation, that is nothing but the passeri. Again, all khabis and khabis, akhakhiya, sak, ramak, dissolved in khabis sharab, and madbukh babul, tarasis, ambar sabs and kharnoob. There are several other nuskhes are available like gonde babul, tabashir, mazu, kharnoob, akhakhiya, mushk and zarmak. All these are grounded with the sharab and used in the form of firzaja. Barge murid, gunesruk, akhakhiya and postena. All these are the drugs. Similarly, akhakhiya, murmakki, kundur, gulnar, barge as, habbulas, gunesruk, adase mukhashar. What is adase mukhashar? Masoor ki dal. Mazu sabs. All these drugs are the finely powders. Firzaja is prepared with sharab afis and soaked in rogan murid or rogan gul, and it can be used in the form of passeri. The drugs which can be used in the form of zimad or ointment. Once the product, you have removed back the products in its positions, apply the zimad of astringent drugs like poste anar, kaz mazish, gulnar and poste mugulan. Poste mugulan is nothing but akhakhiya over the pelvis. Even mutul with madbukh of these drugs is also beneficial if the patient is having uterine prolapse. Similarly, baboon, tarasis, gulnar, mazu, akhakhiya with usare lehtuttis, which is dumped in abe as and abe bartang sabs and apply over the pelvis in the form of zimad. It's also helpful for the uterine prolapse. Poste anar, aride jaw. What is aride jaw? Barley flour. Sirka with water and apply over the lower abdomens. Baboon ki phalli, that is akhakhiya, tarasis, tarsus, nagar muta, habbulas, akhakhiya and gulnar. All these are prepared in sharab and abe habbulas and can be used in the form of the zimad. There are several other nuskha that can be used in the form of abzin, that is sisbad, like iskar, habbul as and gulisr. Already research has been done on this nuskha. Iskar, gullab and mazu, as, iskar and postenar, all this boiled in abe khumkhum. Abe khumkhum is nothing but the lukewarm water. Apart from this, the other drugs that can be used in the form of abzin are joshande as, joshande mastagi, joshande khumkhum, joshande mazu. Hormone tampon. So the tampon can be done with the drugs like usara, bukhure Maryam as recommended by Janinus, habbulask, gulisukh, samakh, mastagi. Even rogan gul with rogan susan for decubitus ulcer on the prolapse part. What is the cause of decubitus ulcer? What is the cause of decubitus ulcer? Venous congestions and local injury. Sir told in the morning that there are two causes for decubitus ulcer, venous congestions and local injury. That's why the patient may have, the tissue becomes very febrile, chances for injury to take place, and they are with accumulation of the fluid. So that's why they are recommended to use Rohane Gul with Rohane Susan. Okay, I will tell you what are the properties of the Gulistic in later subsequent slides. Other therapies that can be recommended are Zarur. Zarur is nothing but you are sprinkling the powder, the drugs like Akhakhiya, Mazu, Gulnar. It is all beneficial if the patient is having decubitus ulcer. So the mixture of Akhakhiya, Mazu and Gulnar can be used in the form of sprinkle over the decubitus ulcer. Dhuni, that is fumigation, where you are burning the drugs and giving the fumes to the patients from below, like use of cow dung, Bukhure Maryam along with sirka as recommended by Janinus. Then use of lusukh. Lusukh is nothing but semisolic sticky compound. Can be prepared from ardeja barley flour, or even masoor ki dal with other khabis drugs. Ilaj being a surgical treatment. If the uterine prolapse fails to replace its normal position or it gets ulcerated, the treatment recommended is hysterectomy. Let's see what is the prognosis. The disease can be treated earlier. It is an acute stage and it occurs in the young age, young women. Once the disease becomes chronic, it is difficult to treat. If the entire uterus comes out of the vagina and the treatment is unsuccessful, the woman may die. What is the cause of death in uterine prolapse? Shock. Shock and hemorrhage. Shock and hemorrhage, again because of the stretching of ligaments, and there are chances that because of the stretching of the ligament, sometimes there will be chances for the rupture of the uterine vessels, which the patient may have hemorrhage. So if the patient is in the prolonged prolapse, because the gravitational force, the patient may go into the shock and hemorrhage. That could be the reason for the cause of death if the patient is having uterine prolapse. Complications. The prolapse part may get ulcerated because of the venous conditions and local injury. Let's see what are the research studies conducted in Unani on uterine prolapse. So one of the studies conducted by Farzana et al. In 2012 to evaluate the efficacy of Acacia arabica, Achacia, in improving the woman's quality of life in uterovaginal prolapse. So this study was conducted on patients, like 40 patients of uterovaginal prolapse was included, and the patient was given Achacia, both orally in the powder form. 3 gram of powder was given in 2 divided doses, that is 1.5 gram in the morning, 1.5 gram in the evening, and locally whole of same drug was kept. 6 gram of the powdered achacia was dissolved in the 20 ml of the water. The whole soaked in this water was inserted in the vagina once daily at bedtimes for 8 weeks. In addition, the pelvic floor muscle exercise was advised to the patients. Okay, so the drugs was given both orally as well as locally, and even the pelvic floor muscle exercise was advised to the patients. So after this study, it was found that achacia was effective to improve the quality of the life of the woman who is having the uterovaginal prolapse because it acts as a habis, mujaffid, muhallil and mukhawir raham. So again, achacia basically it contains tannins, and the tannin has got astringent property. It helps with the coagulation of the protein. It coagulates the protein, constrict the ligaments, tone up the muscles, and helps the uterus to revert back to its normal positions. So the achacia is the most commonly used drugs if the patient is having the uterine prolapse, both orally as well as locally. It can be used in the form of the absent also. Yes, we have made first fine powder. Fine powder of achacia has been prepared. The achacia can be given in powder form. The powder can be filled with the capsules.
No, ma'am. I'm just telling you the mole.
Huh.
Only you are giving it's okay, ma'am. You are putting a mole also, ma'am.
Yes.
20 ml.
See, powder, how do you pour? The powder can be given directly. There should be some vehicle, no?
20 ml पानी लेना, ma'am. तो उसमें paste जैसा बन गया है या mole?
No, you just tell me what is the size of a mole.
Mole is very small.
Size I'm asking. Have you observed any time how much the mole soak water? 20 ml is the minimum quantity. Okay?
That we can observe.
Yes. Another study. Effect of voucherus and ambulas in uterovaginal prolapse conducted in 2016. So here the patient with first and second degree uterovaginal prolapse in the age group of 30 to 60 years were randomly allocated in 2 equal groups, that is group A and group B. In group A, 4 gram powder of the voucherus was administered orally with milk twice daily, 4 gram in the morning and 4 gram in the evening. And in both the groups, local treatment in the form of absinthe with Joshanda Habbul As. 12 grams of Habbulas is boiled in 1 liter of water. Later on, the 20 liter of water has been added and the patient is advised to have the sitz bath once daily for 8 weeks. After the study, it was observed that the both drugs was equally effective in improving the quality of the life of the women suffering from uterine prolapse because these drugs act as mujaffif, khabis and mukhawi activities. So the chemical constituents of both the drugs, whether it is Bothres and Habbula, this shows that it contains tannin, catechin and flavonoids, which absorb the excess fluid, constrict the ligaments and provide strength to the pelvic floor muscles. Thereby it is helpful for the uterus to replace back to its position, revert back. Another study was conducted to evaluate the efficacy of mazu in the management of uterovaginal prolapse. So here again in the test group, sitz bath with decoction of 20 gram of powder of mazu. 20 gram powder of mazu was taken, the decoction was prepared in 1 liter of water. Then later on 4 liter of the water has been added so the patient may have the sitz bath in test group. Whereas in control group, patient was advised to have the sitz bath with common salt water, where again 10 gram of common salt is mixed in 5 liters of the water, and then the patient was advised to have a sitz bath for 8 weeks. In addition, the pelvic floor muscle exercise was advised to patients of both the groups. After the study, it was found that mazu was effective in addition with the pelvic floor muscle exercise because it has improved the subjective symptoms like mass per vaginum, urinary incontinence, lower abdominal pain and low backache. So this shows that sitz bath with mazu can be used as an alternate treatment options for alleviating the symptoms of the uterovaginal prolapse. So again, mazu acts as a powerful astringent and styptic. Again, this astringent effect of the mazu is because of tannin, okay? Because the tannin has got the capacity to coagulate the proteins. Thereby it helps help in the construction of the ligaments, it tone up the muscles and help the prolapse to revert back. This was the study which was conducted at Malegaon to evaluate the effect of Tukhme Tamar Hindi in uterine prolapse in 2018. So Tukhme Tamar Hindi kernel was separated after roasted and then fine powder of the kernel was prepared in electric grinder. The powdered drug in a dose of 5 gram was kept in a gauze piece to make the tampon for the local use. So the study was conducted with 30 cases of first and second degree uterovaginal prolapse. And the patient was treated with tampons prepared from Tukhme Tamar Hindi, and this duration of the treatment was 3 months. After the study, it was observed that Tamar Hindi is effective in 36.60% of the patient as the clinical features of the uterine prolapse were revealed completely. Okay, while other patients have symptomatic relief. So in 36.60% of the patient, the prolapse have reverted back, whereas the rest of the patient, the symptom has improved. So this study shows that Tukhme Tamar Hindi is effective in the management of the first and second degree of the uterine prolapse, and the drug was well tolerated because the patient doesn't have any sort of side effects. So why this Tamar Hindi is effective? Because again, it has got khabis, mujaffif, mukhawi and Muzayyiq first properties. It tightens the vaginal introitus, thereby it is helpful for the prolapse to revert back. Even we have in OPD Sufuf Tamar Hindi that can be recommended if the patient is having not only istirkhai, famiraham or uterine prolapse or for the vaginal tightening. This Sufuf Tamar Hindi also can be recommended, and even if the patient is having Salanur Rahim, it can be also used because it has got habis properties. So this was the study recently conducted to evaluate the effect of uterine treatment regimens in uterovaginal prolapse. It is an interventional pre and post analysis study. So the regimen which includes Abzin, Humul and cupping. The study was carried on 30 patients between 30 to 60 years of age having first and second degree uterovaginal prolapse. We received the regimen like first Abzin, Humul, then dry cupping. Abzin with Joshanda and Gulisurh, Habbulas and Iskhar, Humul with Akhahia, the dry cupping on the alternate days over the lower abdomens, and then the duration of the treatment was 8 weeks. Abzal was prepared with 20 gram of coarsely grinded gulisur, habbulas and iskal by boiling in the 1 liter of the water, and then it was mixed with 4 liter of the plain water so that the patients can have the sitz bath easily. Then once you have given the sitz bath, then whole has been prepared with akhakhiya. 5 gram of the powdered akhakhiya dissolved in 20 ml of the water. Whole soaked in this water will be kept in the vagina once daily at bedtime for 8 weeks. Then later on the patient is advised to have the dry cupping on every alternate day over the lower abdomen. And the subjective parameter which was assessed was mass per vagina, urinary incontinence, low backache, lower abdominal pain. So after the study it was found that there was a significant reduction in the subjective symptoms. Even there is an improvement in the quality of the life. So that's why the use of Unani regimens like we have used first Abzal, then Humul, then dry cupping is effective in improving the symptoms of retrovaginal prolapse as well as to improve the quality of the life of the woman. This trial is yet to start. CTI was obtained, we have to enroll the cases. To evaluate the effect of Shibbe Yamani versus Akhakhiya in the form of Humul in retrovaginal prolapse. So again, the criteria is married women. 40 married women was included in the age group of 25 to 55 years, having first and second degree retrovaginal prolapse, with complaining of mass per vaginums, stress urinary incontinence, low backache, and white discharge per vaginums. So here in this, as 40 patients has been equally divided into 2 groups, test group and the control group. In test group, solution of Shibbe Yamani Bria was prepared. Humul, that is Mahlul was prepared. Like 4 gram of Shibbe Yamani will be prepared after dissolving in 30 ml of distilled water. 4 gram of Shibbe Yamani was dissolved in 30 ml of the distilled water. Okay, once it has been dissolved, you have kept the Humul. Once the Humul has been dipped completely, and then that Humul will be kept in the vagina once daily at bedtime for 8 weeks. This is in the test group. Whereas in control group, as we have studied Akhakhiya already was studied in the previous studies. So this Akhakhiya was used as a tested Unani drug. So in control group, Akhakhiya was used in a similar pattern, like 6 gram of the powdered Akhakhiya was dissolved in the 20 ml of the water, and then the tampon dipped in this water will be inserted in the vagina once daily at bedtimes for 8 weeks. Okay, Akhakhiya is already the tested drug which is used as a control, and here what we are going to use as a test drug is Shibbe Yamani. Okay. Again, the common regimen which is advised to both the patients of the group is pelvic muscle strength. Assessment tool is mainly to improve the quality of the life of the women and to look for the improvement in the POPQ system as well as visual unlock scale. It will be assessed during the trial. And when you look into the qualities of the Shibbe Yamani, again Shibbe Yamani acts as a Habis Mujaffif, Mukhawwi Raham, Jali Muhallil, Mundamili Khuru, as well as Dafa Tafan properties. So it is also effective if the patient is having any sort of local infection as well. Let's see what are the evidence-based Unani medicines for uterine prolapse. Akhakhiya, Babul. So the babul is the most important plant. Almost all its parts are used in the medications, including root, bark, leaves, flower, gum and pods. Means all parts of the plant are useful in the medicine. And the extract of the pods or legumes of the babul is known as akhakhiya. So it is mentioned in Al-Khanun fi Tib. Decoction of akhakhiya is beneficial in urogenital diseases. It prevents the chorea and revert back the uterus as well as anus. So it is helpful not only in uterine prolapse but also anal prolapse. It is also useful in istirkha-e-rahim and it tightens the perineum if it is used locally. So akhakhiya is the drug of the choice if the patient is having the uterovaginal prolapse as well as decubitus ulcer. Mazu. So as you all know, the gums are the most powerful of known astringents. They are applicable in all cases where astringent medicines are required because it contains tannic and the gallic acid which act as a styptic as well as astringents. So it was mentioned in Khazani Nadiya as well as Jami Mufardat that Abzal with Josande Mazu is helpful in uterine prolapse, rectal prolapse and chronic leukorrhea. Sulfatamazole is used internally to prevent menorrhagia, leukorrhea, and to tighten the vaginal introitus. Gauze are used to restore the postpartum uterine elasticity and stimulate the contraction of the vaginal muscle. So any sort of laxity, especially in the postpartum period, can be recovered by the use of gauze in the form of the abscess or hole. Decoction of the gauze is used as douche in case of a uterine prolapse, and as enema in rectal prolapse proves to be beneficious. Hambulas. It is one of the oldest medicinal plant used by the ancient Greeks and Romans for a variety of ailments because of its flavor and the fragrance. So these gauze basically it acts as astringent, hemostatic, desiccant, anti-inflammatory. Hence it is helpful in uterine prolapse, laxity of the vagina, leukorrhea and menorrhagia. Absent with the boiled extract of habbulas is beneficial in khuruj rahim as well as khuruj liqat and salani rutubati rahim. So it is helpful in leukorrhea also. Jushanda prepared from berries is useful in salani rutubati rahim. So these berries basically contains tannin, sugar, flavonoids, terpenoids, citric and malic acid. Thus it is helpful if the patient is having uterovaginal prolapse. Motilus. It contains muhabbi rahim, khabis mujaffif, jazibe rutubate rahim. So motilus possesses astringent and styptic properties. So the aqueous extract of the bark, when it is mixed with the curd, are used in diarrhea, dysentery, leukorrhea and menorrhagia. So the bioactive constituents of motilus basically includes steroids, tannin, flavonoids, triterpenoids and glycosides. So it is helpful if the patient is having any sort of genital infections as well as prolapse. Rumman, anar. It acts as khabis, rade mujaffi mukhawiyye aza, mawalid khoon, anti-inflammatory, cardioprotective as well as antioxidant. So the bioactive constituent of the anar, it includes tannin, ellagic acid, flavonoids, saponins and gallic acids. So basically this rumman juice is useful to resolve the infected wounds. It is useful, gulnar is useful in salani rahim. Already one study is going on with the suppository prepared from the gulnar. It is, the study was concluded, we have to write the results. So this shows the gulnar is also effective if the patient is having leukorrhea or even the uterine prolapse. So that's why most of the Unani physicians they have recommended to do the passery has to be prepared from the ring of gulnar. So the ring of the fruit is used in diarrhea, dysentery, dyspepsia and uterine disorders also. So rohanigul in combination with other drugs is used locally in the form of lutul, takmeed, firzeja in uterine prolapse. Either it can be used alone or it can be mixed with other drugs and can be used locally. Absent with Joshanda postenar is useful to prevent the heavy menstrual bleeding as well as leukorrhea. Gulisur, it acts as mukhawwi rahim, khabit muhallil aura, muhallil mukhrij madda majlisa. So fresh flowers are hard, bitter in taste with mild acidness and sweetness, giving it medicinal properties. So the fresh flowers of rose have got medicinal property, whereas dried flowers has got khabit properties. So gulasur is used in the form of kumul or absin, is helpful in salani rahim, dard rahim, offensive vaginal odor as well as to tighten the vaginal introitus. Sharbatet gulasur strengthens the internal organs including the uterus. So it can be used as a general tonic also. So these activities is because of the presence of the bioactive constituents like flavonoids, alkaloids, glycosides, phenols, tannins, saponins, etc. Murmukhi. So I can say Murmukhi is a drug of choice for all gynecological disorders, where the patient is having discharge, menstrual disorders, infertility, any type of gynecological disorders, Murmukhi is the drug of choice. So this Murmukhi, it acts as astringent, antiseptic, antimicrobial, anti-inflammatory, analgesic, diuretic, apart from other activities. It is used as firzeja in inzilahur rahim, in combinations with other drugs. Either it can be used single or in combination with other drugs if the patient is having a uterine prolapse. More is beneficence in dard rahim, dysmenorrhea, varme rahim PID, salani rahim leukorrhea, salabate rahim, that is chronic PID, and all menstrual disorders. So these properties of the more is basically because of the presence of the bioactive constituents like volatile oil, resin, gum, alkaloids, again tannins, flavonoids, saponins, glycosides, all these are responsible for the activities of the mimicry. Zaitun. Zaitun acts as antioxidant, anti-cancerous, antibacterial, antiviral, anti-inflammatory, anti-diabetic. So Ibn Sina is recommended the local use of zaitun in the form of hukhna with other drugs is useful if the patient is having the uterine prolapse. Babuna. It acts as muhawi dimagh. Apart from other activities like antimicrobial, anti-inflammatory, anti-cancerous, antioxidants, mohalile warm wa salamat, either it can be used in the form of takmeed or zimat. So these activities is mainly because of the presence of the bioactive constituents like volatile oils, steroids, flavonoids, saponins, triterpenoids. So the decoction of the babuna flowers in combinations with other drugs as recommended by Ibn Sina is used in the form of hukhna for uterine prolapse. So again, babuna can be used if the patient is having a uterine prolapse. Zafran. So zafran basically acts as muhallil, munzish, mulattif, mulayyin, muhawi ahsha, apart from other activities like antioxidant and anti-cancer, because of the presence of the bioactive compounds like terpenes, quercetin, alcohols, etc. So it was mentioned in Tibet-Bari and Zakhir Khawasim Shahid that Rohane Zafran with Rohane Gul, Rohane Zafran with Rohane Zul is used in the form of mutun for uterine prolapse. Passery prepared with equal quantity of zafran, affion and touch mixed with Rohane Gul to treat the uterine disorders. So zafran basically it is strengthen the internal organ because of the khubate, khabiza and aromatic properties. It is also beneficial in the treatment of other ailments concerning the women's like leukorrhea, hysteria, etc. So again, zafran is the drug of choice for gynecological disorders. Kundur. So kundur acts as anti-inflammatory, anti-arthritis, apart from other activities like antimicrobial, antifungal, analgesic, because of the presence of the phytochemical constituents like triterpenoids. So kundur is basically it is used for healing of the wound as it acts as an antiseptic. Local use of kundur along with other astringent drugs in the form of the physaja is useful for uterine prolapse. Again, kundur is also effective if the patient is having stress urinary incontinence because a study was conducted in our institute on SUI and it was found that the marginal kundur was effective if the patient is having stress urinary incontinence. Kazimazich, that is mine kurd. Again, it acts as Habis, Rabi and Mujaffi. It is useful in Khuruj Raham, uterine prolapse, as well as leukorrhea. It is beneficial in leukorrhea orally in the form of sufuf and locally in the form of humul and abzin. Fumigation of Mayan Khurd is effective to regularize the menstrual cycles as well as in all types of inflammations, particularly Varme Barit. So if the patient is having the Varme Barit, Bukhure Mayan Khurd can be given because it is effective. Even it is helpful in tanning industry because of its high tannin content and also provide a coloring substances suitable for dyeing fabrics. Okay, so it can be used as a coloring agent also. Again, its bioactive constituents are almost the same. It contains again saponins, flavonoids, tannins, coumarin, shibeyamani. It acts as Habis, Musakkin, Habisuddam, Mujaffife Rutubad, apart from antiseptic and antispasmodic. So decoction with 6 mart of alum is used in rectal prolapse, uterine prolapse, and even its powder is sprinkled over the anus if the patient is having the anal prolapse. Douche with alum water is useful in pruritus vulvae, vulval irritations, leukorrhea, as well as to tighten the vaginal introitus following the delivery. It diminishes the secretion from blood supply to a part by constricting the small vessels and organic fibers. Thereby it is also helpful if the patient is having the leukorrhea. So therapeutically it is used in various disorders like leukorrhea, hematuria, hemoptysis, menorrhagias and other hemorrhages because of its Habis, Mujaffi properties. Tabashi. It acts as Habib, Mujaffif, Mubarak, Shadid, بفرغ قلب. It is useful in leukorrhea, spermaturia, breathing pains and diarrhea. Even it is also beneficial in sozish asha. What is sozish asha? Okay. Taskin atash. Yeah. Tabashiri is used in, I just want to see whether you are sleeping or not. Tabashiri is used in combination with other drugs in the form of Frizija in uterine prolapse. So when you observe the nuskha, rather than orally, they have recommended the local nuskhas, either in the form of pasari or absal or hukhna. Traditionally, babuna leaves, seeds and root are used as an astringent, laxative, diuretic, and the extract of show the astringent anti-inflammatory, anti-ulcer, antimicrobial properties because the presence of again the phytoconstituents like tannin, phenols, esterol, carbohydrate, etc. Tukhme tamarindi. So tamarindi acts as mulayyin taba, mujaffif, khabis, muhannid. And also it is useful if the patient is having laxity of the vagina like mosaic first properties. Thereby it is useful in atoning of the vagina, rectal prolapse and for constriction of the vagina. The tamarind juice basically acts as antimicrobial, anti-inflammatory, antiviral, antiseptic, astringent, antioxidant. It's a rich source of natural antioxidant and phenolic compounds like polyphenols, flavonoids and tannin. And the acidic taste of tamarind is basically because of the high concentration of tartaric acid in the various parts. So again, tukhme tamarindi can be used if the patient is having any sort of gynecological disorder, especially for uterovaginal prolapse. Let's do the conclusion of this talk. Pelvic organ prolapse is the common health problems affecting up to 40% of the Paris women over the 50 years of age with significant impact on the life of the woman. It is one of the three most common reasons for the hysterectomy in the USA, accounting for 15 to 18% of the procedures in all age groups, and it is the leading indication for hysterectomy, especially in the postmenopausal women. So the treatment modalities for POP includes both surgical and non-surgical techniques, which are associated with the morbidities apart from the complications and the drawbacks and side effects. The indications of the high-risk population could allow a focused modification of the risk factor such as obstetric events by recommending the delivery by cesarean section. A similar screening process including recognition of the levator ani defect could be followed pre-operatively to assess the risk of pelvic organ prolapse recurrence and the mesh complications. Herbal medicine is the mainstay of about 75 to 80% of the world populations for the primary health care, mainly in the developing countries. Because this is generally accepted that the herbal drugs are safe without any side effects, apart from being cost effective and easily available. WHO estimates the use of the herbal remedies throughout the world exceeds that of the conventional drugs by 2 to 3 times. So nowadays everyone is looking for the conservative management. Though in Unani system of the medicine there are reports of the many single drugs and the compound formulations for the pelvic organ prolapse having the properties of khabis, mujaffif and mukhawwir aham. In Unani system of medicine, effective treatment is available, but research was conducted on few Unani medicine, that too on the small number of the patients, with variation in the dosage and the duration of the treatment. Hence, future trials are recommended with a large sample size for the longer duration to prove the efficacy and the safety of the Unani medicines. Moreover, other treatment regimes can be implemented in day-to-day clinical practice as mentioned in the classical Unani text, followed by research study on the particular regime to prove its efficacy scientifically. Any doubts?
Can we use the Romania as you said in the Romanian
Huh.
can we use the Roman?
Yes, we have done the studies on the Rohan also.
Roman function is that way we are using the dry as
Where it was mentioned, you have to use only dry. So you mean to say that Rohan should not be used, is it? say that Rohan should not be used if the patient is having uterine prolapse, is it? I have mentioned from the beginning that even in the ancient period, the Hukmas has recommended to use the Rohaniyat.
इनका सवाल ये है कि जो रोगन दलाली करता है ना, यहाँ पे तो खबासे पैदा करता है। रोगन से सलाइवा वो और ज़्यादा हो जाता है कि हम जैसे
रोहन से पिसा जाता है. आप कितनी क्वांटिटी में यूज कर रहे हैं? हाउ मच द hormone required the रोहन?
अब अभी बोले ना हुमू के लिए 20 ml होना है।
21 is water, not the oil. 6 gram powder is dipped in 20 ml of water to make the solution, and then the tampon is dipped in these solutions and kept over the vagina.
And the variation अभी हमारी 30 ml में ये फिर मासूम मतलब जो आका किया जाता है उसको
See, Akhafia was a tested drug.
कोई रेफरेंस है
No, no, no.
डिकॉक्शन बनाया गया है। फिर उसको पानी में डाल
See, Akhafia, 6 gram of Akhafia was dissolved in 20 ml of water to prepare the hormone.
शबे हमारी 30 ml
Because it was tested drug. Akhafia was used as a tested drug in control. In that quantity only it was used. Shubhagamani, we have increased the dosage to see what will be the effect. Later, after the study only, we can able to conclude what was the effect of the drug. So, semi-solid
Yes, ma'am.
drugs. Huh?
Solid. Like it is used as a tampon, or like how it can be used?
Route of administration.
Yes, ma'am.
So, semi-solid drugs that can be used in the form of local hormone.
In the form
Yes.
of local only.
Yes, yes. Hmm.
में सॉल्ट विथ वाटर लिया था आब्जन के लिए, तो ये कहीं पे प्रूव्ड है क्या कि इसके साथ
No.
इसको ओके
No, there is no such proved. You only has you as a control.
तो एज अ प्लेसिबो यूज किया
As a placebo use किया. As a placebo.
Combined more than one
That is
drug,
true.
तो इट्स लाइक ज़्यादा हाबिस खाबिस इफेक्ट रहने की वजह से पेशेंट को जो कॉम्प्लिकेशंस रहते हैं, लाइक इरिटेशन ऑफ वल्वा या वजाइना, ज़्यादा हाबिस खाबिस होने की वजह से लाइक अल्सरेशन और समथिंग वल्वाइटिस, अगर ऐसा कुछ रहा तो
Ulceration. How does the ulcer may form?
effect of medicines can cause? No, madam.
इसमें एड ऑन ये आपको देखना चाहिए कि हमारे लिटरेचर में देखिए प्रूफ के जो लिटरेचर में दर्ज है उसको प्रूफ करने के लिए तो हम हैं। अब बार बार ये पूछना है कि सर ये प्रूफ है नहीं है, तो इसको इनोवेशन के तरीके से आप एक पैरामीटर सेट करते हुए आप डिफरेंट क्लिनिक्स पर हैं या हॉस्पिटल्स में हैं, वहाँ पायलट स्टडी के तौर पर आप इसको देख सकते हैं। मैं एक एग्जांपल शेयर करूँ, जैसे कि हमारे यहाँ ये जिक्र नहीं किया गया है कि आब्जन के लिए कितना पानी किस दवा में ऐड किया जाए, मतलब उसमें किया जाए, तो इस पर आप लोग अपना कुछ दिमाग का इस्तेमाल करिए कि हम किस तासीर की दवा को, किस दर्जे की दवा को कितना क्या इस्तेमाल करें। अंडरस्टैंड? अगर तीसरे दर्जे की दवा है या दूसरे दर्जे की गर्म खुश्क है, तो वो आपको एक आइडिया अपने आप से निकालना चाहिए। हम ये नहीं कि हमारे लिटरेचर में नहीं लिखा हुआ है या लिटरेचर में ये लिखा हुआ है हम ये करेंगे। मैं एलम वाटर का एग्जांपल आपको बता रहा हूँ। एक कैंसरस पेशेंट पे हमने मैम इसको यूज़ किया था, तो एलम उस पर स्टडी मैंने किया था आब्जन के तौर पर। तो जब स्टडी करने में आए तो ये देखने में आया कि एलम को 1 ग्राम वाटर के हिसाब से आप यूज़ कर सकते हैं, मतलब 1 ग्राम वाटर किसमें 1 ग्राम एलम इन 1 लीटर वाटर। तो 5 लीटर का हमने एक पैरामीटर सेट किया, 5 लीटर के हिसाब से हमने उसको ये रखा, सीट्स बाद जो कर सकते हैं। तो 5 लीटर के हिसाब से 5 ग्राम वो होना चाहिए शुद्ध। अंडरस्टैंड? जिसको हम कहते हैं क्या मुदब्बिर उसको मतलब
At the event, your insight and expertise made a significant impact. Now I request Professor Wajiha Begum ma'am to present a token of gratitude to Professor Isma Shamim ma'am. Ma'am has done BMS MD from Vijayawada University of Health Science. Ma'am has more than 120 publications in national and international journal and penned 5 books so far. Ma'am has been awarded with 11 awards. Ma'am has a member of many institutional committee. Ma'am, kindly come on the stage and share your profound insight on Unani perspective of anemia and pregnancy.
A very good afternoon. I hope in this session nobody will sleep. क्योंकि चाय भी हो गई है, हाँ? अब तो हक बनता है सुनना है बैठ के, है ना? So with this I wanted to start my presentation. So again I welcome all of you for this 6-day CME program in our institution 2024. So before going to start my program, I just wanted to give the information how the women health is important, why we should take care of. So women health is her capital. Women are the real architects of society. The true beauty of woman is in her health, in her ability to be active. Every woman should be in control of the decisions that affects her own health. A strong positive attitude will create more miracles than any wonder drug. So this is very important. If you understand this, so we can assess whatever the patient come, whatever will be the complaint, how we have to give the importance to manage that case. So before starting my lecture on my topic, just I wanted to go through these few guidelines which are very important. Usually we forget this. So in these guidelines, if we start following with each of the patient, especially when we come across in the first visit, so that is very important. It plays a major role in developing confidence with our patient, and we can keep the follow-up very comfortably, and patient will be with us till she recovers. So here assessment of patient, the clinical history and physical examination, as all of you know, we are doing. And here, as we are Unani doctors, so we should give emphasis on the assessment of misage of the patient. Because if we are able to assess the misage in the initial stage, so at the time of starting the management, so we will have the patient who have this misage and what drugs we are choosing, what formula we are choosing, whether it is suitable for her, that at least we will have in our minds, so that we can take decision very easily. Then immediate treatment plan, because as soon as the patient comes, अगर हम कुछ नहीं दे रहे हैं, कुछ इन्वेस्टिगेशन भी कर रहे हैं या जस्ट मिजाज एसेस करके हम भेज रहे हैं, तो patient will be not satisfied. So immediately we have to attend the problem for what she has come to us. Symptomatic, let it be symptomatic. Then along with that, we have to start the investigations for the suspected problem. What we are suspecting, what is our provisional diagnosis, and what we need to confirm with that. So start with that. With the symptomatic treatment, if you go with the investigation, even the patient will be satisfied कि कुछ दवा तो शुरू कर दिया है उन्होंने. Then confirmation of the diagnosis. Yes, once the reports comes and the response of the patient with our treatment and whether we are able to confirm the diagnosis, what provisionally we have made, that is very important here. Then change in the management as per the diagnosis. Yes, this is very important. Once we confirm the diagnosis, what we have started the treatment, we have done that, depends on the investigations and what the other assessment we have done. So we have to modify our treatment. Isn't it? Then only we can achieve our goal. Then as all of you know, after clinical examination, so many factors we have to consider here. जस्ट पेशेंट आया, अपना कंप्लेंट बताया, हमने दवाई लिख दी, हमने इन्वेस्टिगेशन लिख दिया, दैट विल नॉट fulfill our criteria for management. So we have to see in what age the patient has come, what is her problem, whether that problem is related with her age, that we have to assess first. Then sex, occupation, income, yes, even socio-economic condition will matter in many diseases, family history, personal history, and all this, whether they are reflecting on the clinical features, presenting clinical features, even that we have to assess here. Especially as you am telling, when we are going with female cases, usually considered with our department, here menstrual history and obstetrical history is very important. See, we should not make an habit कि the patient has come, कुछ symptoms बता दिया, हमने कभी सूरत भी नहीं देखते हैं, we'll write the treatment and we'll send. Many times it will happen and it is happening also. समझ गया? So that should not happen. See, the first visit is very precious time. At least we have to spend some time, at least 5 to 10 minutes with the patient, because if we are going with a gynecological examination, at least we need 10 to 15 minutes time. ऐसा नहीं कि 2 मिनट में एक चक्कर हुआ patient. So patient का satisfaction भी नहीं रहेगा. Even we are not satisfied कि we have not evaluated the case properly. So proper history is very important. That matters on the presenting complaint or the disease. Then regarding excess bleeding during menses, bleeding piles, lactating history, all will matter. Then we have to individualize the patient. ऐसा नहीं है कि सबको एक कैटेगरी में रख रहे हैं, है ना, कि हमारा कॉन्सेप्ट है हम सबको यही ट्रीटमेंट देंगे. No, that should not be done. Again, we have to individualize the patient depending on the history, depending on the clinical examination, depending on the family history, depending on so many factors. So that should be considered here. Then we have to individualize how to manage this. What is the best option of treatment for this specific condition, for this specific patient. So this is very important, we have to consider here. Then the very important point, little time for counseling the patient is very important. Until unless you won't develop confidence with your patient, with some counseling, they'll just listen and they'll go, they'll not take the medicine also. So they'll not follow you. So give time, ask her the problems, try to elicit what she's facing with, what factors are triggering this problem. If you are able to do that much, the patient will develop confidence in you. She feels so happy. Yes, our doctor is realizing my problem, my pain, my tension, she is realizing and she is giving me the solutions. Because with counseling, so many times at that time only we can use some solutions for that. So that should be developed, we should develop in our practice. So because that plays an important role in the management. Then when the patient believes in you, surely she listens to you and follows you. So this is very important, basic thing. Every doctor should have developed this habit. Then only हम अपने पेशेंट्स को कॉन्फिडेंस में ले सकते हैं. पेशेंट ढूंढ के जो आता है ना हमारे पास, चुप नहीं आता है. तो मैं एक बार ऐसे ही देख के भेज दो. Next time when she is not satisfied, she will go to some other doctor. She will come in some other OPD, isn't it? So this should be avoided. If you are sincere, even our patients will be satisfied. Okay? Then coming to my today's topic of discussion. So we'll have little, because it is a very important topic, very burning topic, because we need lot of concentration to manage these cases when she is pregnant or before conception or even postnatal period. Hence it is very important to consider this topic. So these are the contents of today's discussion. So to start with, iron deficiency anemia is the commonest hematological disorder that may occur in pregnancy. So here there is quantitative and qualitative reduction of HB and the circulating RBC, or sometimes both. So this condition presents when the hemoglobin concentration in the peripheral blood is 11 grams per 100 ml of or less. So this is the WHO criteria. अब हमारे पास तो 11 grams का आ गया तो we'll feel happy, hey, अच्छा है इसका HB, no problem. She can manage. But ऐसा नहीं है. अब हमारे पास कब अलर्ट होता है? 8.5 है, 9 है तो will alert. So that was not the good condition. It was the severe condition we have to consider. Then anemia is the most frequent derailment of physiology in the world throughout the life of a woman. See, I am not telling just pregnancy. It is throughout the life of a woman. जैसे एक लड़की मैच्योर हो जाएगी, वहीं से कहानी शुरू हो जाएगी उसकी. So we need lot of concentration on her health, so that in future when she becomes pregnant, married, or whatever the condition, she should face with a healthy atmosphere. So nowadays what we are observing, हम अपने बच्चों को क्या आदत डाल रहे हैं? क्या डाल रहे हैं? कुछ नहीं. खाना नहीं खाएगी, जंक फूड, बर्गर खा ले, पिज़्ज़ा खा ले, कुछ भी खा ले, नहीं मोबाइल में मुझे देखना है तो भी मोबाइल में देख, ना मुझे पकाना है ना तुझे खिलाना है. Is it it? Is it it? We should accept this. Is it not our negligence? Why this anemia is very much severe in pregnancy? Why we are not corrected in her adolescence age only? Is it it? Is it not our responsibility? आज तुम्हारे बच्चे हो या तुम्हारे पेशेंट्स हो, so we should give some concentration. See, she has come with some problem in her adolescence, so it is our duty to assess what is her general condition, whether she is facing with anemia or whether she is having balanced diet or her lifestyle is not very appropriate. So we would give concentration at that level only. Then only we are able to prevent in pregnancy and we can manage in pregnancy. ऐसा नहीं है कि pregnancy में आ गई हम manage कर देंगे. No. So we have to plan from the adolescence only. Then only we will be able to achieve the target during pregnancy. So here, as with this paragraph, causing an unfavorable status in respect to upcoming pregnancy, of which iron deficiency is the most widespread. Okay? Then, as per WHO, anemia, see, I will repeat few lines with few slides, so that should be related with those factors. Don't think why madam is repeating repeatedly. So few factors that will associate with that slide that we can understand well. So here anemia is defined as the reduction in the absolute number of circulating RBCs indirectly measured by reduction in hemoglobin or less than that. So at any time during pregnancy, as per WHO, any time, in the sense it can be first trimester, second trimester or third trimester. Then CDC defines, that is Center for Disease Control, defining anemia of pregnancy as HB less than 11 grams per dilution or hematocrit less than 33% during the first trimester and third trimester. As per CDC classification, they are considering 11 grams in first trimester and third trimester, and less than 10.5 grams or hematocrit less than 32 in second trimester. As per WHO, in all the 3 trimesters, they are considering like that. But here, in second trimester, it will become low. So that we have to give concentration there. Then, iron deficiency anemia is a composite diagnosis based on hemoglobin and ferritin concentrations. So, जब भी कभी doubtful हो रहा है HB, कभी एक लैब का कभी हम लोगों को सही बताता है, कभी कम बताता है. So, एक लैब का हम लोगों को लग रहा है कम, तो we have to repeat with second lab. If it is same, then we have to go for the ferritin levels also. Then this WHO has defined anemia in pregnancy as a HB concentration less than 11 irrespective of trimester, as I told in the first paragraph, but recognizes that HB may fall physiologically by around 5 grams per liter during the second trimester. So this is due to a rise in plasma volume of 50%, disproportionate to the concomitant 25% rise seen in red cell mass. So the prevalence of anemia in developed and developing countries in pregnant women is 14% and 51%. See the difference in developed and developing countries. So it is a project that India has the utmost prevalence of anemia, that is 57 to 96.2%. See the prevalence rate. It is ranging from 57 to 96.2. It is very high, especially among the South Asian countries. So the estimated incidence of anemia of pregnancy varies between 8 and 20%, largely dependent on the economic state of the measured population. Yes, this is the important factor, because in developing countries the low socio-economic condition will matter for this. And reporting up to 90% in some areas. See, in some areas it is specified 90% anemic. Then hemoglobin level of 8 milligram per dilution are found in nearly 10% of the pregnant population. Yes, we are seeing in our OPDs 8.5, 7.5, 8.8, like that so many cases we are able to see here. Then maternal mortality in selected developing countries ranges from 27 to 194 deaths per lakh live births. It is not very less. 194 deaths per 1 lakh is not just because of anemia. Okay? So however, many women are already anemic at the time of conception. This we have to accept. With an estimated prevalence of anemia of 43% in non-pregnant women in developing countries. See the percentage. Preconceptional anemic state, it is 43%. It is so high. So we need attention at that period only, isn't it? And 12% in wealthier regions. देखो ऐसा भी नहीं है कि in wealthier जो high economic है उनमें भी हो सकता है. So other factors are related with this. So the prevalence of iron deficiency is far greater than the prevalence of anemia, and iron deficiency often develops during the later stage of pregnancy, even in women who enter pregnancy with relatively adequate iron stores. Yeah. See, preconceptional period, she was with a good hemoglobin percentage. But once she conceived, it started deteriorating. Even that we have to consider. So coming to the epidemiology and etiology of anemia is a global health problem that affects approximately 1/3 of the world's population. 1/3 of the world population is suffering from anemia. So anemia affects roughly 2 billion people. In 2010, the year of life lived with disability due to anemia amounted for 68.4 million. See the percentage. An increase from 65.5 million in 1990. So during this frame, 1990 to 2010, the prevalence rate of anemia decreased from 40.2% to 32.9%, but more for males. Here again, see the awareness, more awareness. And as you know, in the school programs, they are supplementing iron, calcium, and midday meals. They are supplementing. So they are trying to reduce that percentage. So it has reduced to 60.5 million to 40 million. Although the cause of this disorder are different, including hemoglobinopathies, cause कुछ भी हो सकता है, micronutrient deficiencies such as folate, vitamin B12 and riboflavin, infections like schistosomiasis, parasites, acute and chronic renal infections, chronic kidney diseases. So here WHO estimates the iron deficiency accounts for 50% in all these cases. So in most instances, ADA occurs in areas with chronic malnutrition, because malnutrition is a very important factor that we have to consider here, because it ranges from 50 to 80%. Nevertheless, iron deficiency condition without anemia are also a common health problem in developed countries. See, without anemia, it is telling iron deficiency conditions without anemia are also a common health problem in developed countries, that is up to 20%. So the prevalence of iron deficiency may vary according to different conditions as it occurs with other nutritional deficiencies. Women and young children are more at risk of IDA. This disorder prevails in infancy 47%, pregnant women 42%, and women of reproductive age in 30%. So brief pathophysiology of iron deficiency and IDA in pregnancy. So here, to replace the demand of pregnancy on iron stores, the recommended daily intake of ferrous iron during pregnancy is 27 milligram, present in most prenatal vitamins, and 10 milligram during lactation in individuals without ovulatory suppression. Human studies have demonstrated that despite the biological process that aim to divert iron to the fetus, infants born to iron deficient mothers often have iron deficiency in infancy. ऐसा नहीं है कि mother was anemic, baby born healthy, कि baby won't have any problem. No, it is still when it was in the womb. So delivery के बाद in infancy they may develop deficiencies again. So this is because fetal iron is derived from the maternal iron stores. Iron is preferentially transported across the placenta to the fetus, even if this causes iron deficiency in the mother also. Some data suggests that teenage pregnancies are also at higher risk for iron deficiency, presumed due to increased maternal nutritional requirement for iron. So the majority of iron deficiency occurs in menstruating individuals, and as such many women are iron deficient at the time of conception. This we have to accept and we have to manage. For example, if newly married couple, they may come after 6 months or 1 year. First rule out, don't give emphasis on infertility. कि एक साल से बच्चा नहीं हुआ, 6 महीने से शादी हो गई, बच्चा नहीं हुआ. First see her condition. What are the factors that are associated with? If she is not conceiving, whether she is all right, that we have to rule. Whether she is anemic, first priority, because anemia is the base for all the problems, all the health issues. Then pregnancy further increases physiologic iron demand, as iron is preferentially directed to the developing fetus over the pregnant individual. So physiologically red blood cells mass expand approximately 25%, as I told, with a singleton gestation, while blood volume expands by 50%. So the greater expansion in plasma volume is typically reflected by a decrease in HB percentage. So anemia in pregnancy can be attributed to a expected dilutional effect. However, given the incidence of iron deficiency in pregnancy, there is a risk of iron deficient erythropoiesis that further worsens the anemia. So furthermore, there is additional total iron loss associated with pregnancy and lactation. This includes approximately 350 mg associated with fetal and placental development, 500 mg with expansion in red cell mass, and 250 mg associated with blood loss at delivery. So we have to balance this loss. So first we should understand iron requirement during pregnancy, how much it is required, and what are the causes for anemia in pregnancy. So as you know, if you are considering the causes, physiological anemia is usually there due to the volume expansion and the same. Then nutritional anemia, anemia of chronic illness, blood loss, hemolysis and hemolytic anemias, hemoglobinopathies, other hereditary anemias, and aplastic anemias. So we have to rule out all these causes, whether it is physiological or something else, that should be ruled out and corrected. So iron requirement during pregnancy we have to understand first. क्या requirement है for a fetus to grow? What is the extra need? Even though if she is with normal hemoglobin levels, and what extra supplementation she needs? क्यों हम normal जैसे कि 12 है, 13 है, फिर भी we will give the supplementation. We will give. There is a demand. There is an increased demand, isn't it? So iron is an essential element required by almost all organisms due to the indispensable role it plays in processes such as DNA synthesis, cell growth and differentiation, immunity, mitochondrial function, and response to hypoxia. So it is an important need for the growth of the fetus. Then iron requirement increases approximately 10-fold during pregnancy from 0.8 milligram per day in the first trimester, 7.5 milligram per day in the third trimester in order to support the increase in maternal red cell mass, sustain placenta and fetal growth and accommodate blood loss during delivery. So this is the requirement. So accordingly we have to give a supplementation. So for a normal case you have to give this much supplementation because tenfold demand is there. So we need proper supplementation. ऐसा नहीं कि patient is quite healthy, her HB is good, 12, 13, no problem. No, we can't live, isn't it? So this was the extra demand that we have to supplement here. The placenta requires around 90 milligram of iron and transports approximately 270 milligram of iron to the fetus over the course of normal pregnancy. So here now we should understand what are the risk factors, why she is anemic, and even though if her HB is normal, why she is going with deficiency. Okay, so here lifestyle factors, see vegetarian or vegan diets, diet low in heme iron or high in substances impairing iron absorption. So देखिए अब यहाँ पे हम लोग लाइफस्टाइल फैक्टर में so many factors we have to consider. अब बच्चों में ये आदत हो गई है कि उनके डाइट में they don't want to eat any vegetables also. ऐसा नहीं कि नॉनवेज ही खाना चाह रहे, नॉनवेज भी नहीं खाते, मुझे ये भी नहीं खाना है, मुझे ये भी नहीं खाना है, बस मुझे दाल का पानी खाना है, चावल खाना है, मिनरल खाना हो गया. This is there in many of the children. We are observing. कई पेशेंट हम आके बोलते हैं कि कुछ नहीं खाती है, तरकारी भी हटा देती है, गोश्त भी नहीं खाती है, वो भी नहीं खाती है, बस थोड़ा चावल खा के उठ जाती है. चावल खाना तो यहाँ का बहुत बड़ा ट्रेंड है. रात का भी चावल है तो खा लेंगे, रोटी नहीं खाएंगे, सब्जी नहीं खाएंगे, है ना. That's why the main reason women are so anemic here. Then patient factors. Yes, this is important. Previous anemia. Yes, if the patient is with the previous history of anemia and is used to take repeated supplementation or infusions and all, that should be employed here. Then malabsorptive conditions, especially IBS and any celiac diseases, that should be ruled out here. We have to ask how you will inquire with IBS. For example, you are suspecting कि हो सकता माल अब्जॉर्प्शन है, मैं खाती हूँ मगर फिर भी मुझे मतलब मेरे में इम्प्रूवमेंट नहीं आता है, मैं खाती हूँ फिर भी मुझे नहीं आता. सो व्हाट यू लास्ट फॉर? यस, सी जस्ट द पेशेंट टेल्स, मुझे जैसे ही खाती हूँ मुझे बाहर जाना पड़ता है, जैसे ही खाती हूँ आई विल पास द स्टूल्स. सो इट इज़ द इम्पॉर्टेंट साइन ऑफ IBS. उसके लिए एक बेहतरीन फार्मूला है, आप लोग अभी से सुन लीजिए क्योंकि आई मे फॉरगेट आफ्टरवर्ड्स. जस्ट आंवला, रुब्बे आंवला लीजिए, रुब्बे बेलगिरी लीजिए, फॉर एग्जांपल एक पाव किलो के हिसाब से ले लीजिए, उसके साथ 50 ग्राम सोंठ डालिए, उसको बीज निकाल के आंवला का अच्छे से बना लीजिए, उसका क्या बोलते जवारिश हो, माजून हो, जो भी को बना लो और उसको पेशेंट को 2 महीने करेक्ट कंटिन्यूसली दे दो. शी विल इम्प्रूव लाइक एनीथिंग, क्योंकि इवन उसका HB परसेंटेज भी बढ़ जाएगा. बिकॉज आंवला जब हम दे रहे हैं ना, दैट विल इम्प्रूव ए लॉट. एंड बेलगिरी बेहतरीन चीज़ है ABS के लिए, समझ में आया. सो दैट विल गिव लॉट ऑफ सपोर्ट. सो प्रिलिमिनरी अगर इफ यू आर एबल टू गिव दिस एंड करेक्ट हर होल हैबिट, सो आफ्टरवर्ड्स आप कुछ भी दो सप्लीमेंटेशन, दैट विल गिव गुड रिजल्ट्स. अगर हम ऐसा नहीं है कि तुम ये खा लो, ये ले लो, ये ले लो बोले तो खाती रहेगी, जाती रहेगी बस, है ना. We won't find any good results. So that we have to give more concentration. Then any known hemoglobinopathies that should be asked. Then Jehovah's Witness. So here it is nothing in the Christianity especially, they avoid blood transfusion. For even if they are very anemic, they don't want to take the blood. So this is one of the again risk factor. Then obstetric factors, multiparity, as you know. अब हमारे पास अब तो थोड़ा बहुत कंट्रोल में आ गया है, वरना हर साल हर 9 महीने में एक बच्चे की हिस्ट्री है जो 16, 18, 22, 11, 12 तो मामूल थे. अब तो नाउ इट हैज़ बहुत ज़्यादा फर्क आ गया है कि 3-4 के ऊपर बहुत कम सुनने जाते हैं, है ना. 2-3 तो एवरेज में आ गया है. So this we have to consider, and with proper gap giving is very important, and also that will play a major role in maintenance. Then multiple gestation, for example twins hai, yes, for example if you have twin pregnancy, you have to consider it as high risk, and you have to give more concentration, more visitations, you have to monitor more, isn't it, because the demand is high there. Then high risk of bleeding during pregnancy or during labor, yes, that we have to consider, antepartum hemorrhage में जा रहा है या कोई और complications में जा रहा है, that we have to understand here. Then short inter-pregnancy intervals, that is less than 1 year. थोड़े patients में मैंने देखा है, even 9 months she didn't had her menses only in between the pregnancy. ऐसी हिस्ट्री है कि they didn't had the menses for 3 children, in between they didn't had 9 months, every 9 months pregnant. So उनमें सब deficiency के chances तो बहुत ज़्यादा बढ़ ही जाएंगे, है ना. Lot of care is necessary there. Then coming to the clinical features, as well if you know, mild anemia is usually asymptomatic, because anemia के symptoms जब भी develop होंगे when it will become severe. तो anemia को assess करने का ऐसा नहीं है कि patient का condition देख ले, she is fine, she is not anemic, no. समझ रहे? Symptoms develop when it will become severe. So this we have to remember with every patient. Okay. Then moderate anemia, they will have weakness, fatigue, exhaustion, loss of appetite, indigestion, giddiness, breathlessness. बहुत जल्दी सुस्त हो जाती है, एक ही सिम्टम काफ़ी है. थोड़ा काम करती है, काले से आती है, सुस्त हो जाती है, थक जाती है. We have to rule out that. Then in severe anemia, they will come with palpitation, tachycardia, breathlessness, increased cardiac output, cardiac failure, pulmonary edema. See, this is the severe. ये जब तक आएगी तब बहुत परेशान होके आएगी. ठीक है. Other than that, we have to see for pallor, nail changes, chillosis, glossitis, stomatitis, edema, then hyperdynamic circulation, short and soft systolic murmur. देखो usually what we will do, anemia we will not bother to auscultate. That is the wrong thing what we will do or we will miss. So as soon as if you are thinking she is anemic, it is our duty to see, very precisely we can hear the murmurs. Make the practice. Otherwise ऐसा नहीं लगेगा कि anemia है बस उसका correction करो, हो गया. No, first assess. Okay. Then edema, yes, puffiness, edema that will be there. Then fine crepitations, yes, that's why I am telling, auscultate. अब हमको लग रहा है इसका HB परसेंटेज आ गया या नहीं, 8 ग्राम से 9 ग्राम से कुछ देख रहे हैं, बट वी विल नॉट बॉदर टू auscultate until unless मुझे खांसी है बोले तो पुस्तक पकड़ेंगे, isn't it? No. We have to see for this, because pulmonary edema will give a clue through fine crepitations. Clue towards, it might have not developed, it may develop, isn't it? So that you have to look for. Then जैसे समझ में आ गया, so screening, yes, screening of the patient is very important. क्या reason है? We have to evaluate what is causing anemia here, what are the risk factors, and how we have to evaluate, what are the parameters we have to look for. That should be. But here there is not a clear consensus on screening protocols. ऐसा नहीं कि ये प्रोटोकॉल फॉलो करें. It is not like this, isn't it? कोई ऐसा प्रोटोकॉल है कि सिर्फ अनीमिया के लिए डायग्नोस्टिक क्राइटेरिया बना है? No. So every case with every risk factors we have to evaluate accordingly as the patient presents. Or even the routine use of screening of iron deficiency in pregnancy, there is no clear consensus on screening protocol here. But few organizations support screening for isolated iron deficiency given the paucity of studies demonstrating risk ameliorating with treatment. So they develop, yes, हमारे पास पेशेंट आया तो we have to go for this protocol. हम ये सब करेंगे, अगर ये वैल्यूज अगर abnormal हैं, so further we will go for this investigations. Like that they will make the protocols. However, recently the United Kingdom officially recommended risk-based screening for iron deficiency in individuals with a state of anemia parity greater than or equal to 3, multiple gestation, inter-pregnancy interval that is less than 1 year, poor dietary habits, vegetarian or vegan diet, pregnant teenagers, those at high risk of bleeding during birth, or in individuals who decline blood products. क्योंकि these are the factors, isn't it? These are the important factors. So keeping in mind these factors, so depends on that, they'll make the criteria, what to evaluate, how to approach this case. So accordingly they'll make the criteria or the protocol in individual institutions like. So they recommend the diagnosis of iron deficiency be made using a serum ferritin of less than or equal to 30 microgram per liter until quality data suggests the use of an alternate cutoff. Then the United States Prevent Service Task Force has concluded that current body of evidence is insufficient to assess the balance of benefits and harms of screening to IDA in pregnant individuals to prevent adverse maternal health and birth outcomes. So counter to this, the American College of ACOG recommends screening for anemia in pregnant individuals and implementing universal iron supplementation to meet the iron requirements in pregnancy. So वही तो स्टैंडर्ड मेंटेन हुआ है कि यूनिवर्सल रिकमेंडेशन. Yes, as soon as first trimester ends, you have to start with the oral iron and calcium, isn't it? Then the only recommend assessment of iron stores in the setting of previously diagnosed anemia, serum ferritin has the highest sensitivity and specificity for diagnosing iron deficiency in pregnancy, but there is not a clear consensus on the ideal diagnostic threshold. ऐसा है कि in every hospital or every setup we are not going with serum ferritin levels. क्या हम कर रहे हैं हर पेशेंट के लिए? Whether we are going with serum ferritin levels in every case? No, सिर्फ HB पे डिपेंड है. HB जो भी वैल्यू मिलेगी will go accordingly. So here ferritin levels of less than 30 microgram per liter have been endorsed by ACOG as diagnostic for iron deficiency, while the WHO has suggested a cutoff of ferritin level of less than 15 microgram per liter, and others have suggested threshold as high as 50 microgram per liter. So these are the important points we should remember. ऐसा नहीं कि HB देख ली ले लो हो जाएगा. So some cases depends on the risk factors that are associated with. We have to consider the ferritin levels also. At that time only we can able to assure, because many times even from the beginning we are taking the case, we are seeing, we are able to maintain the HB percentage, and still why the patient will go in complications? Why complications in second and third trimester? Isn't it? So we thought, yes, she is healthy, no problem, just supplementation दे दो, चलता रहेगा. No, still why she'll lodge with PPH. Isn't it? So these are the factors that we have to correct from the beginning only. Then this is the evaluation. Actually now why it is important? What makes the deficiency difference? So because it has got maternal and offspring complications. थोड़ा कर ले. So important by iron deficiency. So here we have to consider the neonatal risk like low birth weight, small for gestation age, fetal distress, preterm birth. See, these are the very common problems that will associate with the deficiency. Then offspring waste, memory or processing disorders, intellectual disability, iron deficiency, then maternal risk. See, maternal risk, just consider if you are unable to correct properly, preterm labor is a major risk factor, then placental abruption, yes, APH, that's what I am telling, because anemia is the base for all the complications of pregnancy. If you are able to correct anemia from the beginning, if you are able to maintain, we can control many complications. So if you are neglecting, the patient may land up with any of the complications. Then severe PPH, preeclampsia, then if severe bleeding, if you are unable to control the PPH, they'll land up with hysterectomy. Then maternal shock, increased ICU admissions, maternal deaths. See, so much risk we have got, isn't it? See, it is with the neonatal, it is with the fetus, it is with the offspring risk. So this is the very high risk condition where we have to give more concentration. So here few things I wanted to explore here again. So the clinical, as the clinical signs and symptoms of IDA includes fatigue, we discussed, angular stomatitis, weakness, palpitation, everything. So they may also be present in NAID. What is this? What is this? PGs. सोचिए थोड़ा, होशियार हैं सब, हाँ? I'll keep this for you only. सोचिए, हाँ? Tomorrow, yeah, at the end of the presentation. So here observational studies have demonstrated an association between maternal anemia and mortality, with one study demonstrating a 29% linear increase in maternal mortality with each 10 gram per liter. Maternal ADA is a recognized risk factor for preterm labor, as we discussed, low birth weight and small for gestation babies. The baby's vascular health and iron in pregnancy, that is baby BIT, studies showed that maternal iron deficiency in the first trimester was associated with a twofold increased risk of having a fetus with small for gestational age. Then every 10 gram per liter decrease in maternal HB before 20 weeks gestation was associated with a 30% increase in the relative risk of SGA. See how the risk is increasing here. Then a systemic review of 48 randomized control trial, a total of 17,793 women and 44 cohort studies, a total of 18,51,682 women found that iron supplementation resulted in a modest increase in birth weight with a small reduction in the risk of delivering a low birth weight infant. So there was no evidence of an effect on gestational length, preterm birth or SGA infant. So postpartum anemia has been linked to depression, fatigue, impaired cognition, impaired lactation and early cessation of breastfeeding. So this is the important factors that we have to remember. It will not end to the pregnancy or the labor or the postpartum. Even it will have effect on the lactation, because cessation of lactation is a great loss for the baby. So if I am briefing here, so antepartum, they will end up with preterm, preeclampsia, sepsis and IUGR. Intrapartum, they will end up with uterine inertia, PPH and cardiac failures. So in postpartum, puerperal sepsis, subinvolution, pulmonary embolism, failure of lactation, delayed wound healing and cardiac failure. See the risk. So fetal effects, as we discussed, prematurity and low birth weight, IUGR, IUFD, increased perinatal mortality, poor mental performance or behavioral abnormalities in fetus. So this all will matter in each and every step. Okay, ऐसा नहीं है कि खत्म हो गया, pregnancy खत्म हो गया, no. Even the child will also suffer with this. So this is the same that I have discussed here. So diagnosis, see first of all
diagnosis is very important. Confirmation, isn't it? We have diagnosed, yes, patient is looking pale, she might be anemic. So we have to confirm that. So baseline what we'll go with hemoglobin measurement, peripheral blood smear to know the type of anemia, and reticulocyte count. What is the importance of seeing reticulocyte count? What is the importance? Why we wanted to go see the reticulocyte count? See, reticulocyte count, increase of reticulocyte count gives the response to your treatment. समझ रहे? So that's why even that we have to include here. Then hematocrit values, blood indices, stool examination for any occult blood or any other infections, worm infestations and all. Urine examination, for even that should be ruled out because repeated UTI is again one of the cause for predisposing anemia. Then proteins, LFT and RFT should be done. So here for the differential diagnosis with other causes of anemia such as hemoglobinopathies, infections in kidney disease, further investigations are needed, depends on the clinical features that are associated with that condition. So in particular HB electrophoresis or chromatography is indicated to exclude genetic disease such as beta thalassaemias. In case of megaloblastic anemia, vitamin B12 should be measured since vitamin B12 deficiency is a common condition. Folic acid deficiency anemia instead is less frequent nowadays. So this we have discussed. So coming to the prophylaxis. So there is a poor evidence about the effect of iron prophylaxis in pregnancy in determining a reduction of global iron deficiency prevalence and consequently a decrease of maternal and fetal complications. So see, this is still the evidence is not strong here. Still there is a poor evidence regarding the outcome with the deficiency in either the mother or the fetal. So therefore the risk and benefit of preventive iron supplementations are debated. The WHO promotes daily iron supplementation during pregnancy for women who live in areas with a high prevalence of iron deficiency because the administration of prophylactic iron in women with low iron stores represent a significant benefit. Nevertheless, iron prophylaxis is also used in industrialized countries. The right dosage for prophylactic iron supplementation is unclear. Current guidelines indicate 60 to 120 milligram elemental iron per day. So lower doses show no effect. Instead, dosage 120 milligram per day involves increase of unwanted side effects and consequently lead to poor compliance. So as all of you know, the therapeutic trial of iron dose, oral iron therapy usually will start with. So increase in reticulocyte in 5 to 7 days, that's what I was telling. So that's why reticulocyte count, observing is important. Then rise in HB at a rate of 2.2 to 4 grams per dilution every 3 weeks till normal. This we have to monitor whether we are able to achieve this increase or not. So if we are unable to achieve, think whether the supplementation is less or the absorption is not good or the patient is not responding for that. Then if no response or incomplete response, additional tests to be done. Then additional tests includes again the serum ferritin levels, TIC, that is total iron binding capacity, serum ferritin, saturation, HB electrophoresis, bone marrow examination also is needed in some cases. So see, first you are sending the case for evaluation, but you should have an idea what are the normal values. Until unless you won't have the idea, ठीक है, चल जाएगा, अच्छे से खा लो, उस पे हो जाएंगे. So if we know whether she is improving or not, we can able to assess properly. So here HB, we have to, if it is less than 11 grams, again the patient should be considered for proper management.
peripheral smear, microcytic hypochromic anemia, that should be corrected. MCV and MCSCR, if they are low. Serum iron level is low, less than 50 micrograms per dilution, and total iron binding capacity is increased, that is more than 400. These are the indicators. Then test for iron stores, serum ferritin, if it is less than 12 microgram per dilution, we have to be very careful and we have to keep the eye on proper follow-up and proper progress of the patient. So sustainable iron in the bone marrow is reduced, especially macrocytes on peripheral smear, hypersegmentation of neutrophils, pancytopenia, low HB and high MCE values, megaloblastosis on bone marrow, and serum folates less than 3 nanogram. These are the special investigations that will addressed if we are unable to achieve our goal in some of the patients. So now we should understand what are the rich sources, isn't it? समझ में आ गया अनीमिक है. अब हम पेशेंट को दवा भी देंगे, ग़िज़ा भी देंगे, तो हम लोगों को पता होनी चाहिए कि what are the rich sources, that is heme iron and non-heme iron. So heme iron is rich in animal food source. Part of heme protein attached to the iron occurs in oysters, red meat, poultry, beef, liver and fish. Absorption rate is high. Excess heme iron can cause health risk. Excess heme iron has got the risk here. So non-heme iron, they are of plant food source, do not contain heme protein attached to the iron, occurs in beans, nuts, lentils, green leafy vegetables, not well absorbed as heme iron. So it is not very good absorbed and does not cause health risk. वहाँ पे absorption ज़्यादा भी हो सकता है, problems भी हो सकते हैं. So non-heme iron is safe. So these are the rich sources, these are the points we have to remember. Why vitamin C is important here? Yes, it motivates absorption, it promotes absorption, isn't it? So vitamin C हम किस रूप में देंगे? क्या vitamin C tablets दे रहे हैं क्या हम प्रेगनेंसी में? नहीं, whether what the supplementation we are giving, whether that contains vitamin C? So what I am asking, we are giving calcium and iron regularly. Whether we are addressing whether that is associated, the content is with vitamin C? Yes, no, that's why the time gap will give morning when the iron if we are giving, evening we are giving. Regarding vitamin C I am asking. So that's why we have to encourage to our patients with the food. क्योंकि जैसे उनको कहेंगे कि आपको हर दिन एक ऑरेंज खाएंगे, तो सिर्फ विटामिन सी बोले तो नहीं मानेंगे. उनको कहेंगे कि तुम्हारा बच्चा बहुत गोरा होगा, बहुत हेल्थी होगा, so she'll be happy. समझे? बस उनको बस थोड़ा ट्रिकी बोलना है कि देखो अगर हर दिन एक ऑरेंज खाएंगे, एक एप्पल खाएंगे ना, आपका बच्चा इतना हेल्थी होगा, इतना अच्छा होगा, surely she takes. अगर तुम खा लो माँ अच्छा रहता बोले तो नहीं खाएंगे वो. ठीक है? टोमेटोस है, लेमन है, मौसम्बी, लाइम जूस, आंवला, कैश्यू नट्स, ये सब तो फ्रूट्स हैं, वेजिटेबल्स हैं, सो मेनी. अब उनको थोड़ा ऐसा बोलना है कि आपके डाइट में फ्रूट्स और वेजिटेबल्स ज़्यादा ऐड होनी चाहिए. सो विद दैट वी कैन हेल्प हर बाय सप्लीमेंटिंग द विटामिन सी आल्सो. सो फॉलिक एसिड डिफिशियंसी तो पहले तो पर्निशियस एनीमिया के नाम से देखा जाना जाता था. सो दिस विल को एग्जिस्ट विथ आयरन डिफिशियंसी एनीमिया. So because if it is a folic acid deficiency purely if it is there, we need to go for supplementation, extra supplementation, otherwise the patient may have other problems. So because this folic acid deficiency, if you are unable to fulfill properly, they will have the other problems. So that we have to address here. So folate is essential for normal growth and development. This we should understand. So
by advising all this, she'll get that supplementation. So this iron bioavailability, because food preparation is the key. अब हमारे पास a lot of practical things we are forgetting what our ancestors were doing previously. So देखिए फूड प्रिपरेशन में टाइम एंड टेम्परेचर, अब पका रहे हैं कुछ भी डालो, सीटी डालो, 4 सीटी डालो, 5 सीटी डालो, इधर कुछ काम करने तक आ जाए, उसमें कितना अवेलेबिलिटी है या कितना न्यूट्रिएंट मिल रहे हैं, कितने गारत हो रहे हैं, हम लोगों को नहीं पता है ना, डूइंग नो। हाँ, पहले देखिए तांबे के बर्तन में पकाया जाता था, तांबे के बर्तन में पकाया जाता था, तांबे के बर्तन में पानी रखा जाता था, तांबे के बर्तन का पानी पिया जाता था, तांबे के लोटे में पानी मिलता था, है ना। तवा लोहे का तवा आयरन का था, आज तो नॉन स्टिक लेके पलट रहे हैं, थोड़े केमिकल्स भी खिला रहे हैं साथ साथ, इज इट नॉन स्टिक। अब वो नॉन स्टिक उबल के कितना केमिकल्स हमारे फूड में आ रहा है, वी कैन अंडरस्टैंड बेटर, ठीक है। सो फ्यू थिंग्स वी हैव टू फॉलो हियर। अब देखिए चावल बना रहे हैं, चावल के अब कई घरों में ये बनता है कि चावल इतना पानी डाल के उबलते, पूरा पानी फेंक देंगे, पी को दम करके खा लेते, व्हाट दे आर गेटिंग। अब सब्जी है, सब्जी को उबाल रहे, कभी सब्जी का पानी फेंक भी देते, फिर उसको सूखा सूखा बना लेते, व्हाट वी आर गेटिंग, इज इट। तो हमको क्या मिल रहा है, हमारे बच्चों को क्या मिल रहा है, इज इट। सी सो मेनी थिंग्स वी आर नेग्लेक्टिंग एक्चुअली। Even after knowing everything we are not doing properly. If we are able to follow everything, ये सब इतना डिफिशियंसीज में, पहले इतना डिफिशियंसीज की बात कहाँ थी। हमारे पेरेंट्स की अगर हम हिस्ट्री देख रहे हैं तो उनका लाइफस्टाइल और उनका काम और उनका खाने पीने का ढंग, उनकी चीज़ों का इस्तेमाल, सो देयर इज लॉट ऑफ डिफरेंस देयर, ठीक है। So cooking of cereals and pulses was shown to cause a loss of 22 to 24% of their iron. Just think, अब जो हम बना रहे सही तरीके से जो नहीं बन रहा, हम कोई चीज़ थोड़ा उबाल के खाना है, उसको उबाल के डाल रहे हैं, तो वहाँ पे लास्ट 22 to 24% आयरन लॉस हो रहा है। So what we are getting? Nothing, isn't it? So however, baking chapati on an iron plate raised the iron content by 90%. 19% रेस आयरन कंटेंट मिल रहा है लोहे के तवे पे पकाने से, बट हमको अच्छा नहीं लगता वो तवे पे रोटी बनाना। ये नॉन स्टिक में तो बहुत इजी रहता, लगता नहीं, चिपकता नहीं, उसका केमिकल्स थोड़े लग जाते, खा लेते, हो गया खत्म। देन फर्मेंटेशन कैन डिग्रेड द फाइटेट एंड इंक्रीज द बायोअवेलेबिलिटी ऑफ आयरन in bread made from whole wheat flour. Household process such as germination, malting of grains or pulses and fermentation should be used to overcome phytates and enhance the ascorbic acid and B vitamins. So amount of potentially available non-heme iron, adjustment to fortification iron and contamination iron. So these are the few basic things that can easily be done with every house, every home, every mother, isn't it? तो आज हम ही मौका दे रहे हैं बच्चों को एनीमिक होने के लिए, प्रेग्नेंट सीमे एनीमिया का जो बड़ा इश्यू बनाए हुए हैं, वी आर रेस्पॉन्सिबल फॉर दैट। So here few factors that are affecting bioavailability. So few are enhances. So here meat, fish, poultry items, acidic food, fruits, vegetables, fermented vegetables, if we are adding in our food, that will enhance the bioavailability, whereas this coffee and tea, especially iron absorption is affected less by coffee than tea. तो पेशेंट को गोली खाते ही चाय पीना होता, चाय के साथ गोली पीते हो, है ना, चाय के साथ गोली पीते, तो वी हैव टू एड्रेस कि चाय बिल्कुल नहीं पीना है, ठीक है। तो एटलीस्ट 1 आवर गैप का हम लोगों को एडवाइस करना है कि 1 घंटा तो एटलीस्ट गैप दे के पियो, वरना तुम्हारी दवा खाना कोई मतलब नहीं। देखिए अब हमारी वी आर ऑब्जर्विंग इतना सप्लीमेंटेशन देने के बाद भी वी आर नॉट अचीविंग गुड रिजल्ट्स। वाई? माल एब्जॉर्प्शन, आई मीन एब्जॉर्प्शन ही नहीं हो रहा है, इट इज गोइंग इन ए रॉन्ग वे, इजंट इट? Then cocoa, certain spices, certain vegetables and most red wines, they are inhibitors. देख रहे हैं, अब कोका कोला पीने की तो इतनी ख्वाहिश, इतनी हैबिट है, ओहो वो पी ले तो डाइजेशन अच्छा हो जाता, बस खत्म, सब पूरा डाइजेस्ट होके चला जाता, वो नहीं मालूम है, ठीक है। देन वेजिटेबल्स लाइक स्पिनच है, बार्ब है, स्वीट पोटैटोज, होल ग्रेन्स, देन and calcium, that is simultaneously they are going with milk and cheese, then isolated soya ingredients, so they are the inhibitors, समझ रहे? So this you have to remember, and you have to, and here one important point is the iron status of the individual and other host factors such as obesity and medical problems like malabsorptive disorders, what we have discussed, celiac disease, Crohn's disease, and those with history of gastric bypass surgery interferes with iron absorption. So this history we have to elicit. That will play a key role in iron availability, and iron status generally has a greater effect than diet composition. So these are the important छोटे-छोटे points हैं. अगर if we are considering, I think we can help the patient more. If we are making them aware, awareness is very important. देखो जब तक पेशेंट को हम नहीं बताएंगे नहीं चलेगा. हाँ, पेशेंट को एक बार ओपीडी में बता देंगे भी तो नहीं चलेगा. We have to conduct awareness programs. We have to emphasize all these factors. We have to explain them. Then they will understand. ऐसा नहीं है कि जो प्रेग्नेंट है वही समझेगी वही करेगी. उनके फैमिली मेंबर्स को भी देंगे तो even at least some or the other time they'll interfere. They'll ask, they'll tell, yes you have to go with this, you shouldn't do this. We can help in that way. चलिए, now the recent millets during pregnancy is very important. अभी बहुत चल रहा है, 2023 से तो बहुत ज़्यादा ही चल रहा है millets का. So it is important also, isn't it? So iron, biofortified millets contain higher concentrations of iron. Hence iron levels in this type of millet reaches 90 ppm, that is parts per million, whereas levels in non-biofortified millets are around 20 ppm. See the difference, कितना ज़्यादा फर्क है. Several studies indicates that regular intake of biofortified millets can be efficacious against iron deficiency. So biofortified pulses containing 100 ppm or more have the highest concentration of iron. So several studies have examined the bioavailability or efficacy of iron in biofortified beans consumed in developing countries. Though phytic acid is present in beans, a high proportion of the iron is contained in phytoferritin. Iron from ferritins has been shown to be highly bioavailable. So millets का importance बहुत ज़्यादा है. एंड वी हैव टू एनकरेज दिस. अब तो हर दुकान में मिलेट्स तो जुड़े हुए मिलते हैं, ऐसा नहीं है कि पहले ढूंढना पड़ता था, अब ऐसा नहीं है, हर दुकान में आसानी से मिल जाएंगे. सो ए पर्ल मिलेट वेराइटी वाज स्टडीड अमंग 12 to 16 years adolescent girls consuming 200 to 300 grams of pearl millet during lunch and dinner for 4 months. That revealed the following difference. There was no difference in HB में फर्क नहीं पड़ा, but ferritin levels were increased significantly. See the difference. हम HB नहीं मिला, चलो कुछ फायदा नहीं है, कुछ भी खा लो बोल देते हैं. No. So positive impact on cognitive function. This is very important. So this is the importance we have to show to our patients. To conclude, overall intake of iron from iron-rich food together with vitamin C needs to be increased to obtain the optimum level of recommended dietary allowance of iron. This decrease should be merged with efforts to curtail appropriate food in the diet to enhance the bioavailability of iron and reduce inhibitory factors. The inhibitory factors that should be considered here. Even without the heme iron found in fish or poultry, vegetarians are not a greater risk from iron deficiency than non-vegetarians. Cereals and millets, pulses and legumes, green leafy vegetables, nuts and oil seeds are good sources of iron. So dietary consumption of iron and ascorbic acid should be increased by encouraging the production, processing, marketing and consumption of food rich in these nutrients. So vitamin C rich food must be consumed as the same meal that contributes the major part of daily dietary intake. So this is the conclusive point. We have to add on vitamin C here. Then nutrition education could be a mean for further promotion of dietary iron.
So इसीलिए ना the government has motivated so much for marketing and growing everything. It has given the more importance for the millets in all the ages of life, not only in pregnancy. ठीक है? So now first how to avoid? Yes, first avoidance, prevention. समझ रहे? So how to avoid anemia? Yes, avoid child marriage. Yes, below 18 years. Now it is coming to 21 years. समझ रहे? Now it is coming to 21 years. We have to avoid marriage up to 21 years. Then avoid frequent childbirth. Yes, minimum interval of 2 to 3 years is important. Not like immediately they will conceive, within 1 year they will conceive. And a realistic balanced diet is very important. Balanced diet is very important, which is rich in iron and proteins. देखिए balanced diet जो हमारे होटल्स में मील्स का तट्टा मिलता है ना, that is the balanced diet. जो हम लोगों को कितना समझ में आता नहीं मालूम, जो मील्स जो हर चीज़, हर सब्जी, हर चीज़ रख के जो देते हैं ना, एक्चुअली दैट इज़ द बैलेंस डाइट. जो हम सिर्फ एक रोटी बना लिए, एक सब्जी बना लिए, खा लिए, हो गया खाना, बहुत अच्छा नाश्ता हो गया मेरा. आज मैंने कलीजी का सालन खाया, मेरा नाश्ता अच्छा हो गया. सो दैट विल नॉट गिव टोटल बैलेंस, इजंट इट? सो यू हैव टू मेक द हैबिट कि रॉ वेजिटेबल्स, कुक्ड वेजिटेबल्स, फिर ग्रेन्स, स्प्राउट्स, लाइक दैट वी हैव टू ऐड इन अवर डाइट. तो तट्टा बनाना शुरू करो, तो चावल कम हो जाएगा, ये तट्टा पेट भरेगा और फायदा भी देगा. ठीक है? देन eradicate hookworm infestation. See, this is very important. See, this we have to rule out. कई बार ऐसा होता है कि हम अनजाने में अपना ट्रीटमेंट दिए जा रहे हैं, will not make out what is happening there. So that should be ruled out first. If you have started the treatment, the patient is not responding in 1 or 2 months, we have to rule out all these things. और कभी भी अनीमिया ट्रीटमेंट जब भी स्टार्ट करते हैं ना, फर्स्ट डीवर्म, फर्स्ट डोज डीवर्म, उसको दवा दूसरे दिन शुरू करना है, आज डीवर्म करना है तुमको. देन टुमारो यू स्टार्ट द मेडिकेशन. सो दैट विल हेल्प ए लॉट. समझ रहा? ऐसा नहीं है आ गए दे दिए ले लो खा लो चलो, कुछ नहीं होगा. देन ट्रीट ब्लीडिंग पाइल्स. या यानी ब्लीडिंग हिस्ट्री. अब देखो यहाँ पे सिर्फ पाइल्स की बात है, हाँ, बिकॉज वी आर डीलिंग विथ प्रेगनेंसी. अदर देन दैट प्रीवियस हिस्ट्री ऑफ HMB, that this all will matter. Okay. Then prevention. So here again the same dietary advice and modification, iron supplementation in adolescents. This is what I wanted to tell. Correct anemia in adolescence itself. Don't allow her till pregnant. समझ रहे? Then treatment of hookworm, then iron deficiency, iron supplementation in pregnant women, food fortification and ANC for early recognition. Yes, because early recognition, जैसे as soon as the patient reaches to, so immediately you have to evaluate, check her hemoglobin levels and ask her for previous values if she knows. Then start the treatment properly. Then strategies for prevention and control of iron deficiency anemia. It is again for the food-based strategy, supplementation and improved health service and sanitation. Then food में dietary diversification and food fortification. This is a brief summary. Then management, as you know, oral iron therapy, prophylactic iron therapy, 100 milligram elemental iron daily with 500 megagram of folic acid, deworming of all anemic patients, treatment of anemia, 200 milligram of elemental iron, folate, 5 milligram per dilution. So this is the oral supplementation. So iron requirements, see again I am just repeating this in brief. So 2.5 milligram per day in early pregnancy, 5.5 milligram per day from 20 to 32 weeks and 6 to 8 milligram per day after 32 weeks with an average of 4 milligram per day. So this is the need, this is the requirement, additional requirement. Okay. Then side effects, yes, we should remember this. Many a times the patient comes with some or the other side effects and they will not tolerate also.
and at that time we need to go with some alternate supplementation. So usually the side effects will be nausea, vomiting, constipation, abdominal cramps, diarrhea. So this will be treated with some corrections, some food corrections that will be managed. If at all they comes with severe reactionary this thing, immediately we have to stop here. And now you have to understand what are the reasons for failure to response. This is very important. First, non-compliance. So what we are giving, how she is taking, whether she is maintaining with proper this thing, that will matter. That is non-compliance. Then concomitant folate deficiency, then continuous loss of blood through hook infestation or bleeding hemorrhoids, any coexist infections like UTI and all, then faulty iron absorption, inaccurate diagnosis, then non-iron deficiency macrocytic anemia. So these are the reasons to failure to respond, and even this should be assessed. If we are not achieving our goal, we are not achieving, if the patient is not improving, then we have to think of all this and we have to rule out this. Then parenteral iron therapy, as you know, if they are unable to tolerate or if they are with very low levels, then we need to go with parenteral iron supplementation. So that indicates when the pregnant woman is unable to take iron supplements due to side effects, or its main advantage is certainty of administration. Raise in hemoglobin is similar to that of oral iron, that is up to 1 gram per week. Then available preparations and dosage. So as you know, iron sucrose is there, iron citrate, sorbitol is there, iron dextron, IM or IV we are giving. So it depends on the patient response and the hemoglobin levels. And because sometimes even in early pregnancy also we may need to go for supplementation in many of the cases. But usually we will find in 3rd trimester. So at that time immediately we have to correct, we have to go with the infusions, and proper improvement should be achieved till the patient goes in labor. So these are the supplementation we can recommend to our patients, and even the vitamin C. Yes, if the patient is anemic, management is in labor is again a task. So here अब पता है हमको anemic है, and sometimes patient will not cooperate and directly they will come with 9 grams, 8 grams and all. So at that time you must be very much vigilant and here make the patient comfortable. ऑक्सीजन ऑक्सीजन ऑक्सीजन, क्योंकि वहाँ पे जैसे लेवल कम होगा, ऑक्सीजन डिफिशिएंसी रहेगा, तो हम लोगों को इंटरमीडिएट ऑक्सीजन देना पेशेंट के लिए फ़ायदेमंद है, क्योंकि एट दैट टाइम हम कुछ भी इमीडिएट ट्रांसफ्यूजन और इंफ्यूजन वी कांट गो विद दैट. देन सेडेशन एंड एनाल्जेसिया, प्रिवेंट कार्डियक फेल्यूर. यस, सीवियर अनीमिया will be a major complication at the time of labor as cardiac failure, even during labor and even in the postnatal period. Okay, then aim to deliver vaginally, antibiotics should be covered. Then cut short the second stage. This is very important. Cut short the second stage of labor. Then active management of third stage of labor, because the risk of PPH, intrapartum hemorrhage, APH, all H will be here, APH, IPH and PPH. So that is should be considered here. So this is the total outline. I have briefed up a lot here because for a short time. Now we will have Unani, the concept, isn't it? So अब तो ये तो अच्छे से समझ में आ गया होगा. अब यहाँ पे थोड़ा देख लेंगे कि हम क्या क्या कर सकते हैं, है ना. हम यूनानियंस, हम अपनी थेरेपी को लेके हम क्या क्या कर सकते हैं. So anemia, as you know, is termed as soulfenia. हर कोई जानता है. So it is also termed in various Unani definitions as खिलतुद्दम, फसाद-ए-मिजाज, खून की मोहताजी, फसाद-उद्दम and खून की तबाही. So ये सब अल्फाज में जिक्र किया गया है जहाँ पे अनीमिया रिफ्लेक्ट होता है. So khinia means पूंजी, the reservoir. Sulfenia abnormal. समझ रहे? Then sulfenia means alteration in the reservoir of blood. ये देखिए मैं ये यूनानी कॉन्सेप्ट के मैं डेफिनेशंस बता रही हूँ जो यूनानी बुक से हैं.
Then according to Razi, due to altered temperament of liver, causes insufficiency of the liver leading to anemia. Because as you know, many of the diseases, the main concept and the target organ will take as liver, isn't it? सिर्फ अनीमिया के लिए नहीं है, कई हमारे बीमारियों में the main target organ is anemia. If you are able to correct liver, we can correct the other problems, isn't it? So we have to give more focus on liver correction. समझ रहे हैं? Then pica is one of the cause of for anemia. Yes, pica के तो examples इतने अच्छे example हैं. Recently I come across one very still unique example. Some girl came in adolescence age. अब तक सुनते थे पेपर खाते हैं, चाक पीस खाते हैं, क्या है ईंट खाते हैं, सीमेंट खाते हैं, सब सुना था. So अभी recently we had one case. कौन है मेरे स्टूडेंट हुए हैं? तो वो एक स्टूडेंट आई थी, पता है मिडनाइट शी विल गेट अप, आइस फ्लेक्स वो फ्रिज में रखे होते हैं ना 3-4 ट्रे, बैठ के चबा के खाती है, बैठ के चबा के खाती है 3-4 ट्रेस. पता है, यू जस्ट इमेजिन, आई हैव नेवर हर्ड ऑफ दिस, कि चलो कभी कभार आइस मुंह में डाल लेता हूँ, दिस डिफरेंट, बट बैठ के चबा के खाती है. एंड हर हस्बैंड इज वेरी लो एंड शी इज़ वेरी लीन, एंड यही रीज़न से बहुत परेशान होकर उसके पेरेंट आए थे. शी वॉज नॉट टेलिंग, एट द एंड बहुत ज़्यादा काउंसलिंग के बाद शी एक्सपोज कि मैडम ये ऐसा आइस मिडनाइट में उठ के खाती है. वो खाना ज़रूरी है उसको, वरना बेचैन होती है. तो देन वी थॉट, बिकॉज दिस इज़ द फर्स्ट टाइम आई हर्ड कि आइस का भी विल हैव दिस सॉर्ट ऑफ, खाना नहीं पसंद उसको. Then we took that case, we have started the treatment and थोड़ा काउंसलिंग करना पड़ा बच्ची को, अच्छा कॉन्फिडेंस पे लेने के बाद she has stopped. बोली अगर मैडम मुझे कुछ ज़्यादा हो तो मैं ठंडा पानी पी सकती हूँ. बोली तुम पी लो, ठंडा पानी पी लो, मगर ऐसे नहीं छाड़ना है. So 1 महीने के ट्रीटमेंट में lot of difference has come in that. Now she started taking proper food and her mother was happy. मैडम हम बहुत परेशान थे इसका कैसा होगा ये चीज़ से, क्योंकि हर कोई ट्राई कर रहा था, फैमिली मेम्बर्स कुछ भी कर रहे थे. शी वॉज नॉट एक्सेप्टिंग इट सीम्स, बट अल्हम्दुलिल्लाह शी इज़ फॉलोइंग नाउ. तो मतलब ये भी हो सकता है, समझ रहे हैं? अब ये तो सब सुने थे, चाक पीस खाते, कोयला खाते, मिट्टी खाते. मिट्टी का तो प्रेगनेंसी में बहुत ज़्यादा जिक्र है, लाल मिट्टी खाने का. हाँ, चॉपीस नहीं चॉपीस एंड ऑल एवरीथिंग अदर टाइम खाते हैं, मगर प्रेगनेंसी में मिट्टी खाने का बहुत ज़्यादा होता है. पिका मिट्टी समझ रहे हैं? लाल मिट्टी खाते हैं, स्पेशली लाल मिट्टी. Then edema due to anemia is the result of altered temperament of liver. He recommends treatment with muqayyat and goats. ये हमारे बुक में जो लिखा है, just I am briefing up. So according to Alcina, excessive soda produces anemia by stagnating in between the liver and stomach. This interferes the normal production of blood and other minerals. So Al-Majisi has told anemia is the result of हुवते मौलिद खून, मतलब की कमी, हुवते मौलिद खून की कमी के होते हैं, which is the cause of hepatic coldness due to slow misaj jigar, which alters the hemopoiesis. Then डोमिनेंसी ऑफ बरूदत पे भी है. देखिए यहाँ पे सौदा की भी जिक्र था और यहाँ पे बरूदत की भी जिक्र है. सो लिवर विल नॉट बी एबल टू अकॉम्प्लिश हेमाटोपोइसिस, हार्म एंड फासिड ब्लड इज सर्कुलेटेड टुवर्ड्स द ऑर्गन विच द ऑर्गन वुड बी इनकेपेबल ऑफ यूटिलाइजिंग. देखिए उनके ऑब्जर्वेशंस देखिए आज हम सब कुछ डायग्नोस करना आसान समझते हैं, and with just their observations how much they have assessed at that time. तो आज हम लोगों को भी थोड़े observations ऐड करना चाहिए. ऐसा नहीं है कि वो करे थे हम डायग्नोस करेंगे दे देंगे, नो, इवन वी शुड ट्राई अवर बेस्ट. हम कुछ अपने नए नुस्खे लाएं, कुछ नए ऑब्जर्वेशंस लाएं, कुछ नए एडिशंस लाएं, तभी तो ग्रो होगा ना सिस्टम, है ना? इफ़ यू आर लिमिटिंग टू दैट, उन्होंने कहा था हम ये कर रहे हैं, हम यही करेंगे, दैट विल लिमिट द सिस्टम. सो हम लोगों को भी
कुछ नए आइडियाज लाना चाहिए कोई भी मैनेजमेंट।
सो ये तो मिजाज की बात है, विल स्किप दिस। सो इसमें तो होते जाजिबा, करोल, मासिका, हाजिमा, दाफिया, ये सब रोल तो समझ सकते हैं। I think we'll go with some research point of some other discussions. ये सब तो आप लोगों की बुक्स में भी मिल जाएगा, ठीक है। अब देखो यहाँ पे etiological factors में just read the headings. अमराज़ कभी मेजर etiological factor consider किया है, अमराज़ कभी, then gastrointestinal disorders, then renal disorders, genital disorders, then chronic infections, because see many they are correlating with the modern concept also. ऐसा नहीं है कि वहाँ पे अलग है यहाँ पे अलग है, isn't it? देखो लीवर जो टारगेट ऑर्गन हम जो बोल रहे हैं ना, क्या मॉडर्न पीपल दे आर नॉट डूइंग दैट, इवन दे आर कंसिडरिंग द लिवर एज द टारगेट ऑर्गन फॉर मेनी डिसीजेस। देन सिम्टम्स एंड साइंस, सेम थिंग यहाँ पे लिखा हुआ है। So many they are related to the modern medicine only. Pallor है, puffiness, gingivitis, cracked lips, then indigestion, altered bowel movement, सब सभी वही चीजें हैं। ऐसा नहीं कि बहुत ज़्यादा है, excessive flatulence, oliguria, delayed healing of ulcers, palpitation, मगर सारे वही हैं। ऐसा नहीं है कि हम अब कभी बच्चे परेशान हो जाते हैं एग्जाम हॉल में बैठ के लिखते लिखते, तो मॉडर्न तो आ गया, मुझे यूनानी क्या लिखना है नहीं समझ में आ रहा है। अगर थोड़ी अकल इस्तेमाल करेंगे ना, उसी को ट्रांसलेट कर देंगे तो यूनानी हो जाएगा, है ना। सो एडिशनल सिम्टम्स डिपेंड्स ऑन द सूजन, झार, बारी, रतब, जो भी है एडिशनल सिम्टम्स विल एड ऑन दैट, जो पेशेंट का मिजाज है, मिजाज के हिसाब से दो सिम्टम्स विल एसोसिएट विद दैट कंडीशन। चलो, तो कॉम्प्लिकेशन में इन्होंने अच्छे से लिखा है, द पेशेंट में अबार्ट, यस, अनीमिया, अनीमिया का फर्स्ट ट्राइमेस्टर अबॉर्शंस ड्यू टू अनीमिया इज मोर कॉमन हियर, एंड अनसार का। चलिए विल कमिंग टू द उसूल इलाज, दिस विल डिस्कस। सो इम्प्रूवमेंट ऑफ डाइजेशन एंड एपेटाइट इज इम्पॉर्टेंट विद आयरन, देन द ब्रीथ इज contraindicated in patients with edema and this thing of extremities, then avoid facet, mucil and area and nuclear drugs during pregnancy to prevent abortion. देखिए नहीं देना है, ये नहीं देना है, ठीक है। Then use of मुखिया, मैदा and जिगररिया is important. Removal of underlying cause, yes, any risk factor or any cause that should be corrected. Then tadabir to stop the production of uzla. चलिए उसूली इलाज, see this is very important here. We have to find out the cause and we have to treat the cause. Nutritious and easily digestible food to be given. Regular exercise and bath to be advised. Stop the hemorrhages if any hemorrhoids or any nasal bleeding or something, that should be corrected. Then avoid stress and strain. If the cause is any chronic disease, it should be treated. Treat पिका, treat पिका, कैसे ट्रीट करेंगे पिका? D1 करेंगे, yes, one step. What is the next step? काउंसलिंग करेंगे, yes. Next, you need supplementation, more calcium. See, more calcium supplementation will only can avoid पिका, समझ रहे हैं? कैल्शियम सप्लीमेंटेशन प्रॉपरली देना बहुत जरूरी है इफ इट इज अ केस ऑफ पिका। देन आयरन रिच फूड, रेड मीट, फ्रूट्स लाइक अनार, आमला एंड विल बी एडवाइज्ड। देन आयरन प्रिपरेशंस हमारे पास कुछ तो खूबसूरत हर्बल है, शरबत फौलाद है, शरबत अनार वगैरह है, हाँ, दिस विल हैव वेरी गुड इफेक्ट। देखिए अब हमारे पास एक बात हो रही थी कि कुछ तो फौलाद वगैरह नहीं देना चाहिए प्रेगनेंसी में, बट व्हाट आवर एक्सपीरियंस टेल्स कि हम लोग कई वर्षों से देते आ रहे हैं, कोई भी पेशेंट में ऐसे कोई अबनॉर्मलिटी या कुछ अबनॉर्मल या इस तरह का एडवर्स इफेक्ट वी हैव नॉट सीन, समझ रहे हैं? हम लोगों के पास यूज करने के बावजूद, बिकॉज दैट इज द एक्सपीरियंस व्हाट आई एम शेयरिंग। बट यूजुअली दे टेल के कुछ तेजाब नहीं लेना चाहिए। तो ऐसा कोई एडवर्स इफेक्ट और एडवर्स थिंग हमने नहीं देखा आज तक, मतलब वर्षों की प्रैक्टिस की एक्सपीरियंस बता रहे हैं, ऐसा कुछ नहीं देखा है। चलिए अब यहाँ पे इलाज बिल्कुजा में तो लतीफ़ मुखवी अदविया देना, ग़िज़ा देना ज़रूरी है। देन मसूर की दाल वगैरह का वो है, बिकॉज इट कॉज ब्रोथ, इजीली डाइजेस्टेबल फूड देना है। लीफी वेजिटेबल्स, मिल्क, वेजिटेबल्स, राइस, मतलब पोमोग्रेनेट, ग्रेप्स, मतलब ये फूड में हम लोगों को ये एडवाइस करना है कि तुम्हारे डाइट पे ये सब आ जाए, समझ में। देन it will become easy for us to manage. Avoid excessive tea, coffee and spicy food. Then food should be cooked well and taken at a particular time. Iron stifled water should be taken along with अर्फ़े बादियान और अर्फ़े मगो। सो उनको बोलना है सबसे पहले जैसे प्रेग्नेंट हुआ आयरन तांबे का घड़ा ले लो, उसमें पानी पियो। अब तो अच्छे खासे फिल्टर्स वगैरह भी मिल रहे हैं, तांबे के ग्लासेस मिल रहे हैं। सो रात में भर के रखना। देखो इवन आई थिंक चंद वर्षों से भी वी हैव स्टॉप, अदरवाइज टिल दैट हमारे अम्मा तो एक पानी का घड़ा दिए हुए थे तांबे का कि इसमें पानी पियो, बट आखिर में मजबूर है कि तांबे का घड़ा निकाल दिए क्योंकि फिल्टर आ गया, वो आ गया सब फना। चले अब तदबीर में तो मॉडरेट एक्सरसाइज इज एडवाइजेबल, इजंट इट? बिकॉज देखो पेशेंट को रेस्ट डोंट टेल, rest is not always advocated, because if everything is right, she is not with some complications where she needs rest, otherwise we should advise moderate exercise. Then इलाज दवा में देखिए माउल लहम का है, मिर्च चिकन वगैरह खिलाने का है, पीपर का वो है, गौ जुबान दालचीनी लो, मतलब इतने अच्छे दवाएं लिखे गए हैं, ये सब अपनी ग़िज़ा में ऐड कराना है, ठीक है। Then this will give strength to pregnant women and provide nourishment of fetus also, it has been mentioned. And यहाँ पे शरबत फौलाद का जिक्र है, खुश्ते खबसे मदीद का जिक्र है, कुश्ते माजून में क्या है, बरंज और खमीरे गो ज़ुबान वगैरह अम्बरी का जिक्र है, मुरक्कबात फौलाद जो भी हैं बता रहे हैं ना, जहाँ पे भी फौलाद के मुरक्कबात हैं वो सब दे सकते हैं, बट वी नीड स्टडीज। यहाँ पे एथिकल इश्यूज की वजह से क्या है, लिमिट, क्योंकि एथिकल इशू देखो हमारे पास इवन इफ यू वांट टू गो फॉर रिसर्च, फर्स्ट ऑफ ऑल प्रेगनेंसी पे रिसर्च के लिए अवॉइड करते हैं, जब अवॉइड करते हैं तो इट विल लिमिट अस, इजंट इट? तो हम हर दवा के ऊपर हम ट्रायल कर ही नहीं सकते, एंड बड़ी मुश्किल से 1-2-3 स्टडीज हुए हैं हमारे पास, बट सो वी आर गोइंग मोर ऑन रिप्रोडक्टिव एज लेके, क्योंकि प्रेगनेंसी में अवॉइड करते हैं तो रिप्रोडक्टिव एज बैठेगी, एंड वी आर सीइंग लॉट ऑफ गुड रिजल्ट्स विथ आवर मेडिकेशंस। और देखिए और एक करेक्शन का नंबर मैं नुस्खा बताऊंगी, एडोलेसेंस एज में अगर मोरिंगा जंगे की भाजी बोलते हैं ना, अगर वो भाजी हफ्ते में एक बार भी, एक मील भी अच्छे से अगर खाना शुरू करेंगे ना, so those children will not develop anemia. बेहतरीन चीज़ है, बिकॉज पर्सनली आई हैव ट्राइड दैट। मेरा कभी 9 ग्राम से ज़्यादा नहीं बढ़ता था, कभी नहीं बढ़ा था। देन व्हेन आई केम टू नो कि दिस विल इम्प्रूव, तो आई स्टार्टेड टेकिंग फ्रीक्वेंटली, लाइक मैं 1 महीने में 2 बार 3 बार, एक बार बना तो 2-4 बार खाना, इट मेड अ लॉट ऑफ डिफरेंस। This is the one, and another more experience I am sharing, जो चिकन की कलीजी है, कलीजी जो पूरा सामान मिलता है ना अलग से, वो तो जस्ट आई कांट से, क्योंकि देखिए कॉस्टली आइटम्स अगर पेशेंट को बताएंगे तो दे विल नॉट टेक आल्सो, इवन वी हैव टू चेक फॉर देयर अफोर्डेबिलिटी आल्सो। सो वो सिर्फ कलीजी का इस्तेमाल, इवन आई ट्राइड दैट, बट बिकॉज आई हैव सीन मेनी केसेस आल्सो, इतना अच्छा इंप्रूवमेंट आया, इट जस्ट कांट टेल यू। हफ्ते में 1-2 बार खिलाओ, 1 महीने के बाद देखो द सीधा चेंज। तुमको इतने अच्छे बादाम खिलाना, अंजीर खिलाना या कोई और कॉस्टली चीज खिलाना, कॉस्टली आई मीन सिरप्स पिलाने की जरूरत भी नहीं है, जस्ट क्योंकि गरीब पेशेंट्स अपने पास बहुत आते हैं,
So we must be helpful to them. ऐसा नहीं है कि तुम बादाम अंजीर खाओ. She can't take, she can't purchase, she can't, उसके बादाम मंजीर में उसके सारे घर की फैमिली का खाना हो जाता है. So it is our duty. So if you are seeing with low socio-economics, daily 100 rupees, 200 rupees if he is earning, how he can support? So ये ऐसे नुस्खे हम पेशेंट्स को मोटिवेट करना है. So that will help, really we are helping at that time. चलो compound formulations, as you know, these are the available formulations is there. So just we'll have little research discussion. से हमारे पास 2007 में एक स्टडी हुई थी एनीमिया पे. यहाँ पे सल्फोफोक्सिल हदीद लिया गया था क्योंकि उस वक्त में अंजीर लेके स्टडी करना चाह रहे थे, बट हमारे डायरेक्टर ने अलो नहीं किया था उसमें. तुम अंजीर लेके खा जाओगे, पेशेंट को नहीं खिलाओगे. सो दैट्स व्हाई वी कुडंट कंडक्ट दैट रिसर्च एट दैट टाइम. ओके, हालांकि कोई खाने वाला नहीं था, बट रहता ना प्रिडिक्शंस. सो इसलिए एट दैट टाइम वी चेंज टू दिस सल्फोफोक्सिल हदीद. 3 capsules of 1 gram they have given thrice a day for 45 days. It has got very significant effect without any side effects. There was a improvement in hemoglobin percentage with 8.8 to 10. Like we found very good response with this, and even we found other response in this thing. Then recently हमने नहीं छोड़ा, फिर से लिया फिर से ही कंडक्टेड वन स्टडी. वी टोल्ड नहीं आप मतलब उसमें ले, मैं बोली इट इज अ डाइटरी सप्लीमेंटेशन, तो दे एक्सेप्टेड. सो दे हैव कंडक्टेड वन स्टडी. इट वाज अ वेरी गुड स्टडी. वी हैड वेरी गुड रिस्पॉन्स विद दिस. सो हियर सी हियर 50 grams. देखिए ये इजी नुस्खा है. You can this to your patients. 50 grams daily in 2 divided doses. 50 ग्राम अंजीर, 25 ग्राम शाम में 25 ग्राम. For 8 consecutive weeks we have used because there is limitation for the research period. हम चाहे तो और भी बढ़ा सकते हैं. There is no loss or there is no side effects as such. So 8 weeks की therapy में we had lot of response and we found a lot of response with that. But what we found कि it needs further, I mean continuation. क्योंकि हम 2 महीने देके हम ऑब्जर्व करें, सिर्फ 2 महीने नहीं चलेगा ना प्रेगनेंसी में. So we can advise. तो पेशेंट को हम हर दिन 2 अंजीर खाने की अगर कह रहे हैं, 5 बादाम या 8 बादाम खाने के लिए कह रहे हैं, तो वी आर गिविंग वेरी गुड सप्लीमेंटेशन देन. सो देयर वाज वेरी गुड इम्प्रूवमेंट दे हैव अचीव्ड हियर इन दिस स्टडी. एंड अदर वन मोर प्रोजेक्ट डॉक्टर कौशल वाज डूइंग विद दिस. शी हैज यूज्ड नाजिना खप्सुल हदीद 5 grams daily in reproductive age group, and even they are finding very good results. I think she might be completing that study now. And the control group they have kept, and they have given FIFAL in that group. And sometimes what we'll do, a group will keep our drug and the other group standard drug with the same drug. So easily we can make out how much improving our drug along with FIFAL or the response with the single Unani drug. And this is the global prevalence of anemia in pregnant women, comprehensive systematic review and meta-analysis. So according to the results of the meta-analysis, the overall prevalence of anemia in pregnant women is 36.8% with a 95% confidence interval. The highest prevalence of anemia is mild at 70.8 and highest in the third trimester of pregnancy with the prevalence of 48.8. while the highest prevalence of anemia in pregnant women was in Africa with the prevalence of 41.7. This is the global prevalence rate. That's what I am discussing here. The result of this study shows high prevalence of anemia among pregnant women worldwide.
worldwide, and the highest of this prevalence is mild anemia. समझ रहे? If you are able to find in the mild level, in the sense in the early stage, so the prevalence rate is good. The prevalence of anemia in the third trimester was lower in the first and second trimester. Anemia in pregnant women in developing countries is significantly lower than in developed countries due to pregnancy, economic, sociological and health factors. So as it is and this is again a systemic literature review of the relation between iron status with anemia in pregnancy and offspring neurodevelopment. So here RCTs and prenatal iron exposure and later neurodevelopment shows that there is some evidence that low pregnancy iron, particularly in the third trimester, may adversely influence offspring neurodevelopment. In the sense, we should be very much vigilant. If we are neglecting there, so we are spoiling the offspring also, isn't it? Results were few and heterogeneous regarding association between the age of early childhood, and there is a need for more studies that performs multiple iron status measurement during all stages of pregnancy, use different indicators of iron status and look at different neurodevelopmental outcomes separately from one another. Follow offspring into adolescence and adulthood ages to confirm potential changes in the association over time and especially with the offspring academic achievements. Because see, we have got very much limitation. जैसे डिलीवरी होगी तो हम समझते हैं कि we have finished our job, है ना? For example, पेशेंट की मतलब she was anemic, she was delivered, and what she is doing, what is the effect on the child? We are not following it, isn't it? Postnatal follow-ups ही नहीं हो रहे हैं. पेशेंट की ऐसी है, एक बार डिलीवरी हो गई तो खत्म. अब बहुत कम पेशेंट्स होते हैं जो 3 महीने तक जो फॉलो करते हैं, टैबलेट्स वगैरह खाते हैं, अदरवाइज इवन दे विल स्टॉप दैट आल्सो. सो अब बच्चे में क्या इफेक्ट हो रहा है, क्या हो रहा है? इट नीड्स लॉट ऑफ एफर्ट्स एंड स्टडीज टू कम टू नो कि हाउ इट इज अफेक्टिंग. Then investigate association of iron overload in pregnancy and offspring neurodevelopment, and future high quality observational studies are important. So it has been concluded that there is some evidence that low pregnancy iron, possibly particularly in the third trimester, may be associated with adverse offspring neurodevelopment. So third trimester anemias should be considered very strictly. Then at most previous research used hemoglobin inferring results to iron deficiency should be done with caution. No conclusions could be reached regarding association between early childhood and supplementation with iron during pregnancy did not seem to influence the offsprings. So here, this study, anemia in pregnancy, is still a public health problem, a single-centered study with review of literature. So this study highlights high prevalence of anemia in females at the time of diagnosis of pregnancy during first trimester. There is thus a huge unmet need to make the various government programs reach the end users at the grassroots level. That's why अभी home-to-home delivery जो NGOs work कर रहे हैं, they are working on this to achieve that goal. Then increased active participation and empowerment of ASHA workers, Anganwadi workers, various continuous education programs, along with education of the masses might help in reducing this starting number of this seemingly easily manageable yet challengeable public health problem. Then this will not only affect the present but also the future of not only the region but also the nation. So this is not only a matter of touching one but two lives. So coming to the conclusion points. So iron deficiency remains the most common cause of maternal anemia worldwide, with detrimental consequences for both mother and baby. Large-scale epidemiological studies have demonstrated that antenatal anemia is a risk factor for maternal mortality, perinatal mortality, preterm labor, low birth weight infants, postpartum hemorrhage. Maternal iron deficiency may also be associated with poor infant neurodevelopmental outcome. So this is the conclusive point. So postpartum anemia is linked with lactation failure and low maternal quality of life scores. So here the WHO aims to reduce the prevalence of anemia in women of reproductive age by 50% between 2010 to 2025. I don't know how much we have achieved till now. So over a 5-year period, the primary prevention of maternal anemia to avoid preterm delivery and other adverse outcomes research programs recently funded by the National Institute of Health Research will attempt to address some of the research uncertainties highlighted. So long-term prospective studies are needed to elucidate association between the treatment of iron deficiency with or without anemia and maternal and neonatal outcomes. To summarize this, iron deficiency anemia is a global health problem which particularly affects pregnant women. Iron deficiency anemia during pregnancy is associated with increased maternal and perinatal mortality and morbidity. So maternal iron deficiency may also be associated with neurocognitive deficits in infants. Iron requirement increase during pregnancy and are influenced by the hepcidin, the master regulator of iron hemostasis. So this hepcidin I have actually explained in the slides. The enduring global burden of maternal anemia suggests that currently employed iron supplementation strategies are suboptimal. Recent developments in our understanding of systemic and placental iron hemostasis may improve therapeutic effectiveness by altering the dose and frequency of oral iron. So IV iron appears to be a safe treatment to correct maternal anemia rapidly, but research on patient-centered outcome and cost effectiveness is needed. Further trials should be adequately powered to assess outcome relevant to pregnant women. Thank you. When they need you, you can offer them something better. So I am expecting now you can offer something better. What you are giving, now you can offer something better now. So my message to all of you is of hope, courage and confidence. Let us mobilize in a systemic and organized way and tackle the grave issues of medical science with grim determination and discipline.